Sannabhadanang dhayayet sarva bighnopashanteye. Taking the name of Almighty, we extend our warm welcome in OARC Update 2, looking at rheumatology through the skin. We feel absolutely honored to welcome on stage our distinguished dignitaries, our Honorable Chief Guest, Professor Dr. Nibedita Pani, Director PGIMS and Capital Hospital, esteemed Chairman API and President IRA Odisha State Branch, Dr. Manoj Kishore Chhotray, esteemed President IADVL, Odisha State Branch, Dr. Biswajit Samal, respected Scientific Chair, Professor Dr. Prasant Pradhan, and our Organizing Secretary, Professor Dr. Jyoti Ranjan Parida. Thank you. ओडिया आमे ओडिशा आम माटी आमे ओडिशा पाई गर्वित आसंतु मिसी ओडिया मार जयगान करिबा. May I request everybody to stand up for the state song of Odisha.
उत्कल जननी वंदे उत्कल जननी वंदे उत्कल जननी
चारुहासमयी चारुभासमयी
जननी जननी जननी
पूतपयोधि विधौत शरीरा
ताळतमाळ सुशोभित तीरा
शुभ्रतटिनि कुल शिखर समीरा जननी जननी जननी
घन घन वन भूमि राजित अंगे
नीलभूधर माला साजित रंगे
कळ कळ मुखरित चारु विहंगे जननी जननी जननी
सुंदर साली सुशोभित क्षेत्र
ज्ञान विज्ञान प्रदर्शित नेत्र
जोगी ऋषि गण उठ जप पवित्र जननी जननी जननी
सुंदर मंदिर मंडित देश
चारु कला बलि शोभित वेश
पुण्य तीर्थ चय पूर्ण प्रदेश जननी जननी जननी
उत्कल सुरवर दर्पित गेह
अरिकुल शोणित चर्चित देह
विश्व भूमंडल कृत बर स्नेह जननी जननी जननी
कविकुल मौळि सुनंदन वंद्य
भुवन विघोषित कीर्ति अनिंद्या
धन्ये पुण्ये चिर शरण्ये जननी 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 वंदे उत्कल जननी वंदे उत्कल जननी वंदे उत्कल जननी.
Thank you. May I request our esteemed guests to kindly kindle the flame of enlightenment and officially inaugurate our event. As the lamp is lit, may its radiance touch each one of you, kindling in you the immortal flame of knowledge and understanding. Shubham karoti kalyanam, arogyam dhana sampada, shatruti vinashaya, deepam jyoti namostute.
आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपज्योतिर्परब्रह्म दीपज्योतिर्जनार्दनः दीपो
May I now request Professor Dr. Jyoti Ranjan Parida to felicitate our esteemed guests. Please give a hand. May I now request our organizing secretary, Professor Dr. Jyoti Ranjan Parida, to deliver his welcome address to the August gathering.
Good morning to all. So, on behalf of the family of ORFT, I welcome you all because on a busy Sunday, I think everybody has committed one day. So that is a matter of pride for us. So people from various parts of the country, our esteemed faculties, we welcome all. Autoimmune diseases once thought to be the diseases of the Western countries, and Indian subcontinent used to have only the infectious disease burdens, and our academic brilliance was used to be determined by cholera, malaria, and diarrhea. But today we realize that actually we are not diagnosing the autoimmune disease in our country. That's why we are not seeing them so frequently. So with advancement of medicine and science, I think today we are seeing them more and more. But still, whatever we are seeing in our clinics is only the tip of the iceberg. I think there are many patients still struggling to have a early diagnosis and have a proper treatment in proper time, therefore landing in various morbidities and mortalities. And one of the key factors that we recognize that lack of awareness, both among patients and physicians, are responsible for this. So Odisha Arthritis Rheumatology Foundation Trust was found 2 years back to spread the awareness of autoimmune disease and rheumatic disease in the different parts of the state, not only to the patients, also to the physicians. Because all throughout the year we are engaged in so many conferences. So when we thought of coming out with an academic meeting, last year we thought of doing an interface meeting, because that's where we felt that it is not only rheumatology has to be trained or physician has to be trained, because these patients, they are multi-systemic, they are suffering from multiple systems. They can present to any healthcare provider. So regardless of the department, everybody should know the basic ABCD of rheumatology and autoimmune diseases, so that these patients can get their due and can come at an earlier stage for proper treatment and their life can be changed. So last year we have done a interface meeting with ophthalmology department. I think around 200 delegates were there, and this was a very, very successful meeting. We have discussed all around EVR, retina, cornea, everything regarding autoimmune disease, eye involvement in autoimmune disease. And this time we have the theme of looking at rheumatology through the skin. I must thank President IADBL, because whenever we have brought this concept, without the skin department involvement, this would not have been possible. And they are very warm and they are very, they have encouraged us to go ahead with this. And today this meeting would not have possible without the involvement of the IADBL Society of the state branch. We are very thankful to API Odisha state branch, because they have collaborated with us. They have extended all their supports. And uh, also the Indian Rheumatology Association, because they have also collaborated and they have given us that encouragement to go ahead with this meeting. So without much delay, I think we should start the meeting. Once again, I thank all our dignitaries, faculties who are busy, very busy in their schedule, but uh, committed to this conference. And I hope we all are going to listen to them and having one good academic meeting today. Thank you all.
Thank you, sir. We feel privileged to have our guest of honor, Chairman API, Odisha State Branch, and President IRA, Odisha State Branch, Dr. Manoj Kishore Chotrai, to share his thoughts with us. Please, sir.
Good morning. Indian Rheumatology Association with API, with skin. This time we have brought a CME on rheumatology through skin. A few days back we had rheumatology through eye. So in different aspects of rheumatology, we are bringing out CME. It is only for the postgraduates and the budding physicians who are on the recent treatment on in different subjects. Only thing is that autoimmunity has played a great role. When we were students, we had nothing, we had no knowledge about autoimmunity. Gradually it has come and it has now spread to almost all subjects. When we are not getting any result when treating a fever, common fever, and not getting cured with almost all antibiotics, then we are thinking of autoimmunity and we go for all the investigations in autoimmune diseases. So autoimmunity has played a great role, and with the passage of time, it has occupied a center stage in almost all diseases. So I think this type, Dr. Pradhan and Dr. Ye has brought out this skin, new concept of autoimmunity through rheumatology through skin. I hope all will be benefited with this CME, and I wish all this year's CME success. Thank you.
We also feel overwhelmed to have among us our guest of honor, President IADVL, Odisha State Branch, Dr. Biswajit Samal, to share a few words with us. Please.
Jai Jagannath. Namaskar, very good morning. Respected Chief Guest, Madam Dr. Nivedita Pani Madam, our Organizing Chairperson Dr. P.K. Pradhan, and Organizing Secretary Dr. Jyoti Perida, and API President Dr. Manoj Kishore Chotrai, and speakers, delegates, I welcome you all to this OARC update, Rheumatology and Dermatology Conference. On behalf of IDWL, I welcome you all to this meeting. I first of all congratulate the Odisha Arthritis and Rheumatology Foundation Trust for organizing such a national conference at Bhubaneswar with international speakers and national speakers to highlight their shares and experience with us, to gain some knowledge so that it will benefit to our patients. So I wish all the success for this conference and CME, and thank you.
Thank you so much, sir. Now comes the most awaited moment of the release of the souvenir. For this, may I request our honorable dignitaries to kindly unveil the hard work being put by each member of OARC. Thank you so much. May I now request our Honorable Chief Guest, Professor Dr. Nivedita Pani, Director PGIMS and Capital Hospital, to kindly share a few words with us.
Namaskar, respected dignitaries on the dais and off the dais, and all my senior sirs and madam. First of all, on this August gathering, I am giving my pranam to everybody. It's a wonderful experience to be a chief guest to such a wonderful seminar or conference that is a OARC update 2. And update 1, I think the ophthalmology, and this time is the skin. So I was just talking to Bharat sir and Vijay sir and also to Jyoti, why don't you start with another update with also the critical care department. So it will be wonderful, so you can know what are the things are coming and what are the complications we are facing as also intensivist. I still remember when we are as a student, when we used to think of rheumatology, that time in rheumatology was very tough for us. Used to feel, nothing will happen, the life has gone, the joints has gone, this thing. But with the development of the medicine and with the untiring effort of all the scientists and the doctors, people are doing an excellent work also. They are normalizing their also activities also. Still we are not that much of scared, because so many drugs have come out, and with that also, as you know that all autoimmune disorders, they can have this lot of problems starting from different organs of the body problems. So this enlightenment with the skin is one of the interesting topic, and with a joint problems with the skin problem, it is really an enlightening subject, and it will definitely, whoever all the delegates have come, they will have a very good knowledge while going back home. And all this, while entering this room, I was going through the topics, and I must congratulate the scientific chairperson who has selected the topic so well, and it is from the day-to-day activities, it is so helpful, starting from psoriasis, whatever it may be, it is very, all the topics are excellent topics. And I wish all the delegates, while going back, they will have a very good memory, starting from the education and also the entertainment and everything. Thank you very much. Thank you, sir. Thank you, the organizing committee, for inviting me as a chief guest. Thank you very much.
Thank you so much, ma'am. May I now request our organizing secretary, and our scientific chair, Professor Dr. Prasant Pradhan, to deliver the vote of thanks.
Respected dignitaries on the dais, of the dais, esteemed delegates, and my friends, good morning to all of you. It has been a quite privilege to be a part of this scientific committee, and when Dr. Jyoti called me saying that we are going to have the OARC update too, and then he told that what have you kept as a theme, then he told that it's dermatology and rheumatology interface. I think it was quite appropriate, and all of us by this time know that with dermatology and rheumatology cannot be separated. In fact, no two specialties of medicine can be separated. And one of the rheumatologists who is most successful probably will realize that it is through dermatology you diagnose many things. And it is important that you are well versed with what is happening of these diseases through the skin. And understanding these diseases needs a lot of expertise. We need the help from our dermatology colleagues, and hence we have chosen these topics in an appropriate way so that it will benefit both the specialties in an equal manner. And of course, there are differences in the approach in diagnosis, treatment, and many other things through the dermatology and rheumatology. But when they work together, probably this becomes, the patients get the best out of it. So without wasting much time, I would again welcome all of you to just enjoy the academic session which are coming shortly. Thank you.
So now we'll be beginning with the session in few moments. Thank you. Thank you for your patience. May I now request our coming speaker, Dr. Durga Prasanna Mishra, who will be presenting on immunology for dermatologists from bench to bedside. It will be chaired by Professor Dr. Sameer Sahu, Dr. Sisir Kumar Mohapatra, and Dr. Anupam De. Please, sir, kindly grace the dais. May I request our speaker to kindly take the dais.
So, good morning, friends. You must be very enthusiastic and energetic to listen to the different talks. Now, I welcome you all to this first session of OARC Foundation Trust. The chairman of scientific committee, as you have already seen him, is a perfect and updated academician. Very nicely he has organized and arranged this scientific program. Now the ability and dexterity of Dr. Jyotiranjan Parida, you know he was ex-professor, he is the consultant and director of Odisha Association Arthritis and Rheumatology Center. Very nicely he has organized such a national conference. See, a few decades ago, we had our Professor Vidyut Kumar Das. When we were beginners, we do not know about this rheumatology. He used to have seminars among the physicians that disorders of musculoskeletal disorder that he used to be teach and discuss. Subsequently, our Bharat Babu came with rheumatology for physicians. And gradually it has expanded and the spectrum has increased, that rheumatology for ophthalmologists and today rheumatology for dermatologists. So this one you will see this topic. This is immunology for dermatology from bench to bedside. Just we were discussing what is this bench to bedside. Now the internet speaks, bench means laboratory, to bedside means to patients. But some physicians differ. They say no, it is from classroom to the bedside, that is to the patients. You know, there are divisions of medicine, there are different systems, according to systems medicine divided. And these systems, they interact, they produce overlapping of symptoms. And there is expression of different pathological and clinical expressions. So also, in connected to this disorder, you find many interactions. As a result, you have to look rheumatology through eye, not stomach through endoscopy. Not endoscopy to look at the larynx, but through your eye you have to look at the rheumatology. Because if you find a patch, you have to think of could it be SLE. If there is joint pain, you have to think whether it could be psoriatic arthritis. So on and so forth. I think in subsequent years, as our chief guests are telling, why don't you put immunology and in critical care? So I must also ask, why don't you put immunology for cardiologists, immunology for nephrologists? So this is a very expanding branch. Few weeks ago also we had inborn error of immunity for pediatricians. So very extending. But for me as a physician, I tell you, once William Baird said, ignorance exceeds our knowledge. I am an ignorant physician. I am very happy to attend, to join and learn. And Professor Honda is there with us. When he was chairman ICP, sir, I got this fellowship from your hands only. You are very happy and we are very grateful for attending. And I welcome all the national faculties. Please do come. This is a very, very divine and holy place. Anything you look at, that is divine. Here at Bhubaneswar and Puri, the earth is divine, the air is divine, the water is divine, the persons are divine, everything is divine. And when you go back, you will be also a very divine person. With this, I think he is our professor, my co-chairman, is a great man. Professor of medicine, IMS, some medical college. Because I am senior, probably asked me to just to start this speaking, but he will be also speaking few words on the topic. And also I will request he will introduce our Durga Prasanna Mishra, Associate Professor, Department of Clinical Immunology and Rheumatology. So thank you, he will introduce you.
So thank you, sir. So basically, I believe that knowledge without translation into clinical medicine is not very useful. So speaking on that, our first speaker will be Dr. Durga Prasanna Mishra. He is Associate Professor, Department of Clinical Immunology and Rheumatology, SGPGI. And he has a number of publications to his credit. His interest varies from Takayasu arthritis, cardiovascular risk in rheumatoid disease, and all those things. And I'll welcome him. Your dais is yours.
Thank you, sir, for the kind introduction. At the outset, I would like to thank Jyoti Bhai, Prasant Bhai, and the organizing committee for inviting me to deliver this lecture. Being a proud ODI, it's a great moment of pride for me that I am giving this lecture in my own home state. So, I do not have any disclosures, and the brief of my talk shall be to introduce you to various immune processes that are ongoing in a normal human body and how these may be dysregulated and what are the various therapeutic targets through which we can bring back this dysregulation to the homeostatic state. So briefly we shall talk about the innate and adaptive immune system and various aspects of the innate immune system and of the adaptive immune system which can be targeted. And nowadays there are multi-target therapies such as Janus kinase inhibitors, which Handa sir shall be speaking on in much greater detail, but I shall just give a brief introduction before I conclude. So what are this innate and adaptive immune system? Whenever we hear about this immune system, we get a little hung up. We think, what is going on here? It's very simple actually. Whenever the body encounters a foreign substance or what we call as an antigen, it initially mounts a response, a predominant innate immune response, which is early, but later on an adaptive immune response specific to that particular antigen is mounted by the body. And when there is a repeat exposure to the same antigen, the adaptive immune response is now dominant because it has something called as memory. That is, it can recollect a previous exposure to this particular antigen and can mount a more robust response to the same antigen. Now, innate immunity is mainly driven by cells such as macrophages, neutrophils, whereas adaptive immunity, broadly speaking, is driven by the lymphocytes, the T lymphocytes and the B lymphocytes. So, to start with innate immunity, first we need to understand what are these toll-like receptors. There are various toll-like receptors which are also called as pattern recognition receptors, and these recognize basically DNA or RNA inside the endosome, and once there is signaling by activation of the toll-like receptors in the endosome, there occurs downstream signaling which eventually leads on to inflammatory pathways including nuclear factor kappa B activation and other pathways. Why is it important to understand about toll-like receptors? Because our drug hydroxychloroquine, which is a mainstay drug in patients with rheumatoid arthritis and lupus and various other diseases, this acts by inhibiting the endosomal TLR, the toll-like receptor interaction with the DNA, RNA, or with the antigens that the body is responding against its own antigens. So hydroxychloroquine acts by down regulating the processes driven by toll-like receptors. Next, coming to interleukin 1. Before we go to interleukin 1, we need to understand these macrophages, which we must have heard of. These are cells which serve as gatekeepers and protect us against various infections. And they predominantly secrete these important cytokines of TNF, interleukin 1, interleukin 6. So we shall see all these, what are these different cytokines and how they can be targeted. So there is something called as an inflammasome, which leads on to secretion of interleukin 1, specifically interleukin 1 beta. The sources of interleukin 1 beta are macrophages, endothelial cells, and some epithelial cells, and its principal targets are again the endothelial cells. It causes systemic symptoms such as fever and causes synthesis of acute phase proteins from the liver. And colchicine is a drug that we commonly use which inhibits inflammasome activation. So that's why this colchicine is useful in diseases such as gout, where inflammasome activation plays a very important role. This IL-1 family has a number of cytokines actually. There is not only the IL-1 and IL-1 receptor antagonist, there is also the IL-18 and the IL-36. And previously, in fact, for a couple of decades at least, we have been targeting IL-1 directly through drugs like anakinra or canakinumab or rilonacept. But now recently, other IL-1 family targets are also being described. This recent paper described imsolidimab, which is a monoclonal antibody against the IL-36 receptor, and it was found to be useful in the treatment of generalized pustular psoriasis in a phase 2 study. Next, coming to tumor necrosis factor alpha. This is something that we have all heard about, tumor necrosis factor alpha inhibitors. So the major sources of TNF are again the macrophages and also the T cells. Its principal targets are the endothelial cells, neutrophils. It leads on to increased catabolism, thereby leading on to cachexia, and also leads on to apoptosis in various cell types. Now, we know that various drugs are available to target TNF alpha, which are infliximab, etanercept, adalimumab, golimumab, and certolizumab pegol. Actually, understanding how this TNF alpha came into being as a target, as a biologic target, is very important to understand how therapies develop and what are the pitfalls. The original use of anti-TNF agents was actually attempted in patients with heart failure. The reason being that it was found that patients with severe heart failure have higher levels of tumor necrosis factor alpha. And the more severe the heart failure, the higher are the levels of the TNF alpha. So people thought that it must be that, if you block TNF, you can improve heart failure. But when this trial was conducted about 2.5 decades back, what they found was that those patients who received the TNF inhibitor infliximab at a dose of 10 milligram per kg actually had almost a 2 times higher risk of death than those receiving placebo. How is this possible? It is because probably this elevated TNF levels in patients with heart failure was a counter-regulatory protective mechanism. This again leads on to the concept, the basic epidemiological concept of association versus causation. Higher TNF levels were associated with heart failure, but they were not the cause of severe heart failure. So, following this failure in heart failure of infliximab, subsequently it was found that this drug is useful in rheumatoid arthritis, and the rest is history. Now, TNF inhibitors are readily available, easily accessible with the availability of biosimilars, and are used widely in autoimmune diseases, particularly in rheumatoid arthritis, psoriatic arthritis, spondyloarthritis. So there are certain settings where TNF inhibitors are not useful, for example in lupus, because they can cause drug-induced lupus, or in patients with interstitial lung disease, but they're definitely useful in rheumatoid, in spondyloarthropathy, particularly in psoriatic arthritis. Next, coming to interleukin 6. Interleukin 6 is another target which has got the attention of many people, particularly since the time of the COVID-19 pandemic, when tocilizumab was one of the drugs that had some potential benefits in severe COVID. So what is this interleukin 6? It is again secreted by macrophages, endothelial cells, T cells, and it has principal targets on the liver, on B cells. It helps to proliferate antibody producing B cells, and also has a role in T helper 17 differentiation, which we shall see in a little greater detail subsequently. So what is interesting to understand about this interleukin 6 is that this interleukin 6, for its signaling, has to bind to an interleukin 6 receptor and then to another molecule called as GP130. Now this interleukin 6 receptor may be present on the surface of cells, or there is also a circulating interleukin 6 receptor. Therefore, the interleukin 6 can bind to a surface bound interleukin 6 receptor and then to GP130 on the cell surface, or the interleukin 6 and interleukin 6 receptor complex can bind to GP130, which is present on practically every cell of the body. So this is something called as trans signaling. Therefore, interleukin 6 has pleiotropic effects on practically every cell of the body. And downstream, it leads on to activation of JAK-STAT pathways. As we shall see at the end of this presentation, Janus kinase inhibitors are coming in a big way as orally available molecules which have important immunosuppressive or immunomodulatory properties. So targeting of interleukin 6 receptor can be through tocilizumab and various other drugs like sarilumab, or direct IL-6 inhibitors like sirukumab, olokizumab, clazakizumab. So these are drugs that are used again in rheumatoid arthritis, and when these drugs are used, what is important to understand is that because of the direct action of interleukin 6, there is a reduction in C-reactive protein production from the liver. And also because interleukin 6 affects the production of fibrinogen from the liver, which is an indicator of the erythrocyte sedimentation rate. As such, ESR and CRP become unreliable markers once a patient is on an interleukin 6 signaling inhibitor. Therefore, you cannot rely on ESR and CRP, and even if these patients have frank sepsis, you will have absolutely undetectable CRP because that's due to the effect of the drug per se. That's why CRP is no more a reliable marker in a patient who's receiving a interleukin 6 blocking therapy. Briefly about type 1 interferons, which are actually important for antiviral responses, and these are again secreted by macrophages, plasmacytodendritic cells, and fibroblasts. And type 1 interferon targeted therapies have predominantly been tried in lupus, although they have not been very successful, and also in dermatomyositis. Now coming to the adaptive arm of the immune system. So what happens is when the body is exposed to a particular antigen, it processes that antigen and presents it to the lymphocytes, which now have the ability to specifically respond to that particular antigen. That's what is called as an adaptive immunity in very simple terms. The T lymphocyte subsets are very important to understand adaptive immunity. For each T lymphocyte subset, there is a polarizing cytokine, there is an effector cytokine, and there are specific transcription factors which drive the generation of these T lymphocyte subsets. The common T lymphocyte helper subsets are the Th1, which is driven by interleukin 12 and IFN gamma, and secretes IFN gamma, and the transcription factor of importance is Tbet. Then you have the T helper 2, which is important against parasitic infections. That is driven by IL-4 and IL-5 and secretes IL-5. And the transcription factor of importance is GATA3. The T helper 17, which we shall look at in a little bit more detail, its transcription factor is something called as ROR gamma T. It is driven by interleukin 6 and TGF beta. When there is TGF beta alone, this transforming growth factor beta alone, then it drives T regulatory cells. But when there is interleukin 6 and TGF beta, it drives the generation of T helper 17 lymphocytes, which in turn secrete interleukin 17. Now, IL-23 is another target for T helper 17 lymphocytes, but it does not play a role in differentiation. It helps to maintain the differentiated population of T helper 17 lymphocytes. So why is it important to understand this dichotomy between T helper 17 and T regulatory cells? For example, if we have, let's say, a disease process like rheumatoid arthritis that is refractory to conventional therapies, by logic, if we can take the patient's T lymphocytes, if we can make them into T regulatory lymphocytes and inject them into the inflamed joint, they might be able to exert a suppressive effect. But thereby lies the issue. What drives the T regulatory lymphocytes is TGF beta. What drives the T helper 17 differentiation is interleukin 6 plus TGF beta. And in the inflamed joint, the refractory joint, there is a lot of interleukin 6. So even if you inject these T regulatory cells, this suppressive T helper cell population into the joint, there it will convert into a T helper 17 inflammatory phenotype, and therefore these strategies of ex vivo differentiation and injection of T regulatory lymphocytes to sites of inflammation have not been very successful. For T lymphocyte stimulation, apart from the T cell receptor and MHC interaction between the T cell and the antigen presenting cell, there is also a requirement for a co-stimulatory signal, which is given by molecules such as CD80-86 interacting with the CD28 molecule. So you have drugs like abatacept, which is a CTLA4 immunoglobulin, which actually blocks this co-stimulatory signal and therefore prevents aberrant T helper lymphocyte activation. A little bit in more detail about the TH17 IL-17 pathway. As we have seen, the T helper 17 differentiation is driven by IL-6 and TGF beta. These secrete interleukin 17, which is also secreted by gamma delta T lymphocytes and other populations. And the IL-23 helps to maintain the differentiated T helper 17 population. So from this, it's important to understand the IL-23 receptor as well, which has a P19 subunit and a P40 subunit. And this P19 subunit is in common with the IL-12 receptor, which drives the differentiation of T helper 1 lymphocytes. So that's why this P40 subunit is the one that is targeted by ustekinumab. IL-23 targets are guselkumab, tildrakizumab, risankumab. IL-17A monoclonal antibodies are secukinumab and ixekizumab. IL-17A and F dual monoclonal antibodies, bimekizumab, and IL-17 receptor antagonist is brodalumab. So these T helper 17 interleukin 17 pathway has been implicated in various diseases, and therefore these targets have been also explored in various diseases. While they were found to have a role in the pathogenesis of rheumatoid, they were not found very effective in rheumatoid arthritis, but they are useful in patients with spondyloarthropathy, with psoriatic arthritis. And again, as we go deeper into the molecular pathology, we understand certain specific differences, why certain drugs may act at certain sites but not at other sites. For example, in psoriasis with psoriatic arthritis, at the skin, the interleukin 23 inhibitors are useful because they rely on the direct effect of interleukin 23 on driving the T helper 17 lymphocytes, but they are not useful at the enthesis because there the effect is not dependent on interleukin 23, rather it is dependent on the direct interaction of the mesenchymal cell with the T helper 17 lymphocytes. B lymphocytes are important targets, particularly in diseases where autoantibodies play a major role, like in lupus, in systemic sclerosis, and the commonest B lymphocyte targeted therapies are rituximab, which is an anti-CD20 antibody, and now people are also trying to target CD19, that is inebilizumab is being tried in systemic sclerosis, lupus, and other diseases. And you also have these B cell activating factor BAF and APRIL, which are being targeted by multiple drugs. And once the B lymphocyte becomes a plasma cell, none of these drugs will work on it. So there you have to use something which directly inhibits the proteasome activation in the plasma cells, such as bortezomib. Coming finally to Janus kinase inhibitors, this JAK-STAT pathway is important. That is, whenever there is a signaling through a growth factor or a cytokine, there are these Janus kinases or JAKs and STATs, which mediate the downstream effects. And there are various Janus kinases like JAK1 to 3, TIK2, which, as you can see, affect a plethora of various cytokine mediated pathways. So that is where the JAK kinases are important, because they act on downstream to various different cytokines. As you can see, for interleukin 6, interferon alpha, interleukin 2, 4, 15, interferon gamma, GM-CSF, all of them are driven by different combinations of JAKs and STATs. And there are selective and non-selective JAK inhibitors. Tofacitinib is the most commonly used JAK inhibitor, which inhibits JAK1 and 3 predominantly, but also JAK2. Ruxolitinib is used in hematological malignancies, predominantly inhibits JAK1 and 2. Baricitinib again JAK1 and 2. And now various selective JAK inhibitors are also being tried. Selective means they're relatively selective, like upadacitinib, which inhibits JAK1. And now deucravacitinib, a TIK2 inhibitor, is also coming into play in psoriatic arthritis. Recent literature has highlighted increased cardiovascular risk with Janus kinase inhibitors. And this is predominantly with tofacitinib, may not be for as much with baricitinib or upadacitinib, and it is believed that the TIK2 inhibitors will not adversely affect cardiovascular risk. So again, various diseases where Janus kinase inhibitors are being tried right now, including in rheumatoid spondyloarthropathy, psoriatic arthritis. Just to introduce a concept that people are also trying bispecific antibodies, like antibodies which target both IL-17 and TNF-alpha. None of them have come into the market, but they might come into play in a few years. To conclude, various therapies are useful in different diseases, like for example, lupus is predominantly B lymphocyte mediated, so B lymphocyte therapies, targeted therapies are more useful. Whereas in systemic sclerosis, you have various processes of fibrosis, inflammation, and autoimmunity. So again, T and B lymphocyte targeted therapies are found to be useful, and some direct targeting of fibrosis has also been tried, but not very successfully till now. In psoriatic arthritis, a variety of drugs like TNF inhibitors, Janus kinase inhibitors, interleukin 17 targeted therapies, interleukin 23 targeted therapies are being used. And I think we shall hear about all of this in more detail in the subsequent lectures. So to conclude, that the adaptive and innate immune system activation is possible to be targeted by multiple parenterally administered biologics as well as orally administered small molecules, and different lymphocyte populations play different roles in different diseases. For example, B lymphocytes are more important in lupus and systemic sclerosis, whereas T lymphocytes and innate immunity are more important in diseases like psoriatic arthritis. Thank you. Questions are most welcome.
Thank you, Dr. Misra. A very lucid presentation about targeted therapy and the drugs that are available and those that are in pipeline, and how to anticipate their effects and interpret their actions. You have presented it very nicely. Thank you. And if there are any questions, it's welcome.
Thank you, Dr. Durga Person. Very nicely, thoroughly you have explained everything. But at the beginning, just I had a doubt. Hope you will clarify this first point from bench to bedside. So we have to take these laboratory parameters and put it, interpret, and to come to a diagnosis. Is that the meaning, or is there anything else?
I have tried to provide an overview of what are the various pathological processes in the body, and as of today, how we can possibly target those pathologies. So that was my interpretation of bench to bedside.
So anybody?
Yeah, congratulations Durga for making that complex subject into such a simplified manner. And I think he has covered most of the advanced treatment and the treatment that are already in use. So if I have missed, can you tell why IL-17 inhibitors are not that effective in rheumatoid arthritis? Because IL-17 is a very important cytokine to target. I think that is a question in everybody's mind.
Thank you, Dr. Jyoti. This is a very interesting question. Maybe related to the tissue tropism of different cytokines in different tissues and the disease processes which drive different disease pathologies. I'm not exactly sure why IL-17 targeted therapies were not very successful in rheumatoid, but it is likely that they were due to the differential effects of IL-17 in rheumatoid as opposed to diseases like spondyloarthropathy.
So thank you very much, Dr. Mishra. Now we bind up this.
Actually, I am from medicine background, so this is out of course you can think. So all autoimmune diseases, you know, there is no treatment actually. You have to maintain the treatment immunomodulator for lifelong. Okay. So you know every disease having some genetic predisposition along with some environmental factors contributing. So why you should not target the genetics?
Make your mic closer to the mouth, yes.
So is there any cure for this? Be gene therapy or some target to gene? Why you should not think any advance to that?
Thank you, Sujata Didi, for this nice question. Actually, what happens is from gene to translation to the level of proteins, a whole many processes are happening. And what happens is the simple presence of a gene does not often translate into a disease because there are epigenetic factors which regulate this, which regulate the expression of genes. So that is the reason in these polygenic diseases which have the interaction of multiple genetic risk factors which drive the disease, it may not be possible to target the specific gene for a therapy. But in specific diseases like, for example, deficiency of adenosine deaminase 2, which causes a phenotype of early onset polyarthritis nodosa, it may be possible that targeting the gene would possibly reduce the disease pathology because it's starting from a mutation in the gene. But these diseases being polygenic, various different genes at different processes, at different places are driving these diseases. That's why it's not so simple that we can target one gene and get down the disease process. Because like for the example, the TNF inhibitor story that I said, we saw that TNF levels were increased in heart failure. We thought that that was driving the heart failure, but that was not the explanation. It was probably a counter-regulatory response of the body. So similarly, some gene upregulation which appears to be inflammatory may actually be a counter-regulatory response. So if we suppress that, actually disease process may go up. So I hope I could provide some clarity because it's not a simple question to answer.
Okay, if there are no questions, I think we will bind up the session.
Sir,
Thank you
one more
very much,
question,
Dr. Mishra.
Sir,
Huh?
just one more question.
Oh, please, carry on. No problem.
So, as you congratulations for the nice presentation. So my question is, as you told earlier, just now you told, so targeted B lymphocytes in SLE and systemic sclerosis. So would you like to share what are those? Basically in systemic sclerosis and in which aspect?
Predominantly rituximab is the drug that has been used. It is a CD20 target and it has been found useful in systemic sclerosis associated ILD and in systemic lupus, particularly in refractory disease, and also is used in patients with rheumatoid arthritis and ANCA vasculitis. Beside rituximab B-cell targeted therapies, others are not really into clinical practice. Many are being evaluated. Recent literature has also tried to evaluate CD19 blockade because that acts on B lymphocytes at a little earlier stage of development as well, in addition to, because CD19 is expressed earlier than the CD20. So practically in clinical use, you have rituximab, and also your cyclophosphamide is a drug which predominantly affects the lymphocytes. So
Belimumab, I think, is a B-cell
Belimumab, yes, but Belimumab has not yet come into the Indian market, and I'm honestly skeptical about it.
Lupus, yes. Only in lupus, and
Yeah,
it's
only-
again the
only in
nephritis
lupus,
activity is again
in
controversial.
predominantly mild disease, and very many people feel that its effect is similar to that of hydroxychloroquine. So,
Okay, thank you all for your patient listening. Thank you, Dr. Mishra, for your very excellent, extensive talk. Thank you. All the
Thank
best.
you, sir. May I request our speakers to our speaker to kindly felicitate our chairpersons. Yeah. So it will be both. And now we request our chairpersons to kindly felicitate our speaker. Thank you, sir. Thank you, sir. Thank you. Our second talk will be chaired by Professor Dr. Hemant Kar, Dr. Manoj Ram, and Dr. M. Sri Chandan. So please kindly grace the dais.
Hello. Good morning to everybody. Dr. Muralidhar Rajagopalan is an eminent dermatologist of the country. He is working as a senior consultant in Apollo Hospital, Chennai. Very close friend of mine, very close friend of everybody. Only he is the eminent dermatologist using the biologicals maximum in so many biological responsive dermatoses, including psoriasis also. So, yes, a lot of publications, 74, a lot of awards, honors in achievement. He is a senior counselor, International Psoriasis Council. He is the director of International Society of Atopic Dermatitis. He is a Marcus Bolan visiting professor for vasculitis in the Rutgers University. He is a Lifetime Achievement Award by SARC and DAS also. So, his area of interest is on immunodermatology, photography, and art. So now the desk is yours, Dr. Muralidhar, please.
Thank you, sir. I'd like to place on record that is my first visit to Orissa. Very charming place, and I'm grateful to Dr. Parida for accommodating me. And thank you very much, my friends over here. I'm also grateful to Dr. Mishra because he laid the groundwork for what I'm going to be talking about. I'll probably be taking off from where he left, and some of the questions raised will also be probably at least partially addressed in this talk. Psoriasis and immunology is my primary area of interest, and this talk, when you talk about future trends, will definitely be probably a little bit toxic, but please bear with me. I'll try to make it as easy as possible, but being rheumatologist, it shouldn't be a problem. You know, the areas I'm going to be talking about, there is no pharma company involved, and I have absolutely no conflict of interest. Each slide actually is a presentation by itself. So I'll be only presenting concepts and which we can discuss as time goes by. Now there are, when we talk about the future needs of psoriasis, working with the IPC from 2004, we have been addressing a lot of these issues. We need oral therapies which are similar or better than the biologics. Yes, I am interested in biologics, but we know the fallacies with biologics, the problems which we face. Now there is a great need for topical agents that can be used long term, because many patients of psoriasis have very mild disease, so you may not need something as potent as a biologic. There are many unanswered questions with respect to the development of psoriatic arthritis. As a dermatologist, we are going to see patients who will develop arthritis, and dermatologists in the audience here and many rheumatologists would understand that every year that a patient of plain psoriasis is not treated, there's a 3% increased risk of the patient developing arthritis. The combination of psoriasis with psoriatic arthritis is pretty lethal, because that is when the heart starts getting affected. But we are not able to predict which psoriatic patients will develop which comorbid condition. There are very significant needs which are related to access and affordabilities of these newer targeted therapies, which is probably why targeted therapies have not taken off well in India. Now, the majority of psoriasis patients are underdiagnosed, they are undertreated. So when we talk about future of psoriasis, we have to talk about optimizing our treatment protocols. We do have a Skin of Color Society, and we have a separate group which is looking at the response of psoriasis in skin of color, which I happen to chair. We realize that dark skin races, like all of us in the third world, are a challenge because most clinical trials are conducted in Caucasian skin. And we are just blindly transporting it into our patients, which may not actually be the reason or the rationale for using it. The skin of color is underrepresented in these studies. Even the responses to biologic varies in different skin types. Some time ago, I did a separate lecture on why biologics fail. And this is one of the main reasons, because we are assuming that what happens in the white skin should happen in India, which is not necessarily true. We all know about this. Dr. Mishra has briefly touched upon this also. This just talks about the lineage. When we have a trigger, we have targets at the triggers, the stressed keratinocytes. This is where the question of Dr. Sujata about epigenetics comes in. We have dendritic cells which are going to stimulate different lineages, the Th1, Th22 and Th17 cells mediated by cytokines. We also have the JAK-STAT pathway, all of which contribute to developing psoriatic skin. The presence of psoriatic skin is going to lead to its own problems in the whole system. Our basis in this whole lecture is going to be working towards a more holistic management of patients with psoriasis. So for that, this next cartoon is very important. As a dermatologist, I can tell you we are not very bothered about psoriasis in the skin anymore. We are bothered about inflammation, and we are bothered about endothelial dysfunction, which seems to be mediating what is happening in the end stage of a patient who has psoriasis. We have accelerated atherosclerosis, subclinical vascular injury, and cardiovascular disease. We had to change the mindset of cardiologists into accepting that cardiovascular disease is actually an inflammation rather than just a benign collection of platelets and lipids which block arteries. Why do they collect? It's because of inflammation. So this is where this group comes into relevance. There are traditional cardiovascular risk factors. We had lipid anomalies. There is platelet activation and other factors like insulin resistance and the dysregulation of adipokines, which incidentally is very, very important in psoriasis, because psoriatic patients have all these factors, and all of which leads to cardiovascular disease and ultimately death. So the newer treatment targets, for some time, those of you who are interested in looking at some of these aspects will know that for a very brief period of time, probably 6 to 9 months, they started talking about statins improving psoriasis. It's a very interesting concept. But then it was found that statins are not so very important because it's not uniform. But there was an enzyme called the PCSK9. This itself increases the risk of psoriasis. Now this is present, this is mainly mediating the metabolism of cholesterol. This gives you the direct link between psoriasis and cardiovascular disease. Now, the levels of PCSK9 is elevated in psoriatic skin. Now, we are developing targets for this. Alirocumab, that is Praluent, and Evolocumab, that is Repatha, are new anti-lipid agents which target this particular enzyme. And probably, if you're going to have a patient of psoriasis, it will be good for dermatologists to look at the lipid levels and start using drugs like this, because they have a much more holistic management in managing both psoriasis and in preventing cardiovascular disease. Actually, we're going to move away from biologics. I was introduced as a person who's very fond of biologics, but I think we're going to move away from it. The biggest hurdle in psoriasis, questions which patients ask us: why do I have psoriasis? Why does he not have psoriasis? Now, you have a family member, you have a parent coming with psoriasis. The question he asks you is, will my child get psoriasis? We need to answer this. We all know as doctors that the phenotype of psoriasis varies from person to person. Now, is that going to affect treatment? Is a single patch on the scalp going to be different from multiple patches on the whole body? Is a person with mild enthesitis seen just in the ankle and a person with extensive psoriasis going to respond differently to drugs? Now, when you start a patient on a drug, can you actually predict the response? They're going to use pretty expensive drugs, and a whole lot of therapeutic armamentarium is there. What is likely to be a complication of drug therapy? And in a patient, which drug is going to work best? So what are the demographics which are going to decide this? We also have to understand that when we tell our patients about therapy, we have to also tell them that there is no cure. But a year or 2 years down the line, some patients come back to us with persistent disease, some patients come back to us with remission, whether it is psoriatic arthritis or psoriatic skin disease. Now, one of the important factors which we need to understand is the presence of these. I was just discussing with one of my friends in dermatology just now, is the presence of what we call as tissue resident memory T cells. Many of these biologics fail because they don't target these memory T cells. Now, there are genomic profiles which have been studied. They are persistent in these cells and they perpetuate the disease. So, in so-called resolved lesions between a flare, we are not actually targeting or studying these cells. So, which is why lesions come back on old plaques. Now, these are IL-22 producing CD4 cells. They also produce IL-17. The question is, for the future, when you look at it, the next, now when I talk about the future in my deliberation today, it's going to be the next 4 to 5 years. I'm not going to go beyond that. Can you target tissue resident memory T cells to prevent a relapse of the disease? Because there's nothing more disheartening for a patient in whom you treated and then the patient's lesions disappear, he comes back and tells you everything has come back, sir. The answer is yes. This may be deleterious actually. It's a huge topic of discussion because psoriasis is in many ways an evolutionary advantage for the species. May not be an advantage for all of us as individuals, but for the species it is an advantage. I did discuss this in one of the dermacons where by mistake they gave me an oration and I spoke on perspectives in psoriasis and I spoke about how the evolution of psoriasis changed and how diseases disappeared when psoriasis came up because of the pro-inflammatory milieu that came into the body and actually helped patients in the initial stages. But what should we do? We need to know how to keep that inflammation under check. So we can target tissue-resident memory T cells. Take a simple thing like IL-23 blockers. They decrease tissue-resident memory T cells. The IL-17 blockers don't do that. Very well-known gentleman, Dr. Andrew Blauvelt. I know him personally, and this is what he told me. He told me this about 4 years ago in one of our meetings. Recently got published in September 2023, just about a month ago. Hitting hard and early in the treatment course with high-dose IL-23 blockade may actually be an effective strategy to induce long-term remissions and possible cure this is what we call as a knockout therapy. So very early, when you just have a patient with psoriasis in the skin, nothing else, you might probably want to hit hard and early. Please understand that most of the data that's being presented in conferences is data from trials. And companies would like to optimize the trial to get an FDA approval. So they wouldn't actually use what they call as a suprapharmacological dose. Real world evidence in the use of these kind of drugs does not exist in the amount that we would like. But this is a gentleman who actually did this and talks about what we call as a knockout therapy. The other question is, what is the psoriasis autoantigen? Do we call it as an autoimmune disease, or do we call it as an autoinflammatory disease? Do they overlap? If they do, where do they overlap? Huge area of discussion again. There have been identified epidermal autoantigens. Now, keratinocyte proteins are similar to streptococcal antigens. We were aware long ago that streptococcus can worsen psoriasis, and this has now been linked to an epidermal autoantigen, which is where once again your epigenetics comes in. There is one antimicrobial peptide, CCL37. There are also neolipid antigens. Rheumatologists are all aware of HLA-CO6. Now, this actually presents a melanocytic protein called as ADAM-TSL5. A combination of CCL37 and ADAM-TSL5 is recognized by IL-17 producing CD8 cells, which is when the psoriasis loop starts. We all know that psoriasis is intricately linked to metabolism. This is where the whole field of metabolomics comes in. A high-fat diet has been shown to exacerbate the inflammation in psoriatic skin. You do not treat your patients without talking about lifestyle. I advise all my patients that your disease is not going to go, even with therapy, if you don't change your lifestyle. Even if you're not obese, you have to exercise, you have to bring down the abdominal fat content. That is what is important, what we call as the brown adipocytes. These produce fatty acids. They shift the immune response in dendritic cells towards IL-23. We saw the dendritic cells right in the beginning of this lecture. Now, psoriasis by itself worsens the metabolic syndrome. So the disease tends to perpetuate itself, and that is why we need to start working on metabolomics in psoriasis rather than just treating a patch of psoriasis. There is a genetic polymorphism of psoriasis. The treatment efficacy is going to change in the future. So the concept of personalized medicine is a new individualized approach which helps to apply a targeted therapy. It's not going to be blind anymore. The goal of this kind of therapy is to determine what is that subgroup of patients. Remember, I told you who is going to respond to what therapy. So if you're able to find out who is going to respond, you will be able to use a biomarker so that you will be able to get the best benefit and the lowest risk of side effects. There are genetic predictors for clinical response to biologics. It may vary from person to person. So it is wrong to say that a particular biologic will work in all patients. So, in psoriasis studies, let's look at something very simple, which is the TNF-alpha. Now, TNF-alpha blockers are actually the very first generation of biologics. We don't use them so much in our practice today except for very certain specific situations. There is a superfamily 1b, that's TNFR1b. We have TNF-induced protein 3. They all are associated with a response to anti-TNF therapy. So if these are not there, if you're able to measure it, your patient won't respond to a TNF-alpha blocker, even if you use a drug like infliximab at 10 milligram per kg body weight. All the other cytokines have also been studied. So all this can help to predict response to therapy and even complications such as psoriatic arthritis, which is where rheumatologists are interested. So this takes us to the whole field of biomarkers. Now, what's the downside to it? Now, biomarkers are indicators of the normal biologic or pathogenic processes or the responses to therapy. We have diagnostic biomarkers, say for example, to look for psoriatic arthritis. We have prognostic biomarkers, which are going to tell you who is going to develop which type of comorbidity. We have predictive biomarkers. They can predict a response to a particular drug, by using biomarkers like single nucleotide polymorphisms. This is the most important thing in this whole lecture. Biomarkers can save costs, but then you have certain ethical issues. Have a patient, this may actually lead to overuse of a particular drug, because your biomarker may say that this patient is going to develop this comorbidity and you'll end up using the drug. We don't have very extensive studies which are going to actually evaluate or clarify which biomarker, what is the predictive response of a particular biomarker. So this, once again, in the next 3 to 4 years, we will have more clarity, which is why biomarkers have not yet been approved in psoriasis today, though we have them. Now, look at predicting disease severity. At the genomic level, we have all these biomarkers. Most of us are aware of HLA-CO6. We also have IL-17A. We have all these glycolic acids, kallikrein, and you have the metabolomic candidates like tyramine. They were all considered. None of them have been approved as yet. Psoriasis patients incidentally end up with diabetes, and diabetes worsens psoriasis. Psoriasis and diabetes is a deadly combination as far as the heart is concerned. There are genomic variations in IL-12 and 23. These are potential indicators. So your patient may not have diabetes at the time of presentation. This is an area where you might be able to predict this. The cardiovascular disease prevention in psoriasis is actually being done at the level of a dermatologist. So I think dermatologists should wake up, learn a lot of immunology, and work closely with the rheumatologists. We need to have more such conferences where we work together, because ultimately we want to prevent cardiovascular disease, not just disability due to joint involvement or skin involvement. Now, take for example secukinumab, which is an IL-17 blocker. I have actually been doing this with some of my patients. We have a lot of patients who are being referred to me by other dermatologists who say that they have not responded well to secukinumab. Can we do something else? I have used secukinumab 300 mg every 2 weeks. Superior efficacy compared with secukinumab 300 mg every 4 weeks in patients who are overweight. Take 80 to 85 kilos. Now, incidentally, Indians are getting there. Maybe in this particular audience, we have an average weight of 75 to 80. But you go to many audiences in dermacons, thanks to the gala dinners, you have an average weight of 90 to 95. Am I right? Okay. Now, despite, very interestingly, when you talk about IL-17 blockers, everybody talks about the frequency of candidal infection and fungal infection. When I have used secukinumab, now incidentally, I am not a person who publishes too much nowadays. I'm a bit lazy. But this got published after I already put in my observations. One of my own colleagues from the IPC did this in BJD. If you give secukinumab more frequently, forget about the trials, the incidence of infections actually comes down. We actually don't know why. I have not seen any patient with candidiasis in my practice. And I've been using IL-17 blockers ever since they were introduced in India. We have drug delivery systems like nanodermatology. It's an emerging field. One interesting point I'll make over here, there's a very good Taiwanese scientist called Tai Chen. He had a sophisticated large-scale approach. He looked at the synergy between capillary sequencing, PCR, and gold nanoparticles to see what are the factors which confer a risk to develop psoriasis. If you remember, I told you, if a patient comes to you and says, I have psoriasis, will my brother or will my child develop psoriasis? Now, this is one area which probably can be useful there. SNPs are also capable to predict responsiveness to certain anti-psoriatic drugs. All this comes into the field of nanodermatology. We have another very interesting part called microneedling. We have psoriatic patches. We have different types of microneedling. I won't go into all this. But this is one form of transdermal drug delivery. You have a base plate. There is an array of micro-sized needles. They can pierce the skin and create a microchannel. It has been tried with calcipotriol and betamethasone. Methotrexate has been encapsulated and delivered into a patch just at the level of the subdermis. You have drugs which can target the inflammasomes, which Dr. Mishra spoke about. They are loaded with dexamethasone. Now we know that topical steroids can create a problem because of atrophy and a lot of side effects. But you target just those particular cells with the steroid, and the patient actually responds well. The question of gene editing is being accomplished with this technology of microneedling, where they're able to deliver a particular drug at the level of the gene. Very, very nascent stage, but yes, this is happening. There are newer biologicals. I'll talk about only one. That is mirikizumab. This targets the IL-23, TH17 pathway. As of now, it is in trial in ulcerative colitis. It has just been approved about 3 months ago. Now, they used it in patients who failed TNF blockers, tofacitinib, which is a small molecule, or other biologics. Now, this is a humanized IgG4 antibody. It binds to the P19 subunit of IL-23, which can, stimulate the whole cascade of other cytokines. Why are we talking about ulcerative colitis? We know very well that in the autoinflammatory syndrome complex of psoriasis, you have skin, you have joint, you have bowel, you have the heart, you have even the brain, by the way, being involved in the entire sequence of autoinflammatory syndromes. Oral biologics are going to be introduced. TNF-alpha blockers have already been introduced as an oral biologic recently. Now, there are peptide-type small molecules which can block IL-17 or IL-23 signaling. Forget about giving injections. They're less expensive, actually. And then you can also develop a monoclonal with a robotic pill. We have been using robotics. In my hospital itself, we have already started using robotics in many fields. But you start delivering a drug with a robotic pill. There are different parts of the gut which are going to be able to absorb a particular nanomolecule better. So this is how we are going to use a robotic pill in the future. JAK inhibitors, a brief mention was already made about it. Say, to just take one example, the IL-23 receptor is associated with JAK2, tyrosine kinase 2, and STAT3. No JAK inhibitor has received regulatory approval for the treatment of plaque psoriasis, though yes, psoriatic arthritis, it has received some approvals. But when you talk about deucravacitinib, it's a selective tyrosine kinase inhibitor which is receiving approval. Now, incidentally, deucravacitinib has already been approved in Japan for treating atopic dermatitis. Now, what is the future actually going to look like? The future is going to be, now this is where youngsters need to wake up, because in the future, we are not going to talk about psoriasis, we are not going to talk about atopic dermatitis. I work on both the fields. We're going to talk about one particular molecule which is pathogenically important, and how can we target that molecule? Where is its role in the pathogenesis of the disease? Now, this is how deucravacitinib has a dual role, whereas most biologics, when we talk about it, may worsen one or aggravate the other or make things better for another disease. This is the advantage of these kind of selective tyrosine kinase inhibitors. Epigenetics, the question was asked. Now, it is a study of heritable changes in gene expression. There are active versus inactive genes. They don't involve changes in the underlying DNA sequence. Now, this is where the question of polygenics becomes important. You have at least 15 to 17 genes which induce psoriasis. So you don't bother about that, because these genes change a phenotype without a change in a genotype. So epigenetics can modify that. You have areas like DNA methylation, histone modification, and silence the gene via the action of microRNAs. These are all potential targets in new therapies. If you look at this cartoon, looks very complex, so I'll take you around it. Number one is you can target DNA methylation. You can't see that there. Yeah, DNA methylation. Number two are histone modifications. You have this over here. Number two, it's written out there. Then you have targets which are going to target microRNA, which is number three. This is microRNAs which are coming out and producing inflammatory molecules. Then you have DNA methyl transferases, what we call as DNMT, which is number four. We already have developed DNMT inhibitors. You have histone acetylases or HATs, which is 5, which is over here. Now, histones are necessary for activating transcription. And very interestingly, we have a new thing called as the BET inhibitors, which are bromodomains, which activate histones. And these have also already been developed. Just a question of 3 to 5 years, remember this, before you're going to start using epigenetic modifying therapies. Now, they are not going to interfere with the polygenic genes present in a particular disease, but you're going to modify the way these polygenic genes are going to affect a target organ. That is why these therapies are very exciting. So they have been developed. I spoke about methylation, histone upregulation, aberrant microRNA expression. Now, all this leads to activation of cytokines, proliferation of keratinocytes, and angiogenesis. Please remember, we are talking a lot about angiogenesis because it is the endothelial dysfunction which seems to be very important in these kind of inflammatory diseases. So we have to start changing the way we think about inflammation. We have a drug called as trichostatin A, which inhibits differentiation of the regulatory T cells to pathogenic Th17 cells in psoriasis patients. We are now looking at ways to reverse the way in which Th17 cells have been developed, because the regulatory T cells maintain the body in a homeostatic formation. SIRT1 activators, we have them also, which inhibit keratinocyte proliferation. These are class 4 histone deacylators. The aberrant expression profiles of microRNAs have been characterized. We are developing inhibitors for this now. Look at these drugs. Do you find any of them familiar to you over here? The interesting thing is most of these drugs have been developed for lymphomas. Vorinostat is already available for the treatment of lymphomas. The epigenetic therapies regulate cytokine expression irrespective of what the gene is doing. So we're looking at a connection between a lymphoma and psoriasis. Incidentally, psoriasis specialists will tell you that psoriasis is actually a pre-malignant disease. One of the commonest malignancies seen in psoriasis is lymphoma. It is not the drug, it is the disease which produces the lymphoma. So you might want to start using a drug like vorinostat in psoriasis in the future, because this is going to target the epigenetic modifications. Once again, this is what I was talking about. You can combat autoimmune diseases with ROR receptors. Dr. Mishra showed you where these receptors are placed within the cells, and look at the multiple areas where ROR receptors are going to play a role. Now, not just psoriasis. In the brain, multiple sclerosis, rheumatoid arthritis, ankylosing spondylitis, Crohn's, psoriatic arthritis, diabetes, and respiratory disorders, especially interstitial lung disease. I do not know how many dermatologists actually look at the lungs in their patients of psoriasis. The very high incidence of interstitial lung disease. I myself have patients who have succumbed to interstitial lung disease. So you block that, you're going to target multiple diseases at the same time. So I think you will get an idea as to where I'm going. We also have what are called as ROCK2 inhibitors. These inhibitors are Rho-associated protein kinase. There is an oral administration of a drug called KD025. Once again, phase 2 trials. There is only a 50% reduction in delta PASI scores. If you look at drug companies and FDA, they only talk about delta PASI 100. But we are not really bothered much in the future about delta PASI 100. If you are able to modify the inflammatory response, you might be able to have a more holistic management. So it down-regulates the autoimmune response, which are driven by Th17 cells. So combining epigenetic drugs with gene editing by using, say, for example, one of the many examples, I won't go into that, is, say, for example, a CRISPR technology. This is one of the promises for a cure in psoriasis. So to wind up, my take-home messages when we talk about the future of psoriasis, that what are we moving towards? We are moving towards a complete cure. We are moving towards a holistic management. This is mediated by precision-based personalized medicine. We have newer drug therapies, newer targets, and newer molecules coming in. We are looking at genetic modification and treating the unaffected. This is what we are looking at now in the future, because we have a patient population, we have patients linked to them with a genetic profile, and we are looking at what are they going to develop. Very huge ethical issues here, but this is where the future is. The future is going into not just a brave new world, but a dangerous new world. We are looking at a holistic management of psoriasis as a disease of the immune system. That is what you're going to look at. So the search has just started. I will wind up with this image. How many of you recognized who drew this? Who painted this? This is a painting by Van Gogh. You know the importance of why I brought this here? When Van Gogh actually made his paintings, or when he brought these up, he was considered a madman. He was even put into an asylum. I'm sure 90% of the audiences I have addressed in my life feel the same way about me when I present certain topics. They're toxic and they open up a new field which we are not familiar with. But after Van Gogh died, the world woke up, and this particular painting sold for $110 million recently. It's the largest sale for any painting. People are going to realize what we are talking about in conferences like this only in the future. So I'm very grateful that Dr. Parida invited me to present some of my take-home messages which I have learned in my experience with psoriasis. I hope it makes sense. Thank you very much.
I think this is an excellent talk. So I think all the hall, because Hari is here, I think we are very fortunate to have him here. And I have never actually had something like this. So I request the hall to please stand and applaud, sir. Thank you, sir, for being with us, sir.
I'm very grateful. I'm very, very grateful.
It was wonderful listening to you, Dr. Murli. We were transported to the future of psoriatic therapy. In a sense, cure was something which we never thought about. Psoriasis, now you give us a ray of hope. That probably after going out of this hall, when I see my next psoriasis patient, I'll think beyond skin and bone. I'll think about metabolic things, I'll think about cardiovascular things, I'll think about genetic, and even lymphomas. Thank you for that. And now for the audience to questions.
Thank you, Dr. Muralidhar. Very nice talk. Really, psoriasis management is a multidisciplinary approach. As you have already showed, there's multiple comorbidities. So you have rightly pointed out that cardiovascular disease is definitely a major problem. So also the diabetes, hypertension, dyslipidemia, these are all major problems with psoriasis. But my point is, suppose a patient with MI, post myocardial infarction, with psoriasis comes to you, okay? As you have already shown, and already also you have pointed out, the cardiovascular disease is an anti-inflammatory, it's an inflammatory disease. So you have to deal with anti-inflammatory drugs. But unfortunately, though inflammation is a part of a risk, high risk, but no anti-inflammatory has been proved to be beneficial, except one, there was one controlled trial where canakinumab was used and found to be effective, but unfortunately it was not approved. But there is only one anti-inflammatory drug, that is colchicine, has been approved for in post-MI patients. Okay, Calcutta trial has shown effective and is been approved. My point is there any area your psoriasis with MI patient comes to you, and is it in this subset of patients, is there any role of treating the patient with the colchicine? Does it also helpful in treating psoriasis as well?
Thank you, sir. I think it's valid. I didn't go too much into the pathogenesis of psoriasis. So when we look at the pathogenesis of psoriasis, one of the final pathways is the NLRP3 inflammasome, and colchicine, as Dr. Mishra pointed out, targets that. I really think that colchicine is an underutilized drug. My talk was not about established drugs and what we do, but I do agree with you that this is a drug which is unexplored in psoriasis. I think dermatologists have kind of closed their mind. I can talk about dermatologists. We have closed our mind to use of a very simple drug like colchicine. And you also highlighted that there are multiple diseases which should be looked at with the common lens. And when we talk about an inflammasome, probably the next conference will be just on an inflammasome. Colchicine is an excellent drug. In some patients of mine, I have actually used it who can't afford all these therapies. And I think all rheumatologists here know that it is a very, very non-toxic drug. If you don't have anything else, use colchicine. I completely agree with you, sir.
Dr. Sakib.
Regarding your experience of ILD in psoriasis, ILD is not a known association with psoriasis spectrum of diseases, but how frequently have you encountered them, and have you considered doing a maybe whole exome study in them to find out if they have specific genetic defects?
Thank you. From 2002, probably before that I was too immature to understand psoriasis. But from 2002, I started working up every psoriasis patient completely, whether they are treatment naive or not. In the last 21 odd years, I have found at least 10 to 20 patients who have had ILD. I really don't think that is uncommon. It is just that we are not looking for it because we know about the pathogenic basis. Your second part of the question about exome sequencing, I have not done anything purely because it's a rather expensive proposal, and until recently we didn't have the technology with us. It's come in probably over the last few years, 3 to 4 years. So I won't be able to answer which genetic profile is actually associated with ILD in my patients. But I would expect that there is a certain genetic predictor. Because that's one thing which I try to highlight, that the phenotypes of psoriasis, the development of comorbidities in psoriasis are all different in different patients, and we are looking at it.
Thank you, sir, for the beautiful presentation.
Sir, congratulations. You have vast knowledge on psoriasis and on biologicals. Sir, two questions I am having. One question, one patient presented with psoriasis with arthritis. Suppose patient developed deformities, and what is the first line treatment? Whether we'll start with methotrexate or we'll start with JAK2 inhibitor or some secukinumab we told. Biological will start, or we'll start first methotrexate, then we'll see response. Or this is the first question. And second question is whether have you seen any case with psoriasis overlap with systemic lupus erythematosus?
Okay. I'll answer the first question, madam. Traditionally, all of us as dermatologists and rheumatologists have been using methotrexate, and I do feel that for the next few years at least, it is going to be the standard of therapy for a pretty long time. What would be the ideal scenario? Ideal scenario would be that when a patient comes to you, we'll lay out all the therapies available. What are the advantages, disadvantages, and most importantly, what is the cost? We'll have to look at that. And third, we have to tell our patients that as of now, we don't have a cure. Fourth, we have to ask the patient, what does he expect of therapy from us when the patient comes to us? One of the things which I remember in one of the national conferences, I was the next speaker, and one of the speakers was a professor in AIIMS, Delhi, said, we have been dishing methotrexate by the bucket loads. I don't know why somebody has to speak about biologics after me. This was a statement made. So I started looking at methotrexate. I told the gentleman earlier that from 2002 I started evaluating patients completely. You'll be interested to know that treatment-naive psoriasis patients have a fatty liver, even if they are not obese. Fatty liver does not depend upon the drug. It is the disease. Fatty liver is not just a question of ignoring it or telling the patient lose weight. Today, we have classifications of fatty liver. Actually, it's called MAFLD now. So, methotrexate is a hepatotoxic drug. We need to think really hard whether we want to continue to use it. But if we don't have a choice, we are going to use it. But the second corollary to your first question is going to be that, are you going to treat a patient early and hard with a biologic? That is what you actually said. I showed you evidence that hitting a patient early and hard, that means you hit early, you hit hard with the best possible therapy in your armamentarium, is probably going to be more beneficial to your patient. The bottom line is going to be, what does your patient want? Has your patient understood the pros and cons of therapy? So that's what is going to decide. I don't make the decisions for my patients. I tell them what's available, I allow them to decide. So I think that answers your second question also.
Sir, SLE with overlaps.
SLE, the question is, if a psoriasis patient has a very high CRP level, when we use drugs, these inflammatory cells start breaking up, the nucleus gets exposed, and you have ANAs developing. They do not necessarily develop full-blown SLE. This is the point. That is one issue. Second, does an SLE patient develop psoriasis at some time? Yes, they do. Did they have a predilection to develop psoriasis? We don't know. We have not studied it.
Thank you, sir.
Thank you.
Thank you, sir, for the beautiful presentation. Thank you.
Thank you very much.
Thank you, sir, for the intriguing session. May I now request our honorable chairpersons to felicitate our esteemed speaker. And our esteemed speaker to felicitate our honorable chairpersons. Thank you, sir. Our next talk will be from all the way from Toronto. It will be chaired by Dr. Bharat Panigrahi, Dr. Deonis Zes, Dr. Santosh Swai. May I please request you to grace the dais.
Okay, so our next session. So I welcome Professor Dr. Vinod Chandran. Where is he? କହିବ oh, is online? Oh, sorry. Okay, so Professor Vinod Chandran is a rheumatologist, is a clinician scientist in the Kremlin Research Institute and an associate professor of medicine in laboratory medicine and pathobiology at the University of Toronto. So he will be talking on looking at rheumatology through the skin. Professor Vinod Chandran, it is audible?
Hello, can you see my screen? Is it projecting?
Yeah. So he will be talking on current understanding of psoriatic arthritis, the way forward. Okay?
All right. Thank you. Thank you, everybody.
Okay, you can start. You can start.
Can you hear me?
Yeah, you can start.
Okay, thanks. So, thank you, and thank you, Jyoti, for the kind invitation. Currently, it's 2:15 a.m. here, Sunday morning. So, but the talks that I was hearing to are quite interesting. My talk would be on psoriatic arthritis, following up with the previous talk. And these are my disclosures. I have received support from some of the major pharmaceuticals that make drugs in psoriatic arthritis. So whatever I talk about treatment should be taken with a pinch of salt. And moreover, my spouse works for AstraZeneca and previously the Eli Lilly, and so I'm very conflicted. Um, Nevertheless, what I plan to speak in the next 20 minutes or so is to describe the heterogeneous disease manifestations of psoriatic arthritis and how that impacts treatment, and then review what current and future approaches to improving psoriatic arthritis outcomes. I must say that I'm speaking from very much from a Western perspective. Although I trained in India, I understand that many of the treatments that I'm going to speak are out of reach for our population there. But hopefully that would change sometime in the future. So what I'll do is talk about psoriatic arthritis, the phenotype and its domains, the current treatment recommendations, and how we can achieve better outcomes. So to begin with, what is psoriatic arthritis? We all know that it's an inflammatory arthritis, a specific form of inflammatory arthritis that associates with psoriasis. And when I say arthritis, there are many other manifestations, not just the synovium, and I'll come to that. And once again, it's associated with psoriasis. There are patients with psoriatic arthritis who do not have psoriasis, but may have a family member. It's seronegative for rheumatoid factor, and that helps in sometimes in the diagnosis. It's a spondyloarthritis, like other spondyloarthritis like ankylosing spondylitis and reactive arthritis. And for clinical trials and other studies, it is classified by the CASPAR criteria. So let's talk about phenotypic domains of psoriatic arthritis. And I'll illustrate that with a few cases. Now this is a person I saw as soon as I came over here in Canada, where he was seen by a dermatologist for psoriasis for about 7 years, and psoriasis was mild. He reported recurrent knee pain with swelling and hand joint pain. When we saw him, he had psoriasis in elbows. He had nail lesions, polyarthritis, DIP involvement. So the diagnosis was pretty straightforward. And as you can see, the CRP was elevated, but not terribly. We treated him with methotrexate and he did really well. However, he used to get injury-triggered flares of arthritis in his knees quite often. And x-rays done over the years showed progressive erosive disease in his DIP, MCP, and PIP joints. And eventually we treated him with etanercept, which he's still on, and did really well. And his trauma-induced, when I say trauma, it's the workout that he's doing in the gym that would sometimes cause his knees to swell up. That also subsided. So this is our successful, despite having disease for some time and erosive disease, he did really well on treatment with an anti-TNF agent. The second case is not so lucky. She had long-standing arthritis, but it affected her lower extremities, the hips, knees, and feet, and which was not recognized as being significant. And she never really saw a rheumatologist. One other reason was that her CRP and ESR, as well as the rheumatoid factor, were all negative, and so the family physicians did not think that her arthritis was related to her very mild psoriasis. And by the time she came to us, she had significant joint inflammation in her lower extremities. She had also already had a knee joint replacement. And as you can see here, the joint involvement was not what we see in other forms of arthritis. She had mid-tarsal involvement, knee and terrible hip joint involvement, which was all missed because she did not see a physician who really could evaluate it properly, and therefore had significant pain, chronic pain, and joint damage, which we initially treated with methotrexate and leflunomide, and then later with anti-TNF therapy. And although her function improved somewhat, her pain scores, as you can see at the bottom, remain persistently high, and her physical function, as measured by the HAG, was still quite bad. The third case is a person who really never knew he had psoriatic arthritis. He had severe psoriasis and was treated with ustekinumab, which was an antibody against IL-12/23, and then realized that he had psoriatic arthritis because prior to going on ustekinumab, he had difficulty getting up and going down the stairs in the morning, and his feet used to hurt a lot in the morning, which he thought was normal. But when that disappeared after treatment with this antibody, he realized that he indeed had psoriatic arthritis. And what he probably had was a lot of enthesitis, which you can see on imaging, an MRI or an ultrasound. But it's complicated because enthesopathy is quite common in the population, especially in the older obese patients who also have psoriasis. And finally, this patient that I saw from a research study where I was looking for patients with psoriasis who do not have arthritis. When I saw him, he did not complain of back or joint pain, but had significant restricted mobility of the spine, and that on X-rays showed evidence of sacroiliitis, and therefore he had axial psoriatic arthritis, which is somewhat different from typical ankylosing spondylitis. So what these four cases indicate is a spectrum of musculoskeletal manifestations of this disease, and of course the psoriasis itself is also very heterogeneous. Just to remind us that psoriatic arthritis is a predominant peripheral spondyloarthritis, and there are other diseases in the same category. So talking about heterogeneity, so as I mentioned, psoriasis is very heterogeneous. There is also nail involvement. The arthritis can be very heterogeneous, as I just mentioned in the four cases that I showed you. Then there is enthesitis and dactylitis, and then with time there can be progressive joint damage, as illustrated in the bottom here with the penicillin cup change. And then axial involvement is also a significant feature, many times asymptomatic. And so to kind of make sense of all this, what we at the Group for Research and Assessment of Psoriasis and Psoriatic Arthritis, GRAPPA, did was to classify these manifestations into these 6 domains. The domains important for the rheumatologist are the peripheral arthritis, axial arthritis, enthesitis, and dactylitis, but also the skin involvement and nail involvement. So when we see our patients with psoriatic arthritis, we evaluate these domains systematically and record if these are active or not. Now, when we look at the musculoskeletal domain, it's not simple. We might think that the patient's joint is involved and there is synovitis, but when you look carefully using ultrasound, we can see that in this particular study that we did a few for last year, can see that even if these patients have swollen joints, when you do a careful imaging, you can see that half of them have predominant synovitis, some of them have predominant enthesitis, and some have predominant peritendinitis. And although these manifestations are present in all these patients, the predominant manifestations differ. And the significance of this is not that clear, but it should note that patients with peritendinitis actually had the most number of swollen and tender joints. So what we see on physical exam is not actually what's going inside. And so if there are experts in ultrasonography, and if you have the time, scanning the joints, especially when the disease is active, or when you're thinking of changing therapy, might be useful, because some of these drugs may work differently in synovitis versus enthesitis. The other problem, of course, this is a cross-sectional study. We don't know if these changes that we see are stable, and we don't know if the treatment differs depending on which domain that we see on ultrasound is present. So these are all important questions when you try to understand the heterogeneity of this disease. As I mentioned, we look at this disease in these 6 domains, but that's not it. In addition to these 6 domains, peripheral arthritis, psoriasis, enthesitis, dactylitis, nail disease, and axial disease, there are other conditions. There are what we call associated conditions, like uveitis and inflammatory bowel disease, more often Crohn's disease, as well as other comorbidities like diabetes and cardiovascular disease, as well as anxiety and depression are the mental health issues. So when we assess our patients, we need to evaluate all of them while so that we can decide on treatment. The reason that's important is because the prominent pathogenetic mechanisms in different tissues involved are different. I'm not going to spend a lot of time on this because it's complicated, but if you could review this paper that was published earlier this year, it would be quite useful. And as you can see, the skin, the prominent cytokine that drives it seems to be interleukin 23 and 17, whereas in the joints, there is TNF, IL-17, and in the NPCs, it's probably IL-23 and IL-7, predominantly IL-17, TNF, and also IL-23. So it's important to there is somebody who has to mute his microphone, sorry. Anyway, if it would have been simple if the cytokine driving a disease in a particular patient is the same at multiple sites, but that is not always the case. You'll have patients who, on treatment with a particular targeted therapy, does extremely well in the joints, but the skin gets worse, or vice versa. And so the heterogeneity of the disease and the heterogeneous drivers of the disease in this particular patients make treatment choice difficult. But having known this, how can we do with the current treatment? Our group has come up with the treatment recommendations. I am not involved in developing these recommendations given my conflicts of interest, and so I'm not an author on this, so probably I can give you a little unbiased opinion on the evidence-based guidelines. Importantly, we talk about achieving lowest possible level of disease activity in all domains, the domains that I mentioned earlier. It's important to get the patient's buy-in, and so explain the options to the patient and they take the decision with your guidance. It's important to look at comorbidities, diabetes, heart disease, depression, fatty liver disease, etc. Will you choose treatment, and the decision is by the patient and is individualized to the patient. The GRAPPA recommendations give you a list of medications that you could choose for particular disease manifestations, the domains that I mentioned. They do not give you a hierarchy of which drug to choose first, because that depends on other factors, and including where the patient is and what drugs are available. So you could choose any of these drugs that are mentioned over here, depending on the domain. I'll spend a little more in a few more slides. And if that fails, they also have recommendations about switching. It's important to ascertain comorbidities and then also evaluate how the patient is doing and ideally treat to target. So what are the drugs that are available? This is our younger members of our organization came up with this review, which was just published, talking about different drugs that are available, looking at the domain. So if you have significant peripheral arthritis or enthesitis or dactylitis, the recommendation is to treat by anti-inflammatories and intraarticular steroid injections, along with conventional synthetic DMARDs like methotrexate, leflunomide, and sulfasalazine. And if that doesn't work, to go on to more targeted therapies, the biologics or small molecule inhibitors. If the disease is predominantly axial, then after NSAIDs, the conventional drugs do not work, and so we generally go to TNF, interleukin 17 inhibitors or JAK inhibitors. For predominant skin and nail disease, after methotrexate, we could consider apremilast, the PDE4 inhibitor, and after that, more targeted therapies like interleukin 17, 23, TNF inhibitors, as well as in rheumatology situation, we could use JAK inhibitors, but also the newer TYK2 inhibitors, which have been approved recently. The related conditions also make it complicated. If the uveitis is severe, you probably would like to treat with a TNF inhibitor. If there is Crohn's disease, you would avoid IL-17 inhibitors and treat with TNF or JAK inhibitors or IL-12, 23 or 23 inhibitors. And so these all have to be taken into consideration. And this table summarizes the relative efficacy between these drugs. There are very few head-to-head trials, so this is more eminence-based. And as you can see, most drugs have similar efficacy on the joints. The differentiator comes when you look at skin and other conditions such as inflammatory bowel disease and uveitis. So how can we achieve better outcomes in our patients with PSA with the currently available therapies and in the future? One important thing is early diagnosis. We showed here many years ago that in our cohort here in Toronto that earlier the patients came to us, the better they had the long-term outcomes. Similar results were seen in a study in Dublin where they demonstrated that even a 6 months delay in diagnosis had a significant impact on joint damage and physical function. This is coming data from the US where they've shown that there's a significant diagnostic delay with that median time from symptom onset to physician diagnosis is 2.5 years, even in the States. And as you can see, over the years, from 2000 to 2015, there has been really no change. So despite all the developments and awareness that's ongoing, the barriers to early diagnosis has not been broken. So one way of improving outcomes is to work with dermatologists, because most patients get their psoriatic arthritis after psoriasis, to identify these patients and then treat them appropriately. The other way to improve outcome is to treat to target. This is a concept that we use a lot in medicine for diabetes and heart disease, for example. So we should use the same concept here, and we could use criteria like the minimal disease activity criteria that looks at patient-reported outcomes and some physician-reported outcomes to decide whether the patient is doing well or not. People say that it's difficult to do in routine practice, but I would argue that when you see patients with psoriatic arthritis, we definitely have to assess all domains and then define the target. 3 of the outcomes are patient-reported, and if you have validated questionnaires in your locality, you could ask the patient to fill it up, or you're a nurse in the clinic. And your job is to look at the joints, the skin, and enthesis to decide if there is disease activity, significant disease activity there, and then identify the active domains, weigh pros and cons of treatment escalation, and always ask the patient what needs to be done, especially if the patient is not in minimal disease activity. Other outcomes that are chosen, which is quite popular, is a CDAPSA, which is the DAPSA without the CRP, but it does not really look at the skin, which I think is a disadvantage. And so if you're doing the DAPSA, also look at the skin by assessing the body surface area. We talked about difficulties and heterogeneity, and I must say that in clinical trials, only about 50-60% of patients have an ACR20 response. And generally speaking, very few patients achieve remission. In our own cohort, sustained remission seen over a period of 6 months is seen in only 9% of our patients. And therefore, we need more treatments. We could go, one of the considerations now is to have combination therapy. Like the previous speaker mentioned, maybe we should start aggressively and then taper off. These strategies have not really been tried. And so, but it's now that we have many options and there is awareness out there, maybe this is a time to use these aggressive therapies earlier on, and even in later phases, try to achieve better outcomes. The dermatologists have done there. Here, with their newer drugs, we get a PASI 19, PASI 100 response in many groups of patients, but not so in rheumatology. We are going in the direction. At the moment, there's a combination trial with guselkumab and golimumab, and we'll see how if you have an advantage of combining anti-TNF therapy with anti-IL-23. The other thought is, could we do something to patients with psoriasis so that the psoriatic arthritis does not happen at all? Could we prevent psoriatic arthritis? There are new prediction tools that have been developed, which we just published, called Presto. But there is also a trial where in patients with high risk for developing psoriatic arthritis, they're treating them with guselkumab for a year to see if that prevents the development of psoriatic arthritis. So if you don't get psoriatic arthritis, that's you don't have the consequent chronic pain, joint damage, physical function, and heart disease. And so primary prevention might be the way to go forward. It's going to be difficult though. With that, these are my learning objectives. And to summarize, what I tried to discuss is that psoriatic arthritis is a specific spondyloarthritis associated with psoriasis. It has many domains, and it's important to assess the peripheral arthritis, axial arthritis, enthesitis, dactylitis, psoriasis, the nail psoriasis when seeing our patients. Targeted therapies used in the treatment, which include biologics as well as small molecules, have made significant improvements, but the efficacy in different domains vary. The goal of treatment is to achieve the lowest possible level of disease activity in all domains of the disease, and it is best to treat to target to improving these outcomes. Early diagnosis and treating to target and use of advanced therapies and treatment of comorbidities, especially obesity, does help achieve remission. And it's time for developing newer drugs as well as newer strategies, including combination therapies, to improve PSA outcomes. And one other strategy that is interesting is to see if we can prevent psoriatic arthritis. With that, I'll stop. I'm happy to take any questions. This is a picture of my group here in Toronto. And hopefully one of these days I'll be there in Odisha to see all of you, especially my professor, Ramnath Mishra, who I saw in the audience. Thank you.
Thank you, sir, for your excellent and lucid presentations on the topic allotted to you. And you rightly said that early the treatment is the basic, best treatment outcome is the basic mantra of the any treatment regarding rheumatological, immunological situations. It is just like tying the goat and to look for the lion to shoot it in the forest, and sometimes you will miss it and the lion will eat up the goat. And similarly, in immunological disease, we face the same situations. And sometimes the question arises, which drug to be started in the early stage, keeping the possibility of associated comorbidities and other situations. We have to individualize the treatment. You have well elaborated on it. And any questions I invite from the house, if anyone of you on the house wanted to have interactions or questions from Professor Binod Chandran, I invite the question from all of you. Yes, please.
Very nice talk, sir. I want to ask one question. Which is the most common JAK inhibitor to be used in psoriatic arthritis?
So what we have here in Canada, we have two of them. We have tofacitinib and upadacitinib. The problem is access and some concerns about the side effect, which was seen in the rheumatoid arthritis trials. What we use mostly is upadacitinib. I don't use it first line. I use it after failure of anti-TNF therapy, primarily because the costs are lower with anti-TNF therapy because biosimilars are available. And in the trials with high-risk patient populations with in rheumatoid arthritis, the side effect profile was better in the anti-TNF group. So our patients with PSA are also at a higher risk of cardiovascular and other diseases. And so I think it would be best to first try an anti-TNF, unless there's a strong reason where you cannot use an anti-TNF, for example, high risk of infection or if there is other contraindications. Of course, the JAK inhibitors are oral therapy, so it's quite popular among patients. It's a pill to eat once a day. But you have to choose the right patient.
Sir, you had a slide that in peripheral involvement, the second line can be methotrexate, but in axial, you have to directly switch as the second line for something other. So, how to approach that?
Right. So it all depends on how severe the manifestation is, right? So if you have severe axial involvement, then after anti-inflammatories, if it is not beneficial, along with other things like physiotherapy, and if that's a primary problem the patient has, then the primary domain that is active, then after NSAIDs, then you have to go to a targeted therapy because methotrexate, sulfasalazine, leflunomide do not really provide much benefit for axial disease in most of the trials that have been done. Although I know there is some data from India which said that therapy with these drugs may be beneficial. But according to the treatment recommendations, if the NSAIDs are not beneficial and you have active axial disease, then it's either TNF inhibitors, IL-17 inhibitors, or JAK inhibitors would be the way to go forward for axial disease.
Thank you, sir.
Now, there is a lot of research going on to determine if not just the symptomatology, but the pathophysiological mechanisms are different between psoriatic axial disease and primary axial disease like ankylosing spondylitis. As you know, the IL-23 inhibitors, which were, when it was tried in axial spondyloarthritis like ankylosing spondylitis, there was no benefit. When they looked at axial symptoms in patients with psoriatic arthritis, there seemed to be benefit. It's questionable because these patients were not properly assessed for axial disease, and they were looking at BASDI, which is a questionnaire which asks about pain, pain in the back, peripheral joints, how do you feel, fatigue, which would improve when other things are improving. So there is currently a clinical trial with guselkumab, particularly looking at patients with psoriatic arthritis with significant axial disease to see if axial psoriatic arthritis improves with an IL-23 inhibitor. We know it doesn't work for axial, for ankylosing spondylitis, but the question is, will it work for axial psoriatic arthritis? And that question is out there. One of the challenges is that we don't really have a proper definition for axial psoriatic arthritis, but we have another study that's going on, which is called the AXIS study, trying to come up with a definition for that too.
Thank you, Dr. Vinod Chandran.
Sir, I want to ask one question. Sir, very nice presentation. Sir, when patient present with peripheral arthritis, swelling joints, and methotrexate will take time to act after 6 weeks minimum. So again, psoriasis will be reactivated by giving steroids. And for arthritis, immediate management helpful is steroids. So can you give low dose steroid for acute inflammation in the joints? It is helpful, or how much steroid? If you give steroid, how much steroid we can give to those patients?
Yes, good question. No, the steroids and psoriasis is interesting. I do not like to give steroids. In my practice, I don't. It's very few patients that I give. But if you look at clinical trials, you know that 30-40% of the patients are on some amount of steroids for reasons. The biggest problem with pustular flare of psoriasis happens when you abruptly withdraw steroids. So if there is methotrexate or other drugs on board, that should not happen. Nevertheless, trying to avoid oral or systemic steroids is good. If the patient has, typically, if the diagnosis is not that delayed, the number of joints affected are low compared to, say, rheumatoid arthritis. So the psoriatic arthritis usually begins as an oligoarthritis and then becomes polyarthritis. So what I do is I inject all the swollen joints rather than give it systemically. So if there are 3-4 joints that are swollen, then I would inject that, including the small joints. not that difficult. Um, give anti-inflammatories if that's not contraindicated. I counsel the patients to say that methotrexate would work quickly if you, not very quickly, but if you have patient that should work, and I give the methotrexate subcutaneously. So I start with 20 milligram off the bat, and after 2 weeks, after repeat blood work, I go to 25 milligram, and then and by 3 months the patient is not doing that well, then go to the next drug, which is usually leflunomide. Again, in my practice, I don't stop and start, so I add leflunomide, continue the blood monitoring and side effect monitoring, and then if they do well, I withdraw the methotrexate. So, and if these two drugs don't really work, then I try to get access to more advanced therapies. But I generally don't give steroids. And if I'm forced to give it, definitely less than 20 milligram. In rheumatoid arthritis, 7.5, 10 milligram seems to work very well. But in psoriatic arthritis, if you really want that kind of wow effect, you would give 20, 30, 40 milligram, which then causes major problems with their, metabolic syndrome and other things. And of course, the higher the dose of higher the dose of steroids, bigger problems. So that's why I try to stay away from prednisone.
Thank you. Thank you, Dr. Binachandran. So I believe it is around 2 a.m. at Toronto. So you are still waiting for your talk. Really, we are all grateful, indebted to you. So please have a good time.
Thank you.
Okay. So thank you. Good night.
Good night.
Scientific Chair, Professor Dr. Prasant Pradhan, to kindly come up the dais and felicitate our esteemed chairpersons. Thank you, sir. As we're running short of time, I would request you to please proceed for the refreshments. It would be for 5 minutes. After that, we'll begin with the tribute session. Sorry.
Somebody can call people from outside. So welcome back after the tea session. I request everybody to please sit because this is going to be the most interesting session of the whole day, and this is what we call as the tribute session. Please, somebody can call everybody from outside. I request everybody to sit, kindly sit, so that we can start. And we can see the posters during the launch time. So good morning all. When we discuss all the recent advances in medicine, I think this is also the time we have to know and we have to acknowledge the fact that there are some people who have, because of their teaching, because of their dedication, because of their research, because of their leadership, has brought the science to this level. And we thought from Odisha Arthritis Rheumatology Foundation Trust to give our utmost respect and tribute to two legends in their field. So for this, the first legend who is a role model for all of us, when we will go to the study the citation, you can just again tell that amount of the citation because this has not been adjusted in a A4 paper, so we have to arrange a A3 paper. But two things what I learned from him and what I observed from him, two things that make him apart from others. One is humility when you are at the top, and the number two is an extraordinary oratory skills. So I'll welcome Professor Rohini Handa sir. Please give him a big hand of applause. Sir, please. So it is very important, it is very difficult to reach certain height in your field, but it is very, very difficult to maintain you at that level with all extreme humility. I think when we are initially introduced to the circle of rheumatology, when we used to see sir, we know that he is a legend because of the last 4 decades of contribution to rheumatology. But when you have a hesitation to interact with such a role model, when he comes down to you in every conference and asks about how are you doing, how are everything, then you really, really feel proud and motivated, and that's what I have got motivated by sir. And number two is, I think I'm not over-exaggerating. When you will listen to his talk today, you will know why I'm telling that he is an extraordinary speaker, orator. He will not tell you the textbooks. It will soothe your ears and soul. So with much delay, before reading his citation, I'll call my wife, Amrita, who has written a poetic tribute to him. Please come here.
Thank you, Dr. Parida, for giving me the privilege. In honor of Professor Rohini Handa, we pay tribute here, a scholar in medicine and a shining pioneer. From Patiala's halls, your journey took flight. With academic brilliance, you reached a towering height. Best graduate with a crown on your head. In clinics and academics, you always excelled. A master teacher, your wisdom still impart. Your dynamic lectures touches every medical heart. Leadership roles you embraced with grace, guiding your peers in the medical race. Internationally renowned, your name gleams. In rheumatology, you fulfilled all your dreams. As a mentor and a guide, you gladly share your knowledge with those who dare. In editorial work, you help us find the path to progress in the medical mind. Professor Rohini Handa, an exceptional inspiration, a beacon of hope for the younger generation. In medicine and rheumatology, you forever shine. It's our honor to pay you tribute in every line. Thank you, sir. Pardon me my mistakes.
Now I'll call upon our scientific chair, Professor Dr. Prashant Pradhan, sir, to read the citation.
It's my privilege and honor to read the citation for Professor Rohini Handa. In the realm of medicine, where dedication meets excellence, there stands a luminary who has illuminated the path of rheumatology for almost 4 decades. Professor Handa, an icon in the field, is not merely a healthcare professional, he is an embodiment of an unwavering commitment and profound knowledge. Professor Handa is currently working as senior consultant rheumatologist at the Indraprastha Apollo Hospital, New Delhi, and Professor Handa has held several important assignments and leadership positions. Professor of Medicine, AIMS, New Delhi, Distinguished Clinical Tutor, Apollo Hospitals and Educational and Research Foundation, Honorary Consultant in Rheumatology in AFMC, Dean of the Indian College of Physicians, President of Asia Pacific League of Association of Rheumatology, that is APLAR President, which is quite a prestigious post from 2010 to 2012, Chair of International League of Association for Rheumatology, President of Indian Rheumatology Association from 2009 to 11, and President of Delhi Rheumatology Association from 2010 to 2012. His contribution to rheumatology have been recognized by several awards and citations by the Indian Council of Medical Research, the Indian Rheumatology Association Oration or IRA Oration, the API Oration, J.C. Patel and B.C. Mehta Prize, and many other orations. And he's also been recognized as Master of IRA in 2022. Professor Handa has served or serves on the educational editorial board of respected medical journals, including Rheumatology Oxford, Current Rheumatology Reports, Best Practice and Research, Clinical Rheumatology, Clinical Rheumatology, Indian Journal of Rheumatology, and many other journals. And he has authored or co-authored 6 books and more than 375 papers, book chapters, and many other articles has been reviewed in various peer-reviewed journals. The most important single contribution is the author of the book, that is Clinical Rheumatology. It is very popular among all the rheumatologists and students. Sir, I personally have read this book and it's really good. And it should be read by almost every trainee. Professor Handa has mentored dozens of students who now occupy chairs of eminence all over the country and abroad. He has delivered more than 500 invited lectures and nearly 20 named lectures, keynotes and orations both nationally and internationally. He is a much sought after teacher and was instrumental in initiating a super specialty training course in rheumatology at Apollo Hospital, New Delhi. In recognition of his invaluable contributions to medicines, rheumatology and academia, we extend our heartfelt tribute to Professor Handa. We honor his remarkable journey and express our deepest gratitude for his enduring service to humanity.
Now I'll call upon Professor Ramnath Misra, sir, Professor Dr. P.C. Singh, sir, and Dr. B.K. Misra, sir, to please felicitate and give this tribute to Professor Rohini Anderson. So now I request Professor Handa, sir, please be here to start your talk. Okay. And by the time the slides are getting uploaded, I think I want Professor Misra to share some of his thoughts on Professor Handa. And incidentally, Professor Misra is the last year we have paid tribute, ORFT tribute 2022 to sir. So this is our honor that sir is here to give the next tribute.
I've known Rohini for decades. And the problem is once you know a person that long, it's very difficult to tell so many good things. Rohini was at AIMS when I first knew him, and I was at SGPGI Lucknow. I have steadily seen him grow to become the president of the Indian Rheumatology Association and the president of Asia Pacific League Against Rheumatism. And the best part of him is his talks are actually directed to the audience. Means he can read the audience mind very well. So he's a very successful orator and has a knowledge of making complex things simple for the audience. He has been bestowed many awards. If I read them out, I have to cut upon his lecture. So without much of it, it's a pleasure to hand over the mic to Rohini. Thank you.
Thank you very much, Professor Mishra. Ladies and gentlemen, chairpersons, I would like to thank Dr. Jyoti Parida for inviting me to speak at this forum. And it's one of my several visits to Odisha. Over years, I have been coming time and again to this, as they said, divine land. I stand before you with all humility. I'm not very sure whether I deserve all these accolades, but I'm nonetheless grateful to the organizers for this singular honor. My brief this afternoon is to talk about small molecules. Have they replaced biologicals in a resource-constrained setting? Now, the advent of the targeted treatments marked a transition from serendipity to specificity. Up until the advent of these agents, we had molecules labeled as the traditional synthetic DMARDs or the conventional synthetic DMARDs that were more by accident than by design, like we borrowed methotrexate from the oncologist. In contradistinction, the targeted treatments that comprise both the biologicals and now the small molecules exemplified by the JAK inhibitors were molecules by design. And we've had a couple of brilliant talks by Durga Prasanna Mishra, Dr. Rajgopalan on the biologicals, the targeted treatments, the pathobiology, and advances in understanding the disease mechanisms led to these targeted treatments. Now, if you look at the science behind this, it's not very difficult. Simply put, you could target the ligand, you could target the receptor, or the site of action could move inside the cell, and we now have agents that target all of these. You have the monoclonal antibodies, they target the ligand, example being infliximab, and then you have receptor constructs that can mop up the cytokine. Classical example is etanercept, and then you target the receptors. Tocilizumab is an example. And then you have cell-targeting biologicals in which you have rituximab and abatacept. And more recently, the site of action moves inside the cell where the JAK inhibitors come into play. Now, the story is somewhat similar to the story of David and Goliath. David was a shepherd boy who went on to become the king of Israel. The big boys or the biologicals caught the rheumatology world with a big bang. Very effective agents, but equally difficult to manufacture, very expensive, and even the biosimilars required a lot of stringent processes to demonstrate bioequivalence. There is nothing like bioidenticality. And the barrier between the big boys and the small molecules was 800 Daltons. This barrier was breached in November of 2012 when we got the first approval for Xeljanz or tofacitinib. And all of us now know that this was a major breakthrough because unlike the biological agents that are manufactured using recombinant technology, the JAK inhibitors could be manufactured by simple chemical processes. The costs were lower. The ease of administration was there. They were oral. Maybe in times to come we'll get oral biologicals also. No problems with storage, transport, no immunogenicity. So this was a major, major breakthrough that we have targeted treatments that could be orally administered and costed a fraction of the biological treatments. And which is what prompted Dr. Parida to talk about this. Do they replace the biologicals? Now, this also stimulated a bandwagon effect. We had a mushrooming of biologicals, then came the biosimilars, and depends upon who you are talking to, intended copies. And we have many of these in our country. But with JAK inhibitors, all hell broke loose. And you have more than 50 companies that manufacture tofacitinib in our country. And for those of you who follow this field, I think it's the #1 selling DMARD in India. The slide pointer is not moving. Well, this is like technology. It lets you down at a moment when you need it most, and which is where the robustness of the JAK inhibitor compensates for the delicate thing of the biologicals. So please bear with me while we get the battery replaced. No, I don't have the laptop here. Actually, that would have been easier, but कोई बात नहीं, we understand. आराम से बदल के दे दीजिए, if possible. Otherwise, give me a laptop here. No issues, we'll wait. Sorry about that. We were talking about the advent of targeted treatments and the major breakthrough that came in November of 2012 when we had these orally administered molecules. And then once tofacitinib came off patent, we have many companies jumping onto the bandwagon, and which also caused some consternation, some confusion amongst the minds of the end users. Do we have the magical cure for rheumatic diseases? And this is a listing of the globally approved JAK inhibitors, and you can see this is a number which continues to increase. And although the slide was made a couple of weeks ago, maybe it is dated, and you find that there are more and more agents that are being approved, several are under development, and to make things complex, what gets approved in Japan may not get EMA approval, and those that get EMA approval may not be approved by the FDA. So you have a field which is mushrooming beyond recognition. Now, this is rheumatoid arthritis, the prototypic inflammatory joint disease seen by a rheumatologist. And if you look at the current treatment scenario, the dice is heavily loaded in favor of the targeted treatments. The conventional synthetic DMARDs number only 4. We have methotrexate as the number 1 drug. Then we have sulfasalazine, leflunomide, and hydroxychloroquine. But if you look at the targeted treatments, they number at the last count 15. We have 5 targeted synthetic DMARDs, and we have 10 biologicals, not all of which are available in our country. So what you have is a problem of plenty, and if you look at psoriatic arthritis, which is seen in nearly 1/4 of the patients with psoriasis, you have even larger number of biologicals that are approved, and trials in psoriasis are not as difficult as trials in rheumatoid arthritis because the skin clearing comes up early. And that is why you have head-to-head trials in psoriasis, whereas you won't find very many head-to-head trials when you talk about arthritis. And then you have some drugs which act on the domain of skin, some which are approved for psoriatic arthritis, although they do work for skin psoriasis also. And golimumab is one example, approved for psoriatic arthritis, not approved for skin alone. Which brings us to the moot point about practical information about JAK inhibitors, and I would like to mention a few things very clearly. Are JAK inhibitors biologicals? And this is a very common misconception. Not at all. The manufacturing process is difficult. They are made by chemically synthesized pathways. So they are not oral biologicals, although you might find people loosely referring to them as biologicals. The manufacturing technology is totally different. Do they replace methotrexate? And for all clinicians, I think this is a very important point, an emphatic no. Methotrexate continues to be the #1 drug even today, the gold standard. Old is gold and gold is never old. So be it rheumatoid arthritis, be it psoriatic arthritis, methotrexate continues to be the #1 drug unless you have reasons of intolerance when you are looking for substitutes or you have suboptimal response to methotrexate. Can JAK inhibitors be used as the first-line drugs? And the answer again is no. So JAK inhibitors, despite all their advantages, are not first-line drugs. You would need to give a fair trial to conventional synthetic DMARDs before you graduate to JAK inhibitors. The lowering of cost does not mean that you lower your vigil. The lowering of cost does not mean that they are catapulted to the frontline ranks. They are valuable additions, but you need to exhaust your options or have cogent reasons before you start JAK inhibitors. And then, very importantly in our country, can they be used without screening? All targeted treatments need screening. You need to screen your patients for hepatitis B, hepatitis C. You need to screen them for latent tuberculosis. And this caution should not be thrown to the winds. So unfortunately, what you find is indiscriminate and injudicious use of JAK inhibitors in our country. They are used as the frontline drug. The patient comes and tells you that my doctor has started this, he said a new medicine has come. So it isn't actually true, and these are the caveats when you consider the JAK inhibitors. Now, the other point, are they the same? Unfortunately, no. And if you look at baricitinib, baricitinib is approved for use only in rheumatoid arthritis, and if you look at tofacitinib, you use it for psoriatic arthritis, and I'm talking about rheumatological indications, ulcerative colitis, but mind you, it's not approved for use in Crohn's disease, whereas upadacitinib is approved for use in Crohn's as well as ulcerative colitis. So there are subtle differences even amongst the JAK inhibitors. Do they replace biologicals? And this was the question put to me by Dr. Parida. And my answer to that is absolutely not. And let me show you some evidence. This is a landmark trial published last year. The oral surveillance trial, this was a post-marketing trial mandated by the US FDA after the approvals to Xalzance. And this was in a population not a trial population without comorbidities, but in a population real world situation enriched with cardiovascular risk factors. There were concerns about the cardiovascular safety of tofacitinib. So the manufacturers were required to enroll patients who had a cardiovascular risk factor, age more than 50, and there were preset endpoints, and this was a non-inferiority trial conducted in almost 30 countries, about 1,500 patients in each arm, and you had two dosages of tofacitinib being used, and the approved dose is 5 milligram twice daily. The trial also included 10 milligrams twice daily, and this is the summary slide which showed that the major adverse cardiovascular events and the adjudicated cancers, tofacitinib, the risk was more in these patients who had a baseline cardiovascular risk factor, and this went on to show that tofacitinib did not meet non-inferiority criteria, and this set the rheumatology world with a lot of buzz, lot of storm, prompted the FDA to give a black box warning, and the labeling changed. And if you look at both sides of the Atlantic, you had the FDA saying that the JAK inhibitors should only be used in patients who have inadequate response to or suboptimal response to or intolerance to the TNF inhibitors. So you had a change in the positioning, whereas the EMA was more circumspect. They did not paint everyone with the same brush. They talked about tofacitinib alone, because this trial was carried out only with tofacitinib, not with upadacitinib or baricitinib. And they mentioned that only for patients more than 65 years old with a history of smoking or risk factors, tofacitinib should be used if there are no suitable alternatives. So the sum and substance of this was that JAK inhibitors come with their share of problems that we as clinicians ought to know about. Of course, there are several unanswered questions. Can this trial data be extrapolated to the other JAK inhibitors? And we have two available in our country, baricitinib and tofacitinib. Can you generalize this to diseases other than rheumatoid? And psoriatic arthritis is not the same as rheumatoid arthritis. And are these results applicable to patients with spondyloarthritis, which is a young patient population as compared to the rheumatoid patients? And this is a very elegant review article by Durga Mishra earlier this year, in which he summed up the evidence. And this trial raised more questions than it answered. And I think the jury is still out. And if you look at now the real world evidence, and this comes from the big data, the US, this is one example. There are many other publications. This is the Corona Rheumatoid Arthritis Registry, multi-site registry in the United States. This was the real-world prescriptions, and as you can see, there were 752 participating providers, and it gave information on 50,000 patients, follow-up time 4 years. And if you look at the real-world data, in contrast to the trial data, this is venous thromboembolism, DVT, pulmonary embolism. The results were not statistically different. And if you look at the major adverse cardiovascular events, serious infectious events, malignancies, again, the rates compared to the biological DMARDs, there was not such a glaring difference. And these real-world data went on to show that the trial data was perhaps different from what you experience in real-world practice. Tofacitinib initiators had a higher risk of herpes zoster, but if you look at the cardiovascular events and the non-melanoma skin cancers, malignancies, death, they were comparable amongst biologicals and the tofacitinib initiators. And this led to a great relief amongst countries where resources continue to be a problem. So the debate about the use of JAK inhibitors, should you adopt them, should you shun them? I think the answer is not in black and white. The answer is somewhat gray, that you need to factor in the patient characteristics as well as other things. And this is the common man of R.K. Lakshman, and in our country we need to think about the common man. Medicine cannot be practiced in isolation. You need to have guidance which is context-specific, evidence-based, and also resource-sensitive. So we need to factor in patient preferences, you need to look at disease attributes, and you need to look at resources that are available. So I think the truth lies somewhere in between. JAK inhibitors can never be the frontline drugs according to the current state of knowledge. You need to select your patients carefully. Do not lower your vigil. We need more real-world data with all the JAK inhibitors that are approved for use. And this is going to be the way forward, neither unquestioned acceptance nor outright rejection. I think that's the way forward. And we also need to factor in the fact that diseases like psoriatic arthritis, diseases like rheumatoid arthritis have a multidimensionality to them. If you look at psoriasis, you have psoriasis spinal involvement, you have peripheral arthritis, the responses vary. Then you have the comorbidities of inflammatory bowel disease with the spondyloarthritis, the skin dimension, the dimensions of dactylitis, uveitis, enthesitis, nail disease, and which is what makes psoriasis more challenging than at times rheumatoid arthritis. And then you have pregnancy. The anti-TNFs are approved for use in pregnancy, whereas JAK inhibitors, according to the current state of knowledge, are not. And this is a slide for the clinicians which outlines that if you have uveitis, the MABs are preferred, etanercept is not preferred. Same way IL-17 inhibitors do not help, the JAK inhibitors do not help. So if you have a patient who has arthritis, spondyloarthritis, psoriatic arthritis with uveitis, you would perhaps prefer a monoclonal antibody. With IBD again, etanercept and IL-17 inhibitors are not preferred. And then with the skin domain, the clearing is far more rapid with IL-17 inhibitors, 2 of which are now available in our country. So all in all, I don't think the answer is going to come in a one-line statement that JAK inhibitors are the be-all and end-all. I think they are, for a country like ours, a valuable addition to the armamentarium. What is more important is a pragmatic drug sequencing. And I think the politically correct word is not resource poor, but resource-constrained countries. And they are very particular about these kind of nomenclature when they make guidance documents, policy documents. And in our country, for inflammatory arthritis like rheumatoid and psoriasis, methotrexate would continue to be the numero uno drug. Suboptimal response to methotrexate, the combinations of conventional synthetic DMARDs would continue to play a role in our country, notwithstanding the fact that the recent EULAR guidance moves away from combination therapy to early use of biologicals. And if there are no cogent reasons, JAK inhibitors would be placed before the biologicals. And if there are contraindications to JAK inhibitors, as I have outlined, this sequence is not set in a tablet of stone, you can change it. But if all goes well, then you would gradually escalate up and then use the biologicals or the biosimilars in our country. And just as it is important to escalate treatment, it is equally important, once the patients reach a stage of remission or disease quiescence, to de-escalate your treatment. adherence is very, very important and a major bottleneck in patients with rheumatic diseases, and you need to de-escalate treatment. And when you talk about de-escalation, you would actually remove the JAK inhibitors or space them apart first and leaving methotrexate till the end. So the reversal is, the de-escalation is in the reverse order, and of course you are parsimonious with your use of corticosteroids, more so with psoriatic arthritis, as Vinod Chandran mentioned. Friends and colleagues, I would like to end with this message that it is not JAK inhibitors to the exclusion of biologicals, it's not one to the exclusion of other. I think we need both of them. And what we need is a nuanced approach that factors in patient preferences, resources available, and the comorbidities. And I think the time has come in rheumatology when I think we do not need more arrows in our quiver. We need archers with better skills like Arjuna, so that we can decide which drug for whom. As Dr. Muralidhar had mentioned, I think we need to move away from protocol-driven treatments to individualized protocols in the subspecialty that is rheumatology. Thank you very much for your kind attention.
Thank you, Professor Honda. Actually, the talk is very, very excellent and very clear message. And as you have told that resource restraint, or there is not, the word should be like that, that there is a the problem with the resource, because it is a personalized, individualized treatment and chronic treatment. So naturally, it's a very, you will have to select the proper patient with the exclusion criteria. And because the lot of JAK inhibitors are available now, and they are oral drugs, little cheaper, but this, those who can afford biologics is the better choice. So in the those who cannot afford and you have a difficulty in having the remission, or there is a difficult to treat rheumatological diseases, and where you think that biologic is needed and he cannot afford, so try JAK inhibitors with the precautions taking, and monitoring is more important, so that you can give a better quality life, and then de-escalation after the remission is achieved. And I like that any of the, from the, any questions to Professor Honda? Yes, please.
Can we have a mic, please?
Mic there. Mic there. Nal samna ko chale aso.
Thank you for your excellent talk. Sir, RA patient after a methotrexate failure, we have given tofacitinib to 3-4 patients. After 2 to 3 months, response is very nice. Arthritis problem almost solved, but patient developed disseminated tinea corporis. So at that time, we have to stop the JAK inhibitor. At that time, what other DMRD we should give in that patient? Sir, my question is not finished. Then, after the improvement of tinea corporis, means treating our tinea corporis, again can we restart tofacitinib? Sir, another question. This is first question. Second question is there, if suppose ankylosing spondylitis patient, patient affordability issue is there. Affordability issue, if patient poor or cannot treat and disease is very severe, and at that time we cannot give TNF-alpha inhibitors, or patient given 3 months TNF-alpha inhibitors, and after this disease flares, and patient at that time cannot afford, can we go for tofacitinib?
Very insightful question. I think pharmacology is the science of selective toxicity. there is not a single clinician who can say that his patients have not picked up any infection or other things down the line. So if you have tinea corporis and you withhold the disease-modifying drugs, in the life of a rheumatoid or the recycling of DMARDs, 2-3 weeks won't matter, because the offset of action will take several weeks. So whenever the dictum is, whenever confronted with an infection, handle the infection. Rheumatoid will take a back seat. If it is a life-threatening infection, you may have to withhold for a couple of weeks. Tinea corporis, you hold for a couple of weeks, treat it effectively, you can restart. Even people who get tuberculosis, should they need biologicals again, they restart that. Yes, the answer to that is temporarily withhold, treat the thing which is staring at you in the face. Once that is sorted out, restart. That's one. Then comes the question of cycling. Not very many patients can continue indefinitely with biologicals, and a reasonable practice is to initiate with biologicals. You have already screened them, whether you need biologicals or JAK inhibitors. And once the inflammatory burden is low and if there are issues about continuation, one can then move over to JAK inhibitors, which is what all of us do all the while. You will not have any guidance document mentioning that, because these are people, when there is a young 25-year-old person who can't drive a bike, cannot go to work, the family will gather the resources for the initial intensive treatment. 4 months down the line, he is driving to work and they cannot afford the biologicals. What we tell them is, whenever you factor in this decision making, you have to discuss costs with the patients. You need to factor in at least 6 months of treatment, and if the patient makes a remarkable recovery, after 4 months you switch on to the JAK inhibitors, and that is what we practically do. And then in our country, no matter what anyone says, judicious use of corticosteroids makes a difference between existing and living. If you learn how to use your corticosteroids, there would come a time when there is a flare despite biologicals. Biologicals are not a cure. 70 to 80% response rate, and over a period of time you may have a slip out. You still need, interspersed with biologicals, corticosteroid. And even in spondyloarthritis, believe me, there are times when you need intra-articular injections all the time, and sometimes you even need oral corticosteroids if the quality of life is an issue. So this is where you are, that you will mix. But what is not good practice is, January you give JAK inhibitors, Feb you move to biologicals, and then by March you are again talking about this. That doesn't make sense. But once the patient is better, and if you are kind of sensible about, don't change horses midstream unless you have cogent reasons. Be patient with your drug, and we have patients who you have to manage like this. What else can you do?
Thank you, sir.
And I would be interested in Professor Mishra's response. He is known to speak his mind, and he's handled a large patient population, and he's a colleague whose clinical judgment I value. I mean, do people continue biologicals indefinitely, and what is your take on then stopping and moving to JAK inhibitors?
Sir, you want to ask a question? Yeah.
Sir, very nicely you given an informative talk. Oh, sorry.
Yes, Rohini, thank you for asking me. I find in a resource-poor setting, or you might use the word resource-constrained setting, the long-term or indefinite use of biologic is a dream. It is not possible, particularly after some duration. The patient himself or herself feels so good that even if you write the drug, the patient decides that I will be off for some time to see if the disease comes back. As Rohini said, that when we use these drugs, which are slow acting but long acting, so the effect of the drug is there for some time, and it appears that it's a both party win, because you are no drug, yet the patient is doing good. But the immunopathogenesis of the disease is very complicated. It is, we are just playing around with some inflammatory molecules, trying to downsize them for a comfortable life. Sooner or later, things will come back. That is well known. However spacing you do, there would be a time come when the disease comes back slowly and definitely. Whether tofacitinib, we haven't had much of experience with tofacitinib. Tofacitinib seems to be a good candidate when cost is comparable. And with many players or many companies manufacturing drug, we are seeing the beginning or just the beginning. Tofacitinib does have a clinical significant role. Disease activity comes down, but again, after stopping tofacitinib, there has been a relapse of the disease which have been managed by biologicals. So I don't know what is the real answer. The real answer should be, I hope, if we can develop prediction model as to which patient respond to which drug. When Tiny Miny was asked this question, when there were 1 million patients of anti-TNF, their genomics, their proteomics have been worked out by Sering Plow. I think the data was by then 50,000 of rheumatoid arthritis patients were given. And when we do drug trial, we take their DNA, we take their RNA, we store them, and we try to figure it out which patient would respond. Many said we do not have the answer. So much as we make things simplistic, God has made us a body and a disease which is far more complicated than giving few shots of tofacitinib or biologic. The last word has not been spoken. We would be enlightened sometime in future to know which patient would respond to which drug. And I have tried my hands with proteomics, with metabolomics. I am sorry to say, in my lifetime, I have not cracked upon this. Someone will eventually, but it is a dream thing, and then only judicious use would be applicable. The best answer is try with a drug for 3 months to 6 months, as Rohini said, and if that molecule works, the genetic, the proteomics are all set for that patient. It is predictably it will work. If there is no response after 3 to 4 months of a particular drug, you have to change the biologic target. That much I can tell you. I am still a novice in this spirit.
Actually, people in India do not switch drugs, they switch doctors. That is the problem. And you will never get an answer. When your chips are down, remember, nothing ever replaces the reasoned clinical judgment of a seasoned clinician. No matter what happens, the patient is sitting before you, you have all the guidelines which are available to you. The person says, "Ki ji, paise hi nahi hai." So when it's a question between choosing what you have to do, you use your best clinical judgment, switch over, and do not fight shy of standing by your courage of conviction. the patient comes first. That ethos has to be ingrained no matter what happens, and something is better than nothing. And as I always like to say, the best is the enemy of good. At least offer good to the patient if you cannot offer the best.
I can just add one of the slides of Rohini. A simplistic mind will tell you why the FDA approved tofacitinib for psoriatic arthritis, yet it had great hesitation to approve it for psoriasis. The same drug, the mechanism of action is same. The cardiovascular side effect of tofacitinib is same in psoriasis as psoriatic arthritis. The drug has not been approved for psoriasis. Yet when we give to patients with psoriatic arthritis, psoriasis lesions do subside. I mean, who will tell the answer? Of the many indications that a certain biological or JAK kinase inhibitors have not been approved, believe me, the pathogenetic mechanisms almost are very similar. So it's not a simple question that a molecule is going to act, yet, I mean, one might think the rheumatologist have more influence on the FDA than the dermatologist has, but it stands to illogic that how did not approve for psoriasis, yet there were phase 2 studies, there were phase 3 studies where plaque psoriasis have seen to be getting better with tofacitinib, yet tofacitinib was not cleared because of the cardiovascular risk factor. So I don't know the answers to many of the questions that come in your mind. Maybe the clinical judgment or the clinician, and each patients are different. Two psoriatic arthritis patients are not similar, and therefore a uniform treatment policy never ever gets to be applicable.
Sir.
No, very simple thing, sir, I wanted to know from you. You said about increased MACE and increased carcinogenesis when using JAK inhibitors. So at what levels, how to monitor, what are the monitoring criteria, and when to stop it?
I think you need to use commonsensical guidelines. There are no guidelines that are mentioned. What is well known is that all inflammatory rheumatic diseases, whether it is psoriatic arthritis or rheumatoid arthritis, what hurts are the joints, what kills is the heart. So everybody who handles rheumatic diseases has to look at the lipids, has to give appropriate treatment in consonance with the guidelines, make sure that the blood pressures and diabetes are under control. You cannot have an ostrich-like attitude about diabetes, about blood pressure, about your cholesterol. This is the kind of screening. There is no extra screening, and age-appropriate guidelines for malignancy, nothing specific. You do a baseline chest X-ray, ask about alteration in bowel habit. If there are any lumps anywhere, you screen them. But doing a PET scan or doing this is not at all recommended. So that's important. And I think finally I'd like to have one message for younger colleagues. Biologicals do not answer everything. You have people failing biologicals upfront. In a tertiary level practice, you will find that you use a biological, it doesn't work. Biologicals may partially work, they may not work at all, and if they work, after 3 years what you find is there is a slip out. So don't go away with this impression that if you do not have biologicals, so biologicals are means to an end, but not an end in themselves.
Thank you, Professor Honda, for a very clear and masterly lecture, Professor. And I thank Professor Mishra for giving the conclusion.
So I think now we understood what we are telling about the session, and this is really astonishing seeing everybody in print of silence and enjoying that academic meeting. I'll request, please, I'll request our speakers are I think I'll request Mr. Sir and both the Mr. Sir to felicitate Sir and Ahanda Sir. So as the time, again we are going very close to the launch, so quickly we'll go to the second tribute session. I think if humility is something that we have described about the previous speaker, simplicity is the best definition for our next speaker whom we are going to pay our tribute. I can just share one or two incidences. When I have left SCB and gone to SGPGI for doing my DA, we are thinking that how our professors will be looking like, because we have seen that institution professors must be having a great aura among themselves and must be in coat jacket and those kind of feeling. But at SGPGI I have seen somebody in slippers, somebody doesn't care about whether the shirt is in or out. But I get to know that somebody has proven the fact that if there is a scleroderma, Raynaud's or scleroderma, digital ulcer, then tadalafil is the choice. And tadalafil, after that I think, is the first line choice of scleroderma, digital ulcer in India. Not only in India, it is worldwide. When I first got my DM, selected into DM, I have gone to touch his feet, and he embraced me with his chest and lifted me in the air. And I have seen that sense of happiness. I don't think that whether my parents were that happy or not, and he told me that I am very happy for you because you are the first one to get this from Odisha, and I think that you are going to serve the people of Odisha. And when I finally passed the DM exam, when I have gone to him, I told, what should I do and where I should join? He told, what is the nearest forest near your city? I told, it is Chandaka Jungle. And he told me, don't take this thing about where you go and join. You go and sit in that jungle. You'll think that after 5-6 months, things will change. So I think from SGPGI, I got the degree, and along with that, I got that confidence from my teachers, which is more than my degree, I think. So without wasting my time, I'll call my professor, my teacher, Professor Vikas Agrawal sir, to the stage for the second tribute, ORFT tribute 2022. And now I'll call my wife to read the poetic tribute that she had handwritten.
Thank you again, Dr. Parida. Dear sir, all the words are not enough. Describing you in few words is tough. A torchbearer and an untiring guide with a soul-touching heart inside. King George's highly revered alma mater, disciplined, hardworking, and a true fighter. Professor in clinical immunology and rheumatology, you always understood a patient's psychology. SDPGIMS, Lucknow is blessed to have you, as you are among the esteemed few. You have mentored and nurtured many a soul, taught them healing pain should always be the goal. In lectures shared, wisdom profound. In research endeavors, you are renowned. With each publication, new knowledge found. Dear sir, your scientific contribution knows no bound. In this ode to Professor Dr. Vikas Agarwal, we toast a scholar, a healer, and humanity's boast. For the lives you have touched and kindness ensued, a heartfelt tribute forever in gratitude. So pardon me my mistakes.
Now I'll call upon our scientific chair, Professor Prasant Pradhan sir, to read the citation.
Good afternoon, everyone. Once again, it's my privilege to read the citation for Professor Vikas Agarwal. We celebrate Professor Vikas Agarwal for his illustrious career and numerous contributions to the world of clinical immunology and rheumatology. Professor Agarwal embarked on his journey at KGMC Lucknow, where he earned his MBBS in 1991, followed by MD in General Medicine in 1996. His thirst for knowledge led him to the SGPGI Lucknow, where he specialized in clinical immunology rheumatology, earning his DM degree in December 2000. He has served as an assistant professor, associate professor, additional professor, and ultimately professor in July 2015. His remarkable journey also includes a significant tenure as senior lecturer at Government Medical College Hospital in Chandigarh. His commitment to nurturing future talent is equally commendable. He has successfully guided 8 PhD candidates to completion and currently mentors 2 more. However, his research prowess is evident in his extensive list of publications in national and international journals along with numerous book chapters. His areas of expertise span a wide range from systemic sclerosis to mechanism of drug resistance, demonstrating his versatility and depth of knowledge in clinical immunology and rheumatology. His contribution to the field of systemic sclerosis is unparalleled and recognized worldwide. His research paper on use of tadalafil in digital ulcers in scleroderma has saved millions of patients from losing their fingers and is a first-line treatment worldwide. In recognition of his outstanding contributions, Professor Agarwal has received numerous awards and honors, including Young Investigator Award at IRACON 2004, Zydus Oration at IRACON 2007, and ICMR International Fellowship for Training in France in 2011, among many others. Beyond his academic achievements, Professor Agarwal's impact resonates across the globe through his invited lectures and workshops, solidifying his status as a respected authority in the field. Today, we feel privileged to honor Professor Vikas Agarwal. We not only applaud in his impressive credentials and accolades, but also recognize the lasting legacy he continues to build the world of clinical immunology and rheumatology. Thank you, Professor Agarwal, for your unwavering commitment to the field of medicine and countless lives you have touched through your work. Thank you, sir, once again.
So now I call upon Professor Dr. Jayashree Mahanti Madam, Dr. M.K. Chotray sir, and Dr. Manish Kumar to felicitate sir. So Professor Jayashree Mahanti sir is the head of the Skin and BD department at ICU Medical College, Cuttack. Dr. M.K. Chotray sir is the president of IRA Odisha State Branch and chairman API, and Manish Kumar sir is our esteemed guest from Patna.
So now we have Professor Vikas Agarwal, Professor in Department of Clinical Immunology, Rheumatology in SCPJ Lucknow. He has about 354 publications, and he will be talking on looking at rheumatology through the skin. His topic is yes, my journey with scleroderma, a decade-long experience. Well, now Professor B.K. Sagrawal, please.
Very good afternoon to everyone, and many thanks for the very honorable respect that has been given to me by my friend Jyoti and Dr. Prashant Pradhan. I don't know whether I deserve all this or not, but I'll share some of the experiences of mine in last 25 years as far as systemic sclerosis is concerned. So my first exposure was during my MD final year exam of medicine, when we got a question on systemic sclerosis, and the question was, write a note on sign systemic sclerosis. Till that time we were not aware of. We know that there is a disease called systemic sclerosis which presents with Raynaud's phenomenon. We literally translated the meaning of sign because we were not aware of this word. Somebody told it means you don't have skin fibrosis. So we wrote everything of systemic sclerosis that we knew, and we passed our exam. But after that, when I joined SGPGI, we were just thinking Raynaud's, we can give calcium channel blocker and everything will be all right. But we were exposed to the harsh realities. When patient comes with this or this, even further disappointing or depressing at times, because we were not having many answers for this. Patient is already on dual vasodilators and is still getting ulcers. But luckily, there was a hope when we could treat these patients, and within few weeks, patients could have a healing of their ulcers. So I'll just share some of my experiences, how we get into that. So systemic sclerosis is an autoimmune disease of unknown etiology, which is characterized by vasculopathy, which manifests in form of Raynaud's, or rather severe Raynaud's, which can manifest in form of even gangrene at times, and also widespread fibrosis of skin as well as internal organs, and also various autoantibodies which are directed against the constituents of the nucleoli. Obviously, as in all the rheumatic diseases, there is some kind of a genetic predisposition because not everybody gets this disease. So just a brief mention about the pathophysiology of systemic sclerosis. In genetically susceptible individual, when you have an exposure of the environmental stress, there is damage to the endothelium. And because of impaired progenitors of the endothelium, there is impaired healing of the endothelium. It leads to activation of the endothelium, which causes activation of various immune cells which are there in the blood, involving both adaptive as well as innate immune system. Finally, this culminates in plethora of inflammatory milieu in form of increased interleukin 6, 17, and also transforming growth factor beta 1. So we did a very small study, I'm not showing the data here, where we had actually 35 patients of systemic sclerosis with interstitial lung disease and 48 patients who were systemic sclerosis but not having any ILD. And we could demonstrate that there is an increase in blood level of IL-6, IL-17 and TGF-beta-1 in systemic sclerosis, and more so in patients with ILD. So clearly showing that there is some kind of a crosstalk going on between inflammation and fibrosis. And also there was increase in TGF-beta-1 in patients who were having interstitial lung disease. So actual journey started in the March of 2007. The credit doesn't go to me because it was this guy whose photograph is there, Dr. Padmanabha Shinoy. He was a senior resident. He came up with the idea, why don't we try out something new? Because every winter we are getting patients with gangrene whom we are trying to get a cervical sympathetic ganglion blockade. And most of the times it was not working. And many times patients were developing complications of this ganglion blockade, including pneumothorax, where we used to rush here and there to find somebody who can put in a chest tube in our patients. So he said, why don't we try out with the PD5 inhibitor? But my contention was that sildenafil, which has got a half-life of 4 to 6 hours and is a costly medicine, how can we give it 4 to 5 times a day only on an experimental basis? Then this guy came up with the molecule tadalafil. This molecule has got a half-life of 17.5 hours. So he said we can give it even alternate day. After 3 doses, we can give it every alternate day and the drug will be having a 24-hour effect. I said, fine, let's write a project. Then we thought if we do just an observational study, it will be mentioned as some kind of a insignificant, significant contribution to the Raynaud's management. Let's do a grade 1 significant study, that is a randomized controlled trial. So we designed that. But while we were designing this study, our ethics committee rejected it thrice, saying that there is no data available. Why do you want to try it? So I said, every time if we have to follow the Western world, then you don't ask us to do something novel. So after third visit of mine to the ethics committee, they finally sort of gave me the approval for this study, and we did this study. So our point at this point in time was that patients who were having Raynaud's phenomenon or ulcer or gangrene, despite on 2 vasodilators, that is calcium channel blocker or ACE inhibitor or angiotensin receptor blocker, they will be given this molecule. So finally we got approval in October. We procured drug with a lot of negotiation with the pharma companies because we have to pay from our own pocket for the drug. But finally we could get it. So once we tried this molecule over a 6 to 8 weeks period, we find that patients were having good relief, not complete relief in Raynaud's phenomenon, but surprising thing was that their ulcers have improved dramatically, as you can see there. But this point in time, we were just focusing on Raynaud's diaries, which patients were reporting on a daily basis. So Raynaud's reported in clinical trials is in form of duration, frequency, and the severity, which they record on a daily basis. When we presented this data to American College of Rheumatology in 2008 in San Francisco, they gave us a plenary presentation for this. The only catch point of this trial was, or criticism of this trial was, that it was a single center study with only 25 patients. Then we decided to go for a multicentric study involving more number of patients. In the winters of 2009, 5 centers were involved, and here we recruited almost 53 patients. Earlier study was a sort of a crossover design, but this was a parallel group study. And so we gave tadalafil 20 milligram alternate day to one patient with standard of care, and the other group we continue with the standard of care. So what we could see was that Raynaud's was improved, and again, the ulcers have improved dramatically. This time we were focusing more on digital ulcers, and we were taking photographs of the ulcers. As you can see, within a span of around 5 to 6 weeks, the ulcers of this lady has healed, which in previous years, historically, hasn't healed in such a short span of time. Again, we presented this study to ACR, and again we got a plenary session this time again, and this was highly appreciated. Just to show you the impact of this study, in 2009, the guidelines for management of Raynaud's in systemic sclerosis were these, as far as EULAR is concerned. Whereas in 2017, when the guidelines were revised, they brought in phosphodiesterase 5 inhibitor, as you can, and it is a strength of recommendation was A. So this meta-analysis conducted on various managements of digital ulcers also gave credence to our study and mentioned that if patient has got digital ulcer, then tadalafil should be, or other phosphodiesterase 5 inhibitors should be used as first-line treatment. While we were doing these studies in 2007, 8, and 2009 and 10, we realized there were some additional catch points also, which we initially didn't pay any attention to. we were using a vasodilator for vasodilating properties. But some of the patients come up and they said that their skin scores have improved. They feel their skin has become more lax. I said it can't happen because there is no report of tadalafil reducing any kind of fibrosis whatsoever. But few patients who were having interstitial lung disease, their breathlessness scores improved dramatically after the usage of this, and they came to me after the trial and they said, we want to continue with this drug. Otherwise, we were using only during winters. So we continue them with the tadalafil, and they showed progressive improvement in their breathlessness. So with this, Jyoti has come to us as the first Odisha DM student at that time, now a very close friend. And he said, why don't we take this observation forward? Why don't we try out with patients of interstitial lung disease and see how the effect of tadalafil is? Because at that time we were using cyclophosphamide predominantly, and a lot of problems with cyclophosphamide were seen, especially the infections, which was one of the very important causes of mortality in patients with systemic sclerosis. So we did design a study. Again, it was a RCT, double blind. All the efforts were put in by Jyoti only. I just supervised, and I said yes to everything. I provided money, I provided him with the drugs. But every effort was put in by him only. So we could recruit some 30 odd patients. Baseline characteristics were similar between all the groups. Our primary endpoint was change in forced vital capacity percentage predicted in both the groups. So one group received only standard of care, other group received standard of care plus tadalafil. There was improvement in visual analog scale of patients as far as breathlessness scores are concerned. The patient and the physician global assessments were concerned. However, our primary endpoint, that was change in forced vital capacity predicted percentage, was not significantly different between the placebo group versus the tadalafil. Maybe because of the smaller number. If you could have recruited more number, this would have become significant. And if somebody remembers, scleroderma lung study shows that patients who receive cyclophosphamide, their degree of fall of FVC was less as compared to placebo. It didn't show any improvement in the forced vital capacity. But if you look at the data here, there was some improvement in forced vital capacity percentage predicted as compared to the placebo group. So this was our conclusion, that we failed our primary objective. However, there was food for thought that it is probably working in patients with interstitial lung disease. Then we reviewed some literature. Are we the only one alien who are actually thinking in terms of whether this molecule has got antifibrotic property? We realized no, we were only ignorant about the literature till that time, because there were a lot of reports where people have already reported that PD5 inhibitors have got antifibrotic properties. So for this, we actually, Mohit is my first PhD student, and we designed a very ambitious project to have primary dermal fibroblasts from patients with systemic sclerosis, and to see in lab whether there is any evidence, if you treat them with PD5 inhibitor, there is some reduction in fibrosis, in vitro evidence. For me as a clinician, I'm not a basic scientist. It took me more than 3 years to establish primary dermal fibroblast cultures. But again, not my effort or not my credit, credit goes to this guy, Mohit. So we could culture, and we cultured these fibroblasts in presence of TGF-beta. You can see that TGF-beta causes upregulation of profibrotic genes. What we have used in this experiment was collagen 1, A1, A2, connective tissue growth factor, fibronectin, and ACTA2. ACTA2 is the master gene for fibrosis. If you are asked to design in a cost-constrained scenario, a study, you can only do with ACTA2. If ACTA2 is high or low, you can say that there is an efficacy or inefficacy of a molecule as far as fibrosis is concerned. And we also looked at the molecules of matrix metalloproteases, which can degrade the established fibrosis like MMP2. So with TGF-beta, you can see there is upregulation of profibrotic gene. However, when we treated these fibroblasts with PD5 inhibitor, sildenafil, you can see there is down regulation of all the profibrotic genes. We used another molecule, PD5 inhibitor, which is zeprinast. Zeprinast is more potent than sildenafil. It again shows more suppression of profibrotic gene expression by TGF-beta. And also we use tadalafil. It again shows that there is a reduction in the profibrotic gene expression. So this was a strategy where we were actually mimicking disease, where we have treated these fibroblasts with TGF-beta first to induce fibrosis, and then we have treated them with this molecule. In lab, we do a reverse strategy also, where we have treated with PD5 inhibitor first, followed by stimulation with TGF-beta 1. And you can see that it was causing further suppression of profibrotic genes. Not only that, it is also causing matrix metalloproteases upregulation. So this was a mRNA expression, gene expression. Somebody may say genes may go up and down, it doesn't make much of an effort unless you show proteins. So we looked at Western blot of these fibroblasts, and here you can see that the Western blot, because TGF-beta has a downstream signaling through two pathways, canonical and non-canonical. Canonical pathways is phosphorylation of SMAD234, whereas non-canonical, multiple pathways, JAK, JNK, P38 MAP kinases, they all culminate on STAT3 or ERK pathway. So here you can see that after treating with PD5 inhibitor, there is definite decrease in protein expression also. So this is a collective bar chart showing of 39 experiments which we have carried out, Western blot data, again showing that all the profibrotic genes or proteins were actually coming down, whereas and the pathways involved were SMAD2, 3 and ERK. Now Sakir is sitting here, who is a professor at KIMS, again, a close friend and a brilliant person. For me, every time I am doing some experiment, my mind closes after that. But Sakir came to me, he said, sir, why don't we do this as a trial, on a trial basis in patients of systemic sclerosis, whether you are actually reducing the fibrosis or not. He designed the study, I only signed and I said, yes, fine. So he came up with 24 patients of systemic sclerosis who were tadalafil naive at that time. 12 were given tadalafil in addition to standard of care. This was not a RCT. It was a consecutive patients who were randomized to just to one patient going to the one arm, other patient going to the other arm. And here what we have done is, so 22 patients actually completed the study. So we have scored the skin by modified Rodnan skin score, which is subjective and at times has come out under a lot of criticism. To remove this criticism, we followed 4 gene biomarkers. There was a paper in 2011 by Lafaya where they have shown that if you can do these 4 genes, thrombospondin 1, cartilage oligomatrix protein 1, interferon inducible gene 44, and Siglec 1, you do not need to show any change in modified Rodnan skin score because this is more objective way. It follows the pattern of skin change, skin fibrosis. And this was one of the outcome measure for this very landmark study on frusilimab, where they have used, frusilimab is a anti-TGF beta monoclonal antibody. It is not coming for clinical usage but because of its side effect profile. So we followed this. And if you see clinically, there was a reduction in modified Rodnan skin score in patients who were receiving tadalafil. If you can look on your right side, and the skin scores were dramatically improving. To say that there is a significant skin score improvement, there has to be a skin score improvement of 5 or more. And you can see in the tadalafil group, out of 11, 10 patients had a skin score improvement by more than 5, as compared to only 1 in the routine care. And when we looked at the 4 gene biomarkers, there was a trend for thrombospondin 1 in the tadalafil group, whereas thrombospondin 1 increased in the placebo group, and rest all Siglec 1, interferon inducible gene, as well as cartilage oligomatrix protein, they came down in patients who were receiving tadalafil. Not only that, we looked at profibrotic gene expression again. We showed that there was significant improvement in the profibrotic gene expression also. So we can conclude with these 2 basic and clinical papers of ours that PD5 inhibitors have definite evidence of antifibrotic efficacy in systemic sclerosis. It blocks both canonical and non-canonical pathways. It improves skin score as well as 4-gene biomarkers. So this was the story till date for the PD5 inhibitors. Then two of my other students, Saurabh, who is on top, and Harshit, who is on below, they thought enough of PD5 inhibitor, why don't we look at other pathways like serotonin? Because serotonin platelets have been reported to play an important role in fibrosis and systemic sclerosis. And platelets have got a very rich source of 5-hydroxytryptamine. And in carcinoid tumors which secrete a lot of 5-HT, you see a lot of fibrosis. So taking clues from there, we thought of, okay, let's evaluate 5-HT pathway also. So we use a molecule terguride, which is a pan-HT inhibitor, and also a molecule which blocks only 5-HT 2B pathway. The molecule is SP204741, and we could demonstrate that both the molecules, both terguride as well as 5-HT2B molecule, a small molecule, SP204741, it causes significant downregulation of profibrotic gene expression. And both gene as well as protein are actually reduced by 5-HT pathway blockade. When we presented this paper of ours in 2017 at one of the IRACON in Lucknow, there was a criticism. You have given 5-HT for stimulation, you have blocked it, so what is great deal about it? You will see some effect. So we changed our strategy. We stimulated these fibroblasts with TGF-beta1 and used 5-HT blockers now. And again, we could demonstrate that once we are stimulating these fibroblasts with TGF-beta1 and using 5-HT blockers, still they have shown reduction in profibrotic gene RNA expression. So clearly showing that 5-HT pathway is important, and it can also be used as an adjunct because some of the molecules are available and they just need some kind of a repurposing. So I'll just skip these slides. I'll come to almost, this is the probably second last slide. Till date, we were only focusing on profibrotic gene expression and the pathways downstream. For the youngsters, this slide is there. Every cell is run by kinases, but they're like it's a car which has been accelerating by an accelerator, but you need to have brakes also. So brakes are basically your phosphatases. These phosphatases, they dephosphorylate various proteins and put brakes on the metabolic pathway, which is. So we thought we should look at some of the brakes which are actually trying to stop fibrosis. So we came across two important phosphatases. One is ppm1A, which actually dephosphorylates your SMAT3, which is a very important canonical signal downstream. And we could demonstrate that with PD5 inhibitor, you upregulate the expression of phosphatases. And another molecule of interest was SHP2, which puts brake on STAT3, which is the main non-canonical signaling molecule downstream. Again, it shows that there is upregulation of SHP2 also. So probably on one hand, PD5 inhibitors are actually causing profibrotic gene RNA expression, protein downregulation, and also putting brakes by upregulating phosphatases. So I'll just like to acknowledge some of my colleagues, contributors to the clinical paper, which have been listed here, and also people in my lab. Specifically, I would like to acknowledge Mohit, who is the person who has established primary fibroblast cultures. From every damn organ you give it to us, we'll have primary fibroblast cultures. We have got pancreatic stellate cell, hepatic stellate cell, lung fibroblast, even peritumoral fibroblast from the brain tumors also, endocardial fibroblast. He is the master. Beside this, I've acknowledged everyone. I would like to acknowledge Parashar Ghosh, who is a professor at IPGMER Kolkata. And his very landmark paper, if somebody has not read, I just want to inform that he has used rituximab for the treatment of interstitial lung disease in patients with systemic sclerosis. And one of his paper published in Rheumatology, Oxford, is widely quoted and is the basis of very many studies across the world. And we do see benefit after we have started using rituximab in patients with systemic sclerosis and ILD. Thank you for your patient listening.
Thank you, sir, for your such valuable talk and also sharing with us your valuable experiences and with so many research works in field of scleroderma. And I think that will stimulate many of our students and also the younger generation for more researches in this field. Thank you, sir, once again.
Thank you.
मैं प्रोफेसर रामनाथ मिश्रा जी के सर को रिक्वेस्ट करूंगा कंक्लूसिव रिमार्क वो दें बेस्ट पर्सन
Thank you, Vikas, for that beautiful talk, starting from the Raynaud's phenomena, then the lab experiment one by one. I am witness to all that because when Vikas joined as faculty, we asked him to look after scleroderma, which is a very challenging disease. And it's very challenging up in the north part of the country. During winter months, these patients are very symptomatic. It is, I was witness at the San Francisco meeting also when Vikas delivered the plenary. Few speakers are allowed in the plenary meeting of the ACR. Only 5 to 6 outstanding contributors, and it was heartening for us because as Asian, if you try to speak in American crowds, things are taken with a pinch of salt. So both his, I think you had both in the plenary, this one and the previous one also.
No, I was in France at that time. Shinoy presented
Shinoy
that.
presented, yes. So we were all very excited that, in fact, our voices could be heard there. It came out in the daily press also. There was a press briefing.
Yeah.
You had a press conference or something like that. So then, of course, tadalafil has been used extensively. But I still feel it's a very challenging disease, despite the drugs that we have, including the scleroderma lung trial, tadalafil. There is probably the window of opportunity is not available to us. By the time the patients have symptoms, they have progressed well in advance, and we need to kind of relook as positioning of these drugs in the care of the patients. It's a very challenging situation. It's only because courage that he manages scleroderma patients. It's a very trying experience. Earlier we used to give cyclophosphamide, they would have lung infections, and I think we still have to look at the most deadly cell, that is the fibroblast. It's a very quiet cell, but once it gets activated, try producing all these fibrogenic proteins, things become very difficult. Probably all of you are aware, all fibrotic conditions of the body, not only of the skin, the kidneys, the liver, we don't have a good drug to arrest fibrosis. I mean, fibrosis is intimately connected with inflammation, but sometimes the fibrosis takes over, and then it's almost like a neoplastic process. I don't have an answer because it's a very, very difficult disease, very, very challenging. If you try to block one pathway, the other pathway starts getting upregulated. So we have to hear more from Vikas in next year. What is new?
Plenty of new things to come, sir. Yeah. Thank you.
I think when we formulated this academics, there was a skepticism in mind that are we going overboard, how our audience is going to listen to some of these basic stuffs. But this is really overwhelming actually to see the whole crowd is full during 2 o'clock, during lunch time. So my sincere request to everybody, I'll not come between your lunch and you, but we are 3 sessions late, so we have to come back in half an hour so that our other speakers can give you more of academics, and I think this all you will enjoy. So this is a break for lunch, but half an hour lunch. Thank you. Oh, sorry. So before that, I want to have felicitation. Sir. So the esteemed chairpersons to felicitate Professor Vikas Agrawal, sir. And I request Vikas sir to And those who are having their posters, please can stand there with your posters because our judges will come to you for scoring. And Dr. Satish Pradhan sir, and Dr. Bharti Sahu, and Dr. Manas Puan, all will now go to judge the posters.
Recording stopped.
So welcome back after the launch session. I request everybody, if the poster judgment is over, everybody may have a seat. We are going to start because we are already late. So I hope you all have enjoyed the launch, and we have now many good academic sessions are waiting for us. So for the next session, which is dermatology clues to the rheumatological diseases. So I'll first try to invite our chairpersons, Professor Ambika Mahanti sir. Sir, please. Sir was our actually chief guest, but due to some official duties, sir couldn't join us in the morning. So we are all here. Thank you. Very thankful. And Professor Dr. Debasmita Behra ma'am, and Associate Professor Dr. Binodini Behra ma'am. Please.
Good afternoon, everybody. Now the session starts with Professor Dr. Sudeep Kumar Ghosh, Professor and Head of the Department Dermatology, RG Medical College and Hospital, Kolkata. Sir, please. Sir will talk on the dermatological clues to the rheumatological disease. Sir, please.
May I start? So, as you all know that rheumatological disorders involve almost every organ system of our body, and their diagnosis often poses real challenge to the treating clinician because of their diverse and at times occult clinical presentations. On the other hand, skin is the window of our body, and an experienced clinician can see the internal organs through this window. So, dermatological science often indicates underlying rheumatological disorders. Respected chairpersons, my respected teachers and dear colleagues, today my topic of discussion is dermatological clues to rheumatologic disorders. And I have no conflict of interest. And the objective of the present session would be to provide a comprehensive idea how skin science help to make a diagnosis of rheumatologic disorder through a problem-based approach. Now, at the outset, let me clarify what do we mean by the term rheumatology in this session. By the term rheumatology, we mean disorder is a non-specific term for medical problems affecting the joints and connective tissues. Now coming to the first set of problem, here I will present a set of cases where the patients are young male with some skin lesions, having polyarthritis or arthalgia, which are acute onset, symmetrical and additive in nature, The patients were febrile. Systemic examination is more or less within normal limit. Rheumatoid factor was positive in each and every case, and routine laboratory investigation, including biochemical panels, they are more or less normal. So this is my first patient, a 32-year-old man presented with acute onset polyarthritis involving both upper limb and lower limb. It was symmetrical, additive type, patient was febrile, rheumatoid factor was positive, laboratory investigation was more or less within normal limit, raised DSR was evident, X-ray shows synovial swelling. The patient was treated with methotrexate, hydroxychloroquine and NSAIDs, but there was no response. Now, what was the initial problem? The treating clinician forget to open the clothes and examine the patient properly. So you can appreciate there are multiple lesions. This is known as classical inverted social lesion of mid-borderline leprosy. The patient was actually in type 1 reaction of leprosy. So remember that type 1 lepra reaction or even type 2 lepra reaction can present with joint pain and tenosynovitis. So the take-home message is that leprosy can present as some arthritic symptoms because at the setting of lepra reaction, which means the appearance of signs of acute inflammation in the pre-existing cases of leprosy, presence of tenosynovitis, sometimes charcoid arthropathy, and sometimes they may present as chronic arthritis. Coming to the second patient, a 24-year-old man presented with acute onset polyarthritis involving predominantly the small joints and a few large joints. It was symmetrical in nature, preceded by a high-grade fever and morbilliform rash, as evident in this picture. The patient had morbilliform rash and some arthritis, which was persistent later on. Rheumatoid factor was weakly positive. Laboratory investigation was more or less non-contributory, and X-ray shows no erosion. The patient had morbilliform eruption. Have a close look at the lesion. Actually, the patient had chikungunya fever. So remember that arthropathy associated with several cutaneous rash can be seen in the setting of chikungunya fever. There may be morbilliform eruption, the characteristic aphthous-like lesion, some vesicular lesion. So this is my third case, a 32-year-old man, acute onset polyarthritis. It is quite obvious, diagnosis is quite obvious to my dermatologist friend. The knee, ankle, shoulder joint, wrist joint was involved. The patient also had tenosynovitis. There was enlarged epitrochlear lymph node. Rheumatoid factor was positive. X-ray shows no erosion. Routine lab test was normal. The patient was treated with NSAID, but without any response. Now, this is a very characteristic lesion. And what we need to do, we have to press the lesion with a pinhead. The lesions are usually excruciatingly painful. This is known as Ollendorff sign. This is very classical of secondary syphilis. So remember that syphilitic arthritis is a very important entity. It may be seen in the setting of condyloma lata or even the other lesions of secondary syphilis. So tenosynovitis is a rare manifestation of secondary syphilis that if diagnosed early, the condition is totally reversible. So in this group of patients, all are male patient, acute onset symmetrical polyarthritis. Patients were initially febrile. Systemic examination was more or less within normal limit. Rheumatoid factor was positive. Routine lab was non-contributory. But the cases were diagnosed based on the skin signs. Coming to the second set of patients. In this group, I will present a set of patients who had fever, skin lesions, polyarthalgia or back pain. Coming to the first patient, a young child presented with polyarthalgia, which was acute onset, symmetrical. The patient was febrile, systemic examination was within normal limit, and there are some non-follicular pustular lesion in the background of erythema. So this lesion, have a close look. There are multiple extrafollicular pustular lesion in the background of erythema. This is very classical of what is known as acute generalized exanthematous pustulosis, that is very classical of some drug reaction. Particularly beta-lactam antibiotic, macrolide antibiotic can produce such type of lesion. Another patient, a 48-year-old male, presented with polyarthritis, acute onset symmetrical, patient was febrile, systemic examination within normal limit. There are generalized pustular lesion forming some lack of pus appearance at some places in the body. This is very classical of generalized pustular psoriasis. So remember that both acute generalized AGEP and both pustular psoriasis, they can present with joint symptoms. A young boy presented with sudden onset fever for last 5 days, retroorbital pain, frontal headache, back pain, myalgia. Initially the patient had some facial erythema, followed by this type of skin rash. Patient had polyarthalgia and skin rash for last 2 days. If you look carefully, there are some spared areas, some whitish areas, what is known as white islands in a sea of red. Although it is not specific, but it is a strong indicator to the underlying dengue infection, dengue viral infection. So, facial flushing, morbilliform rash, purpuric rash, oral vesicles and crusting can be seen in the setting of dengue. And particularly the mucosal involvement is much more common in dengue hemorrhagic fever or dengue shock and purpuric rash also. Another very interesting case, a 50-year-old female presented with some asymptomatic skin rash. You can appreciate there is a polycyclic outline of the skin rash. The central area is to some extent hyperpigmented, and it is progressing at one end and healing at one end. There is a history of excursion to forest 1 month ago. There is a single annular plaque on the left thigh, polycyclic bluish red elevated margin devoid of any scale. Central area is slightly hyperpigmented. We did a histopathology also, which showed dense upper dermal lymphocytic infiltrate mixed with some plasma cell. So this lesion is very classical lesion of erythema chronicum migrans in the background of Lyme's disease. So Lyme arthritis may begin from 4 days to 2 years, mean is 6 months after the appearance of the erythema migrans lesion. This is a very characteristic lesion. All of you can appreciate the underlying condition looking at the periorbital lesion. The patient had carpal tunnel syndrome as well. Patient had features of peripheral neuropathy with palpable nerves. Patient had back pain, which was persistent and worsened by movement, having some rib pain as well. Having proteinuria, ECG shows low voltage complex, hepatomegaly, low hemoglobin with very high ESR. So looking at the eye signs, that is classically known as raccoon eye, we can appreciate that the patient is having some features of primary systemic amyloidosis. Now, whenever you encounter a patient with primary systemic amyloidosis in the background of back pain, so you should rule out multiple myeloma as well, because there is an entity that is known as myeloma-associated primary systemic amyloidosis. Another patient, extremely rare, 22-year-old man having recurrent episodes of erosive arthritis, and father had similar disease. So erosive arthritis, the skin signs, what does the skin sign? This is, sorry. This is actually nodular acne, severe nodular acne, and these lesions are known as pyoderma gangrenosum. So this syndrome is known as PAPA syndrome. This is an acronym for pyogenic arthritis, pyoderma gangrenosum, and acne. A 62-year-old woman having hyperglycemia. You can also appreciate the presence of jaundice and the color of the skin. There is hypermelanosis of the skin. Initially, the arthritis involving the second and third metacarpophalangeal joint of both hands. That is a very important clue. And later on, arthritis involves knee, ankle, shoulder, and hip. The synovial fluid was non-inflammatory. Now, the patient is having jaundice, having discoloration of the skin, hyperpigmentation, having hyperglycemia. So this is known as, otherwise known as bronch diabetes or hemochromatosis. So in approximately half of the cases of hereditary hemochromatosis, presents with chronic progressive arthritis affecting the metacarpophalangeal joint. So in all these group of patients, they have similar presentation, and diagnosis was primarily indicated by characteristic skin lesions. Third group of patient, young patient having acute onset arthritis and having some genital or skin lesion. Systemic examination within normal limit and routine lab also was within normal limit. You can appreciate there is a punched out ulcer over the prepuce, oligoarthritis, right knee, left ankle, treated with antibiotic, no response. Patient also had oral ulcer and some painful nodules, erythematous painful nodule over the shins bilaterally. What is the skin lesion known as? This is erythema nodosum. And also had red eyes. So what is the diagnosis? This is the characteristic presentation of Behçet's syndrome. And this is the pathology test, which is also came to be positive. Similar presentation in a young girl. Another patient having some genital lesion, 20-year-old male, HIV positive, having initially some history of urethral discharge, asymmetrical oligoarthritis, along with low back pain, and redness of eyes, and some nail changes which mimic psoriatic nail changes. So what is this lesion known as? This is actually sarcinoid villanitis. Very good. So also patient may have some hipped up crusted psoriasiform lesion also in different parts of the body. So this was a patient of reactive arthritis. So what are the mucocutaneous manifestation of reactive arthritis? The patient may present with mucosal ulcer, keratoderma blenorogica, which is a very characteristic lesion, erythema nodosum, and sarcinoid villanitis. Another young male presented with migratory polyarthritis. Patient has a history of high-risk sexual behavior. And there was migratory polyarthritis involving wrist, elbow, ankle, and knees. History of tenosynovitis, features of tenosynovitis as well. Asymmetrical involvement of the joints. And a few pustular lesions on different parts of his body. And a few lesions were necrotic and hemorrhagic. So in the background of this purulent discharge from the urethra, what is the diagnosis? This is a case of disseminated gonococcal infection leading to arthritis. So migratory arthalgia are the most common presenting symptom in patients with disseminated gonococcal infection. And patients have generalized pustules. And some of them may be hemorrhagic, some of them may be necrotic, are the key manifestation, cutaneous manifestation of such condition. And remember that diagnosis of this disseminated gonococcal infection depends on demonstration or culture of the non-mucosal sites, like blood, like urine. Another patient present with characteristic skin lesion over the glans penis and also some moist lesion in the perianal area. This is classical lesions of condyloma lata. So secondary syphilis, as I have already mentioned previously, may present with some arthritic symptom. So in all these patient presented with some genital symptom and arthritis, and here understanding of this genital lesion often help to establish the final diagnosis. Another set of patient presenting with pain abdomen, bloody diarrhea, having some skin lesion and arthritis or arthalgia. This 28-year-old female presented with bloody diarrhea, pain abdomen, low back pain, which was insidious, having features of enthesitis, polyarthritis, which was non-erosive, involving predominantly the small joints of the hand, 1 year duration, symmetrical, with features of uveitis. So what is this skin lesion? There are some cribriform scar and progression at one end with undermined margin. So this is a classical lesion of pyoderma gangrenosum in the background of Crohn's disease. So this is a feature of enteric arthropathy. Another young boy presented with sore throat 7 days back, having pain abdomen, bloody diarrhea, polyarthralgia. So this is a tetrad of pain abdomen, bloody diarrhea, polyarthralgia, and presence of hematuria. So this is a case of IgA vasculitis, previously known as henoch-Schönlein purpura. So both the patient presented with pain abdomen, bloody diarrhea, and polyarthritis, and clean signs helped in the final diagnosis. Another group of patients, polyarthritis, respiratory symptom, and skin lesions. The patient is having redness and tenderness of pinna. There is depressed nasal bridge. Have a close look. And also, patient had history of deepness, rhinorrhea, occasional epistaxis, redness of eyes, hoarseness of voice, and non-erosive seronegative polyarthritis. So this is a typical presentation of relapsing polychondritis. Another patient presented to our chest department with history of breathlessness, which was progressive. Patient is also having polyarthritis, predominantly involving the ankle joint and knee joint, 1 year duration, occasional fever, redness of eyes. The patient was initially treated with ATD depending on the pulmonary symptoms, but there was no response. So this may be a typical presentation of sarcoidosis. So a simple skin biopsy from a brownish lesion can reveal a naked granuloma. That is the typical features of sarcoidosis. Another patient, 51-year-old male, migratory polyarthralgia, mononeuritis, vesicular breath sound with prolonged expiration. The patient was having features of bronchial asthma, palpable purpura, rhonchi, and patchy peripheral nodular pulmonary infiltrate. And what is shown here, palpable purpura which are partially blanching. So, in this background, the patient is also having peripheral eosinophilia. So, this is a classical presentation of eosinophilic granulomatosis with polyangiitis or Church-Ross syndrome. Another patient, 43-year-old woman, having frontal headache, occasional bloody nasal discharge, weight loss, symmetrical polyarthritis, cough and occasional dyspnea, pulmonary infiltrate, RBC cast in the urine. So, along with that, the patient is also having features of small vessel vasculitis. So, along with small vessel vasculitis, patient is having features of upper respiratory, lower respiratory, and renal involvement. So this was a typical presentation of granulomatous polyangiitis or Wegener's granulomatosis. So here patients with polyarthritis and skin signs helped in the final diagnosis. Another group, polyarthritis with skin nodules. So a 20-year-old female presenting with high fever, acute migratory polyarthritis of the ankle and knees, mediastinal widening on chest X-ray, suggestive of mediastinal lymphadenopathy and uveitis. So what is this? This is known as typical features of Lofgren syndrome, a variety of variant of sarcoidosis. There are some skin nodules, polyarthritis, which is recurrent, migratory, involving knee, elbow, and wrist. There are some yellowish plaque over the antecubital fossa, a nodular lesion, yellowish. So what are these? These are actually xanthoma. And this is the characteristic histopathological feature demonstrating foam cells with very high abnormal lipid profile. So hypercholesterolemia can also present with polyarthritis. Symmetrical additive polyarthritis having a nodule. So this is typical of rheumatoid arthritis. So polyarthritis with skin nodule, dermatologist can give important input to our rheumatologist colleagues. Another group, deforming polyarthropathy of the hands along with skin changes. What is this? This is very typical. The skin lesion suggests presence of psoriasis. And there are some deformity which may look like sometimes rheumatoid-like deformity, but presence of the skin lesion help to establish the diagnosis of psoriatic arthropathy. Typical nodules of rheumatoid arthritis. So rheumatoid arthritis can present with several mucocutaneous manifestations. We have published this series of 110 patients in Indian Journal of Dermatology. Several types of skin and mucous membrane manifestations can occur in the setting of rheumatoid arthritis. So there is resorption of the terminal phalanxes, hand deformity, flexion deformity, with some characteristic pigmentary changes, suggestive of systemic sclerosis. So systemic sclerosis can also present with several types of mucocutaneous manifestations. So another patient, this is the characteristic salt and pepper appearance and rheumatoid arthritis like deformity of the hands. The characteristic pinched up nose, Ingram sign was positive, fish mouth appearance. The patient had rheumatoid arthritis, systemic sclerosis overlap. And this is a very classical manifestation of diabetes mellitus that is known as prayer sign. So hand deformity with joint pain, dermatologist may give important input to a treating clinician. So arthritis can present with bloody diarrhea, rheumatoid factor positivity, renal symptom, hand deformity, genital lesion, GI symptoms, or pulmonary symptoms, where skin lesions can help to make the final diagnosis. Now, to sum up this thing, let us have an important topographical approach. Examination of the patient from head to toe often gives important clues to the diagnosis of the underlying rheumatological disorder. So over the scalp, you may get the lesions of DLE, scaly rashes of dermatomyositis, presence of Encoupe de Sabry of morphia, systemic sclerosis pigmentation. This can be seen over the scalp. Near the eye, you can get the heliotrope rash of dermatomyositis, Ingram sign, that is, there is difficulty to retract the lower eyelid in the setting of systemic sclerosis, Sitka syndrome, both primary and secondary, redness of eyes often gives important indication to underlying disorder. Near the ear, you can get the signs of Schuster sign, that is the presence of scarring lesion of your DLE in the conchal bowl, that is known as Schuster sign. Inflamed pinna can be a feature of relapsing polychondritis. In the face, you can get perirhombic syndrome, that is facial hemiatrophy, along with Encoupe de Sabry. Malar rash can be seen in the setting of systemic your SLE and also in case of dermatomyositis. Tumid DLE lesions can be seen over these areas, DLE lesion, mask-like facies or mask of facies in case of systemic sclerosis. Multiple mat-like telangiectasia can be visible in the setting of systemic sclerosis. Parotid swelling can be a feature of Sjogren. Paniculitis, any paniculitic lesion above the level of umbilicus often indicates presence of early paniculitis. Saddle nose can be a feature of relapsing polychondritis. Pinched up nose and fish mouth appearance and tobacco pouching around the mouth orifice often indicates presence of underlying systemic sclerosis. Near the neck, you can get Barnett sign. That is on extension of the neck, there is prominent platysomal band. Over the chest area, you can get the V sign, the photosensitive rash of dermatomyositis, or even in case of SLE, you can get that. Cuirass-like thickening in the setting of systemic sclerosis. Shawl sign, a classical sign, some poikilodermatous appearance over the back in the setting of dermatomyositis. You can get the SCLE rash, that is a scaly rash, which may be either psoriasiform or annular, rarely vesicular, and lesions of DLE over this area. Over the arm, you can get the sleep sign, a recently described sign of dermatomyositis, presence of some erythematous confluent macule. Paniculitis of LE, dry reverbate sign of eosinophilic fasciitis, and lesions of SCLE. You can get some nodule of rheumatoid arthritis, or even the lesions of calcinosis cutis in the setting of systemic sclerosis or dermatomyositis. In the palm, you can get Mijutanis sign, that is the flattening of the pulp. Madonna finger, that is sclerodactyly in the setting of systemic sclerosis. Stellate scar or ulceration, Raynaud's phenomenon may be a feature of systemic sclerosis and other autoimmune connective tissue disorder. Gangrenous changes, as Sir has already shown you, the gangrenous changes can occur in the setting of systemic sclerosis or even in rheumatoid arthritis. Erythema multiforme like lesion over the palm, that is otherwise known as Ravel syndrome in the setting of systemic lupus erythematosus. Mechanic sand, inverse Gotton can be seen in the setting of dermatomyositis, and several types of deformity can occur in the setting of rheumatoid arthritis or systemic sclerosis. Gotton sign, there are some papular lesion, sometimes violaceous over the knuckles, usually seen in the setting of dermatomyositis. Erythema in between the knuckles can be seen in the setting of SLE, calcinosis. Sammis sign means there is ragged cuticle in the setting of dermatomyositis, and nail-fold capillary changes are also very important. Particularly for the dermatologist, we have to see the nail-fold capillary dilatation with the help of a dermoscope. In the setting of SLE, there is dilatation and glomeruloid appearance of the capillaries. And in the setting of systemic sclerosis, MCTD, you can get capillary dropout or even capillary hemorrhage. Genital lesion, the importance we have already discussed in the setting of reactive arthritis. Holster sign is an confluent macular erythema on the lateral thigh areas in the setting of dermatomyositis. Over the knee areas, you can get the red on white appearance and Gotton sign of dermatomyositis. In the leg, you can get the features of small vessel vasculitis or medium vessel vasculitis, features of vasculopathy, ulceration, paniculitis, thrombophlebitis, DVT or erythema nodosum. On the feet, you can get the Chilbey-Nelly or even ulcers due to some autoimmune connective tissue disorder. We have to also see the oral cavity as well in the setting of autoimmune connective tissue. They give important clues, and nail signs are also very important. You may get periangular erythema, nail fold capillary changes. Ragged cuticle, we have already mentioned. Red or macrolunula may be a feature of SLE. And longitudinal ridging and inverse increased curvature can be seen in systemic sclerosis. Free edge of the nail, there may be subungual hyperkeratosis or onycholysis in several autoimmune connective tissue disorder. There may be resorption of the bone in the setting of systemic sclerosis. And pterygium inversum anguis or ventral pterygium can be seen in the setting of systemic sclerosis. Mijutanis sign is the flattening of the pulp, we have already discussed. Splinter hemorrhage can be seen in the setting of SLE or even in rheumatoid arthritis. So to conclude, cutaneous signs play a crucial role in the diagnosis of rheumatological disorders, and looking only at the cutaneous signs may help avoiding many unnecessary laboratory investigations and so-called panels. So thank you all for your patient hearing.
Hello. Thank you, Sudeep. You have mentioned so many classical cases of the systemic disease with typical and classical skin lesions. From where you can thought up the possibility there are some systemic diseases, and you have should do some groundwork to reach our diagnosis. Thank you.
You will all agree, Professor Ghosh had a masterly presentation, maybe your lifetime experiences. I'm a physician actually. I was trying to compare what is my, out of 100, how much mark I got. So any questions from the audience or an experience? Definitely, he has given all the visuals, the question, and finally he answered, of course. Any questions for Professor Ghosh? I have got one question. While sitting here, I was thinking. Usually a lymph node comes in the area of infection and the drainage. But why epitrochlear comes in syphilis?
So epitrochlear lymph node is
why it comes in syphilis?
I don't know, sir, exact reason. But epitrochlear lymph node often gives some important clues to the diagnosis of underlying. Number 1 is syphilis. Number 2 is cat scratch disease in our perspective.
The cat scratch, you got it. Area of the scratch, there is a, why in syphilis?
Don't know, sir. Just like in case of non-Hodgkin lymphoma also we can get. What is the site of the swelling? It is subcutaneous swelling. So you are mentioning that there is some spindling of the finger. So one rare presentation.
Typical to very difficult. Typical. Very typical. Classical. Yes, tuberculosis. Yes. I think Sujata, I think whatever Dr. Sudeep has discussed, the typical finding of a system gives typical skin finding, classical skin finding. But what typical, you have to, so many differential diagnoses you can think of. Even tuberculate, in tuberculate also this type of finding can possible. Okay. Is CB0 positive means it is tuberculosis.
So underlying immune suppression should be ruled out. If there is some suppuration within the skin, tuberculosis gamma can present with such lesion. There may be some abscess formation on different parts of the body, and that is usually in the context of immune suppression.
Okay. Okay, thank you. Okay, okay. Thank you.
Thank you, sir. My request our honorable chairpersons to please felicitate our speaker, honorable speaker. Thank you, sir. So may I request our honorable speaker to please felicitate our esteemed chairpersons. Thank you, sir. For the next talk, may I request Professor Dr. Binayak Dwari, Dr. Niranjan Padhi, and Dr. S.N. Swai to please chair the session.
Now the next topic will be delivered by the masterly teacher and the master of rheumatology, the dawn of rheumatology in India, produced around 70 students of DM, more than 2,050 research papers, and professor head of the department of KIMS Medical College, and ex-professor and HOD of SGPGI, where most of the rheumatologists have taken the training, and Dean of SGPGI, and also got the Appler International Recognition Award and very few people get it. And Dr. Ramnath is a very close friend of mine and he is my bosom friend. We studied MBBS and MD together. Now he's on the dais on the topic, the management of refractory cutaneous lupus erythematosus. So, Professor Ramnath to start.
Thank you, Professor Swai, for the kind introduction. It's sometimes very difficult to sustain a lively audience after lunch. But anyway, every program gets delayed. So my brief is, thank you, Jyoti, for inviting me. These days, I don't get many opportunity to speak. I am either chairing or if I am presenting, I ask my resident to make the slides for me. So none of the slides have been my making. Thanks, Prakashini, for that. Disclosure is that I have not taken any money either for my opinion that I give from any pharmaceutical company, and I have no conflict of interest while preparing or presenting this talk. We start with the first slide. How do we move? This one. The skin in lupus gives us the diagnosis. none of the other manifestation or organ system involvement can lead us to a diagnosis. So the previous speaker was very correct that when we are examining the joint, we are fortunate to have a skin lesion because the skin lesion tells us or suggests a diagnosis. Similarly, lupus we know by the skin of the patients. They are specific to lupus. Specific means they are only present in lupus and not present in any other disease. Non-specific means they can be present in other disease, yet they are also present in lupus. The latest classification says that there are 3 types of lesions. One is the acute cutaneous lupus. Many of us, their first encounter with a lupus patient could be an acute cutaneous lesion, and typically it is the malar rash. The malar rash is a giveaway diagnosis of lupus. The SCLE stands for subacute cutaneous lupus erythematous. There can be many forms. One is the annular form, one is the papulosquamous, one is the vesicobullous, and one is a toxic epidermal necrolysis. These vesicobullous and ten-like, they are relatively rare. The chronic cutaneous lupus is characterized by discoid, hypertrophic verrucous lupus erythematous, lupus profundus of paniculitis. It's a paniculitis, so it's a very thickened skin and a thickened fat. And these other lesions, like the mucosal, chilblain, and lichenoid, are also characteristic of discoid lupus. Here I want to make a remark. One can have discoid lupus with no systemic manifestation, and they can live lifelong with discoid, though that is relatively a good prognosis-wise as far as mortality, not for the functional look for the patient. The acute and subacute cutaneous lupus are usually associated with internal organ manifestation, or other organs can be involved. Discoid can have ANA positive, can have serological evidence, but it does not usually have any other manifestations, systemic organ involvement of lupus. The lupus non-specific list is quite a bit exhaustive. You can have the palpable purpura that we saw in IgA vasculitis. You can have periangular telangiectasia, but I don't want to dwell on this because they can be seen in other disease and does not provide a diagnostic clue to the patient. This is a malar rash which we were taught both in our undergraduate and postgraduate days, and it's an unmistaken diagnosis. This is not difficult. The only thing that you can see below the rash, the sparing of the nasolabial furrow. That is characteristic of lupus. If that is not spared, we bring in a diagnosis of dermatomyositis. So this is very important. Why that thing is spared? Don't ask me a question about it soon after the lecture, because I will give vague answers which will not be satisfied to you. Subacute cutaneous lupus have both features of acute lesion as well as chronic lesion. Chronic lesion, I mean scarring. The chronic cutaneous lupus lesion is a discoid lesion. Here the discoid lesion is over the nose. It can be over the ear. It can be anywhere. And this particular lady I encountered at the beginning of my training, at the beginning of my job at SGPGI. So I still have that picture of me. And throughout the 35 years of follow-up, she never had any other features suggestive of an internal organ involvement. Yet, she was so worried about this facial rash, she tried any medicine, any system of medicine, but they refuse to budge a millimeter. So that is very difficult, very challenging to treat. These are lupus non-specific class. In the first classification criteria of the American College of Rheumatology, 1987, alopecia was one of the feature or classification criteria for lupus. The subsequent criteria have removed it because alopecia can not be specific to lupus. Very often we see young girls with alopecia with ANA positive. That does not add to a diagnosis of lupus. This is alopecia totalis. The pathogenesis of cutaneous lupus is such that immunologists believe that the disease lupus starts with the skin. The entire systemic processes start with the skin. On exposure to UV radiation or some drug, in a susceptible genetic individual, there is increased cell death called apoptosis. And in lupus, the apoptosis removal is defective. That means, like we are having Swachh Divas, we are cleaning up debris. Every day, thousands of cells die in our body. But the body has mechanism to remove it without inflammation, without the macrophage getting activated. They simply take it up. Lupus, these apoptotic cells, when the nuclear debris is exteriorized, apoptosis means the cell is turned outside, the cell debris comes outside, body sees a new set of antigens which have never been encountered. So DNA, ideally our immune system is so designed, we do not produce any immune response to our own antigen. The clarification to it, any own antigen which have passed through the embryonic period. During the embryonic period, the immune system is educated. Now, if the body sees a new antigen, subsequently, body thinks that it is, the immune system thinks it is foreign. Some of these antigens, like Rho, La, which are hallmark of the serological functionality in lupus, they are exteriorized by these apoptotic bleb. That is one theory. We still believe that the disease lupus starts in the skin and then the immune system is activated or is systematized that cause all the manifestation of the disease. This is a very simplistic way of understanding. It's very complex. I have made it I made it in simple, but I and some of my colleagues who have worked enough in lupus, both in animal models, believe that it is the skin that gives the trigger. Much like in rheumatoid arthritis, you would know it is the lung that starts the disease, not the joint. The joint are bystander. The effect is in the joint, but where the disease starts, probably it is the lung. So wearing a mask could be useful, or avoiding smoking. The clinician, when he sees a patient with lupus, have to make one important observation that whether the skin manifestations are acute, subacute, or they are damaged. Earlier I told that if there is fibrosis, you had it. We don't have medication for it. It is the acute or subacute, the inflammatory stage. All our medication are to down-regulate the inflammation. This particular chart helps us to find out, to make a score out of the skin manifestation, whether it is activity or whether it is damage. If there is damage, don't bother to give steroid, mycophenolate, rituximab. It's no use at all. You might use tons of steroid. Damage is damage. It is best to accept failure. At some point of time in patient management, you raise your hand, say, "Bhai, iske liye hum aage kar nahi payenge." That is knowledge. Giving inappropriate immunosuppressive drug to, example, discoid, is professionally not appropriate. No one, I mean, you may inject steroid legionally. People have done that and get temporary happiness. But you are not making a dent. The scar that is there, that is permanent. So the approach to cutaneous lupus, you can be very aggressive, you can be very defensive. So it depends upon your luck as to when you saw the patient. The first thing first, if a rash like that is seen, is it lupus? There are very few mimics. Sometimes dermatomyositis can mimic lupus. Not that you will make a great mistake in treating. Both are treated identically. However, if the muscle weakness is not recognized and you are treating with lupus, the patient may end up having respiratory failure or pharyngeal muscle weakness, which you are treating as lupus. There the treatment varies. Leprosy, I have had painful experience when I was at AIMS in my training years. Lepromatous leprosy can mimic lupus very, very closely. So much so that my boss, my guru, Professor Malviya, he makes decision very quick. Sometimes he is so quick that you don't have time to question. And of course, those days, you can't question your teacher. So he came in the round, he said, "Bhai, isko to Dexa pulse laga do." There was one Dr. Pasricha, he names. उस समय वो pulse dexamethasone का बहुत, that was the trend. Pulse dexamethasone is cheaper than pulse methylprednisolone. 100 milligram here, Dexa would be equivalent to 1000 milligram methylpred. And Dexa is very quick. Methylprednisolone, in a corporate hospital, if you give, it's very expensive. Dexa is very quick. So I blasted the patient with dexamethasone, and dexamethasone works. It's not that the lesion also got better. All inflammatory lesion, whether it is due to leprosy or due to immune mediated, it will work. steroid will work. Steroid can take away your fever. You can be very happy that you have treated the condition. But the patient, DEXA is given every month. When the patient came before a month, she had more extensive lesion. Then we did a biopsy and found it was flooded with AB bacilli. So what I mean to say, clinical medicine is such that never become very judgmental. Means you can make a mistake even today after seeing 10,000 patients. And we do make mistake. And probably the beauty of medicine is making mistake and learning till the last moment when you see patient. Patient can teach you every day. Never become very dogmatic. You probably, those of you know Dr. Malviya, he's so charismatic. A timid boy like me would never ask a question, sir, इसके लिए कुछ अलग सोचे क्या? वो तो सवाल ही नहीं है. मतलब, even to say a good morning, you need a heart to say a good morning to Dr. Malviya. But I realized that he also did make mistakes. Wherever I have become dogmatic, emphatic, that is the beginning of error. Never be very proud enough to know that you know everything. The patient will tell you whether you are correct or not. Lupus pernio, the speaker before me, he gave a little bit more example of lupus pernio. That was the best case forward thing. Lupus pernio that we have seen are lesser lesion than that. Psoriasis can confuse lupus also. And these days, these ANA tests have become so positive friendly that any person whom you order ANA in a suspect lesion, it will be ANA positive. God only knows what is the end limit of this. We can know inflation can go up to 100%, 120, but there will be no end to ANA positive result. Your clinical science will hit a blow when you find a 10-year-old girl who is not doing well in school, performed poorly in the exam, and the ANA becomes positive, and be treated for lupus to improve the performance at school. So all of us are very likely to encounter these dangerous lab results. I am a lab person myself for some part of the life. I know how elaborative lab result can be. CLA, subacute cutaneous lupus, is amenable to treatment. The only mistake I have done in a subacute cutaneous lupus, this patient was coming regularly. He was responsive to steroid and hydroxychloroquine. Suddenly, one day in a visit in Lucknow, the patient died on the road. He was complaining of some pain. Subacute cutaneous lupus have a very strong association with an antibody called antibody to Rho and La. Mind you, this can be a lesson for you. Antibody to Rho can have cardiac conduction abnormality, not only in pregnant, when the pregnant baby is there, but also in adulthood. Because Rho antigen and La antigen are expressed well in the conduction tissues. This lady always had antibody to Rho positive, and I was going by the skin. You know, the dermatologists are very happy doctors. Because the skin lesions get better, the dermatologist happy, no worries. They don't bring worry to their family at home. The dermatologists are a class apart. It is the physician who can bring worry to your home because the patient can bite you at a wrong time. And that day, her husband was in the secretary, and I was there in UP. You know how UP can be very challenging area to practice and all. Because she was 35-year-old, and only lesion she had was subacute cutaneous lupus. I knew she was serologically positive. you can have drug-induced cutaneous lupus, and the known drugs are INH, procainamide, and it can be very satisfying. If you remove the offending drug, the lesions get better. There are a list of other 8 drugs. Any of the students who are in the back, they can be questioned about it, but they are only asked in the exam. In real life, you don't meet these drugs. And aggressive cutaneous lupus. These are the list of drugs. Biopsy is not indicated generally because we have excellent serology now. However, if the lesions are not responding to the standard care drug, one can do a biopsy, because skin biopsy is not difficult to do. And the standard, these are the standard histology. And if you do an immunohistological stain, you can see the band at the derma-epidermal junction. That is the site where the lesion starts, where the disease starts. Oh, I thought I will share this picture. This is a patient who had a top panel is that of a scarring alopecia. The bottom is an aggressive lesion. It's very easy to know that you be aggressive in the bottom panel patient, not be very aggressive with the top panel. This is a publication by Prasant, who gave, you see the lady on the top, who gave tofacitinib. Tofacitinib is not the standard care drug, but he had failed to all patients, and I was amazed to see this picture of tofacitinib. See, this is, these are predominant damaged lesions, and there is very limited role of any immunotoxic drug, immunocyte. Don't be very aggressive. There is, you do little clinical advantage. We have now the standard guidelines, the EULAR guidelines, which has come recently, and topical therapy are the first-line therapy for local lesions, topical glucocorticoid, calcineurin inhibitors, these are the strength, and topical retinoid. We advised all to use sunscreen, antimalarials, topical or corticosteroid, methotrexate, mycophenolate, rituximab, belimumab, which is not available, JAK inhibitors, azathioprine, and dapsone. Somehow, in my own hand, I've had not so good experience with dapsone because some or the other side effect I encountered. This is the standard. On the left side, you have the local disease and severe and widespread skin manifestation. We start with steroid and cytotoxic drug for severe disease, whereas for local disease, topical therapy, hydroxychloroquine. And if it is unresponsive, we add methotrexate. If it is not responsive, then add dapsone, or we add MMF. MMF is more expensive. For some reason, when you stop the treatment, the lesions, they come back. So how long to treat is difficult to say, but we generally try to avoid high-dose systemic steroid. Something more than 20 milligram is not advocated because of the other side effects of steroid. But the EULAR endorsed this. These are the medicine not to be given. One is anti-TNF, interferon alpha, leflunomide, danazol, and extracorporeal photopheresis. However, there is, before this recommendation, this is a trial of anti-interferon or anifrolumab in active SLE with good result. However, this is not available in our country. The CLASI scores have had a definite improvement. So the new recommendations that have come in 2023 are very similar. The level of evidence for methotrexate is 1B, MMF is 4, anifrolumab is now 1A, and belimumab is, of course, is advocated. Belimumab is more for cutaneous lupus rather than for lupus nephritis. We have other experimental therapy, IVIG, fumaric acid, sifralimumab, and lanraplenib. We hope that cutaneous lupus management is a challenge, particularly the subacute, and the acute is easier to handle. The subacute or recurrent cutaneous lupus is immensely challenging because you remember the age group. It is young female who are not yet married, and face is the thing. If you give steroid, they will go down, the steroid side effects will come, and the drugs are to be given for a long period of time. This becomes a lot of psychological stress on the patient and, of course, the dermatologist or the internist who is handling. The dermatologists are better geared to look at many lesions. They are not so much disturbed as we are. So they have a good night's sleep. The issues with refractory cutaneous, whatever studies we have done with lupus, the poor functional quality is because of the facial disfigurement and alopecia. They can afford to lose their money, but they cannot afford to lose their hair. That is very devastating. The CLASI activity and damage score, and it may herald a major organ flare in case of a systemic lupus. So take-home message is rule out lupus, sunscreen, steroid, hydroxychloroquine, add one drug after the other, and most important, to be patient in this setting. The physician has to have a lot of patience, and counseling has to be very enduring. Thank you.
Thank you, sir, for your nice presentation, and thank you also for sharing your knowledge. Have you used that newly from the belimumab? Have you used?
No.
You have not used?
No, I have not.
So
I have neither used it as part of the drug trial, nor it is available in India. I have not used it.
In particularly, another question, childbearing age group, newly married couple, suffering from SLE and not responding to the normal standard treatment. Do you use any tofacitinib?
I have not used myself, but if they are refractory to methotrexate, mycophenolate, or tacrolimus, you can use it. But it's not an approved indication by the DCGI. But who in our country follows the what is DCGI recommendation? My painful experience is those are DCGI, but well, if you encounter a legal practitioner or because face a challenge with tofacitinib, then you will have difficulty to explain why we did it. I would recommend in the case sheet or in the record, you take a patient informed consent before prescribing tofacitinib. tofacitinib is not approved for use in such setting.
In childbearing age group, sir?
No, no problem. No problem with childbearing problem, but if you have used it and the child is have an error, then you had it. Because it is very difficult to prove that tofacitinib has not caused it. The lawyer will not take your side. If there is a problem, you had it. As long as there is no problem, use it. But this is not an approved use. I am saying that because I have faced it. I have faced it, I am saying it. As long as things are going fine, doctor is God. If there is a problem, your position overnight will be anyone, not even an average normal, maybe you will be branded as a demon. It's very difficult to prove that a particular drug has not caused the side effect. But if you take a patient counseling in PGI, we used to do it. Our ethics committee said in exceptional situation, you give all the information to the patient, take a consent and give the drug.
Thank you, Professor Ramnath, for your eloquent and excellent presentation and the masterly talk. Thank you again.
Sorry. दोनों प्राइज दो था.
Sir, I'll request our chairperson to felicitate sir.
Okay, so the prize distribution is going on. I have just one announcement. So next Sunday at IM House, the API City chapter again is going to the annual academic meet. So I invite all of you to be there and next Sunday. That is from 9 a.m. to 5 p.m. So again, this is under the API City chapter Bhubaneswar. So please join with us next Sunday.
Thank you so much, sir, for the wonderful talk. May I now request Professor Dr. Chandan Das, Professor Dr. Shrikant Dhar, and Dr. Nihar Sahu to kindly grace the dais for the next talk.
Speaker. Good afternoon, everyone, and we'll go to the next session. I think the session is about vaccines. You know, this century is turning out to be a century of viruses. So the speaker will speak about the hospital-zoster vaccination. Precisely, the talk is challenges and opportunities and challenges of hospital-zoster vaccination. For that, the speaker will be Professor Dr. Bikas Ranjan Kar. He is Professor of and Head of the Department of Skin and VD, IMS and Son Hospital, Bhubaneswar.
It's not working. The pointer is not working. Can someone help? No. Pointer का slide change. So good afternoon, all of you. So hospital-zoster vaccination, I think this is the app platform for the vaccine to be discussed because almost all of us are using day in, day out immunosuppressives. So as a part of prophylaxis, whether we should use it or not, and what are the latest recommendations that we will discuss. No, it's not working. So I have a disclaimer to make. So this session is sponsored by GSK. I'm on the board of GSK as external advisor. So we'll cover the topic under these headings. As you all know, herpes zoster is not the primary disease. What we see in childhood as varicella later on comes back in life after a phase of latency as herpes zoster. So predominantly we see cases of varicella in childhood, and the natural course has got certain phases. If you see, the prodromal phase typically lasts from days to weeks, during which you have typical viral prodromic features. Then the patient enters a phase of acute phase when the typical dermatomal, vesicular, painful rash, unilateral rash develops, and that makes it unique. Then few patients enter the subacute phase. Very few patients out of that, various studies mention 5 to 30%, they enter the phase of post-herpetic neuralgia, which is a very painful condition. So this is typically defined as persistence of pain beyond 90 days of the appearance of the rash. So if you look into overall rate of herpes zoster, this is 3 to 5 per 1,000 person years. What is more important is this: the incidence keeps as we pass every decade, the incidence increases. Indian data says that above 50 years of age, there are plenty of patients who suffer from herpes zoster, out of which the thoracic dermatome is predominantly involved, and almost half of the patients, they land up in post-herpetic neuralgia. So this is very important because this is done across countries, where they found that once a person crosses 50, probably because of the immune senescence, there is an increasing trend of getting herpes zoster, and this could be the reason why this is being recognized at the correct age when the vaccine should be introduced. If you look into the burden and the comorbidities, then it is seen that there are the associated comorbidities. If you see, then trauma, psychological stress, COPD, cardiovascular disease, everything is associated with increased risk of herpes zoster. Among the immunocompromised patients, hematopoietic stem cell transplant category, they have the maximum chance of getting herpes zoster, of course followed by other malignancies and people with various rheumatological conditions. What is more disappointing is we do not have a proper treatment for herpes zoster that would prevent the complications. As of now, what we use is acyclovir or valacyclovir, which is known to decrease the viral spread because it diminishes the viral shedding. So, but it has got very minimal impact on the complications. That is, for us, practically the most important complication is post-herpetic neuralgia. So probably we are not dealing with post-herpetic neuralgia in a lesser number by using antiviral drugs. We do resort to drugs like TCAs, opioids, or some other form of analgesics. Or sometimes we intervene with various modified nerve blocks, but again the patient satisfaction is very low. So one study says that very minimal number of patients are satisfied with the therapies currently available for herpes zoster. So these are the complications. If you see, we most of the time discuss as dermatologists the dermatological complications, but there are other dreaded complications as well. If you see, the cardiovascular complications are there. There are set of ocular complications in the form of keratitis, scleritis, uveitis, even acute retinal necrosis. Set of post-herpetic neuralgia again is one of the most common complications discussed, and it is very disabling. there are a set of neurological complications, though it is very rare. And we have individual dermatomal secondary infection and fibrosis related complications. So on the pain scale, if you do, herpes zoster pain is probably placed above the labor pain. This is as per the McGill pain questionnaire. So that means it is very severe grade. If you ask a patient what was the pain like, they will probably not in a position to describe the type of pain. Some say it is lancinating, some say it's burning, some say it's a electric current type of pain. But exactly it's very difficult. Only one thing they usually localize is the unilateral pain that corresponds to the site of the vesicular rash that appeared. And during the PHN phase, it scores above various rheumatological pain and chronic cancer pain. So the pain has very depressing effect on the quality of life. In fact, almost all the aspects of quality of life, they are getting affected because of the pain and rash. There is another entity called as disseminated herpes zoster, where we have more than 20 vesicles outside the primary dermatome or more than 3 dermatomes getting involved. The severity of the disease is little more, the chances of mortality is little more, and the complications tend to be little more. As far as various autoimmune or rheumatic diseases are concerned, we have been, it's a double-edged sword kind of thing. The patients, there is already a background immune dysregulation. On top of that, we are putting them on various immunosuppressives. So they are the people, they should be more closely scrutinized or followed up regarding the development of herpes zoster. And as of now, we do not have very robust data which supports, or there are not many guidelines which support the use of vaccines. Stop. Okay. So in context of rheumatoid arthritis, I think this slide was discussed, and this is very important in today's scenario. If you see, compare with monoclonal antibodies, tofacitinib users, they have more incidence of herpes zoster. And tofacitinib, I'm sure everybody is using, whoever is present here, they are all using tofacitinib. Though there is not a single indication for a dermatologist which is approved by FDA to use tofacitinib, but we use as second-line drug or off-label drugs. So we should be aware of this thing. For SLE, if you see, the incidence of herpes zoster increases with age and with the duration of the disease. Again, the complication is very disabling. The Euler recommendations say that herpes zoster vaccination may be considered in high-risk patients. This means probably the patients who are put on immunosuppressives or those who have immune dysregulations. So the ACR 22 guideline says that people who are more than 18 years and they are having various rheumatological manifestations, probably they should be also be treated with, or they should be also given doses of herpes zoster vaccine once they cross 18 years of age. So this vaccine is predominantly composed of two parts. One is the glycopeptide E protein, glycoprotein E, and the other one is the adjuvant. The whole purpose of the adjuvant is to increase the immunogenicity. As you can see from this graph, the immunogenicity increases and the immune response is more persistent because of the use of the adjuvant. There are many vaccines in market which do not use adjuvants, but this is the major advantage of using a adjuvant in this case. There are two major trials, JO 50 and JO 70, and they are all regarding the use and the preventing capacity of herpes zoster vaccine called as Shingrix. The trial emphasizes the preventive efficacy of the vaccine in people who are above 50 years and above 70 years. So if you can see, the more than 50 years, up to 70 years, the prevention capacity is almost touching 97%, which is quite encouraging. And beyond that, there is a slight decline in the preventive capacity, but it is still encouraging beyond 91%. So this preventing capacity also goes into various aspects of the complications of herpes zoster in the form of post-herpetic neuralgia and other herpes-related complications, where it scores almost around 90%. So people who have potential immune-mediated diseases, there is also a prevention close to 90% in almost all of them. If you see in the trial data, the frequency of side effects and potentially fatal side effects, they were in the range of 14.6%, but in the placebo group, it was in the range of 11.7%, which was not statistically significant. So was the list of fatal side effects, which was comparable. In the long-term follow-up data, they have found that the vaccine prevents herpes zoster in a range of 10 years in more than 80% of patients. This is quite encouraging. In contrast to Zostavax, that is the only other vaccine which is available, which was available, no more available in US also. So there the preventing capacity was in the tune of 50%, 50 to 60%. And that also the duration, as the vaccine duration is beyond 4 years, the preventing capacity goes down. So various adverse effects were reported, local in the form of pain, redness and swelling. Typically they last for 2 to 3 days. Whereas systemic, common one is myalgia, headache, fatigue, fever, and sometimes loose motion. So they are all reported, but the good part of it is they usually persist for 1 or 2 days. So patients should be counseled on that before we vaccinate the patient. These are the recommendations of various global bodies, CDC, ACIP. Everybody recommends that once a person is above 50 years of age, they should be offered this vaccine, because this adult vaccine and adult vaccination is in infancy in our place, so we have to probably promote proactively. So coming to various opportunities, as the title of the talk says, whatever positive points we have discussed, the efficacy, the preventing capacity or the preventing ability of the vaccine, they are all the opportunities. So out of the trial, there is data which also stamps the efficacy of the vaccine itself, beyond the trial data. So we have various journals which again substantiate the fact that the vaccine is able to prevent herpes zoster in majority, as well as prevent herpes zoster ophthalmicus, which is a dreaded complication. In American Heart Association, there is a publication which says that Zostavax users, they had 16% less mortality compared to non-vaccinated people. And they concluded that if the Zostavax is given now Zostavax is stopped. So now they say that if it is Shingrix, which is the live attenuated vaccine and the preventability is much higher, probably the cardiac protection will be much higher. There is no data on that though. Coming to challenges, as I told, adult vaccination is a big challenge and it's not very widely accepted in India. So we have vaccine hesitancy as the biggest challenge. So probably we have to promote as health workers proactively. And now that we know that patients who are at least either the immune system is senescent, that is beyond 50, or people who are on various immunosuppressives, because of that, at least they are the target group for promotion of this herpes zoster vaccine. There are certain side effects which are reported and they are they are the deal breakers kind of thing. So we have reactivation of herpes zoster keratitis, we have Guillain-Barré syndrome in various forms which are reported in literature. So these things need to be counseled, because the trial data says that there were only 3 cases of GBS reported in the trial, and that was at par with the compared control population. But again, if you are counseling a patient and giving vaccine and the patient develops GBS, the patient is after you throughout rest of your life. So probably we need to take a call on that. There are plenty of reports of various autoimmune blistering diseases following the vaccination, but this is not the only vaccination which is doing it. We have a lot of vaccinations which are reported to cause especially bullous pemphigoid-like eruptions or linear IgA disease-like eruptions or simple fixed drug eruptions. So probably, and on top of that, the recipients of this vaccine, they are all in the older age group where bullous pemphigoid is pretty more common. So probably that is a difficult thing to digest. So these are the pros and cons, and now as a user, you need to decide which way you want to go. I think the preventing capacity is much better compared to the older version that was the live attenuated vaccine, that was Zostavax. So maybe at least the target population should be encouraged to take this. Thank you.
Thank you, Speaker Sir, for your elaborate talk. Because we are running short of time, we will not take any questions. You can ask after the session is over.
Sure.
So now I request the chairpersons to felicitate Professor Dr. Vikas Kaur sir. And then I'll request Professor Vikas sir to felicitate our esteemed panelists. So now I think we are moving to the most interesting session, because till now, whatever we are having actually, these are mainly lectures, but now the day-to-day use things that we have to use in our practice. So my sincere request to the students, to the physicians and clinicians, this session is going to be very interesting and very, very relevant. Know our drugs better. I'll please arrange. So while we arrange the chairs for the panelists, we have our esteemed panelists. So we have arranged this session as our moderator. Please give a big hand for Dr. Ranjan Gupta, who is an associate professor in AIIMS, New Delhi. Also happens to my batchmate at SGPGI. Then the moderators, three from rheumatology side, Dr. Argo Chattopadhyay from Calcutta, Dr. Parthojit Das from Calcutta, and Dr. Ankit Patwari from Guwahati. And we have three dermatology colleagues, Dr. Bhavani Singh, Dr. Vishwanath Behra from AIIMS, and Dr. Dipti Biswai from Cuttack. So I request all the panelists to come over the dais, and Dr. Ranjan, this is all yours. You can start.
So thank you, Dr. Jyoti. So to start with, we have, as Dr. Jyoti has told, we have 3 rheumatologists and 3 dermatologists. And this is basically going to be an interactive session where we are going to ask the preferences about drugs and what the indications are and how they use from both the specialty people. So I have with me, I have the pleasure of having with Dr. Arghya, Dr. Parthojit, and Dr. Ankit Patwari as the rheumatologists. And we have, so we have Dr. Biswanath, Dr. Bhavani, and Dr. Dipti Ranjan as dermatologists with us. So, may I also have, so yeah. So before I proceed with the questions, and yeah, so when this is a long time ago, almost 10 years back, a photograph at Jipmer at Dr. Mishra sir's house on the occasion of Holi, and it brings back some wonderful memories that me, Jyoti, and another colleague, Dr. Sajan, had, and during the Holi season, like during the festival of Holi, and this photograph was taken, and you can have some more familiar cases, from familiar faces of Dr. Pradeep and others. So I would start with first question with Dr. Arghya. And Dr. Arghya, could you please let us know what is the usual dose of methotrexate that a rheumatologist would like to start in patients with the polymyositis or say dermatomyositis, lupus or psoriatic, and what is the maximum dose?
So like starting dose of methotrexate practically don't depend on the disease. It depends on the disease severity. And for all practical clinical purpose, we can divide our patients in 4 major groups, like adult patients with normal renal function. So in that situation, our usual starting dose is 15 milligram single dose per week. So if there is a renal impairment, then there has to be dose reduction, especially if GFR is less than 13, then 30, then there should be, preferably it is avoided, it's contraindicated methotrexate. Third population will be an elderly population, which is a geriatric population. So what we call someone more than 65 years. So in that situation, as with aging process, there's lots of pharmacokinetic changes. We need to start in a different doses because there are higher chances of toxicity. So in that situation, adult population with normal renal function, we usually starts from 5 to 7.5 depending on the severity, and gradually scale up the doses, and we can increase up to, for normal adult population with normal renal function, 25 milligram per week, whereas in geriatric population we go up to 20 milligram a week. And fourth population will be a pediatric one. So pediatric population usual dose is 0.3 to 1 milligram per kg. So again, the initial doses is a relatively lower doses, 0.3 milligram per kg per week doses. And one more important point for starting dose, anything like whenever escalating the dose beyond 15 milligram, it's better to divide the doses, because there is an almost 30% reduction in absorption if we go beyond 15 milligram at a time doses. So suppose we are planning for a 20 milligram dose, it's better to divide into 10 into 10, and that too within a 6 to 12 hours gap, not beyond that. So that is initial starting dose, normal adult with normal renal function, 15 milligram, can go up to 25 milligram a week. If there is a renal impairment, has to be dose reduction. Elderly populations, the geriatric population, 5 to 7.5 can go up to maximum 20 milligram, and pediatric 0.3 to 1 milligram. Don't even, again, that pediatric population, again, we can go up to 25 milligram per week.
Fine. Thank you, Dr. Arge. So let's have dermatologist's perspective on this. So Dr. Biswanath, what is the starting dose in dermatology, and whether you have any differences for oral and injectable dosing when you are using it in patients with psoriasis?
The initial dose is like for adult 15 milligram per kg, but as a child we use body surface area. And for elderly, it's always to look into the GFR, eGFR, rather than looking into creatine level. Even with the normal creatinine, the elderly can have significant reduction in the glomerular filtration rate. So 15 milligram start, and maximum we increase to 20. And it has been clearly shown that after 20 in psoriasis, methotrexate does not work, even if you increase the dose.
Okay. So that's new for us actually. As rheumatologists, we go up to 25. So do you monitor the toxicity the same way? Do you do the tests frequently as we recommend otherwise, say at 3 months to 4 months?
At baseline, we will look into the first is CBC, LFT, urea creatinine, and rule out tuberculosis and HIV, hepatitis B and C. Then first week, up day 6, actually we do to look into CBC. If possible, patient can afford LFT. Then every 2 weekly ideally, but not possible for many patients to come after 2 weeks. So we do baseline 1 week, then every monthly. After 3 months, it's 3 monthly afterwards.
Okay. So let's listen from Dr. Parthajit. So does giving injectable methotrexate has any additional benefits? Like Dr. Arge was telling, that is another way of increasing its efficacy. So does it work better if you are giving it in injectable form?
Yes, sir. I think what we have found is many patients who are taking oral methotrexate, they are quite intolerant. They have GI intolerance. So many patients who are shifted to subcutaneous injections, the GI intolerance part is taken care of. There are a lot of studies they have found that at the same dose, the efficacy of subcutaneous methotrexate is better than when they're taking tablet forms.
Okay, and especially in higher doses, if you are giving injectable, maybe better.
Right, and the common mechanism, maybe the absorption is much higher, the bioavailability is higher, so that really helps.
So, Dr. Bhavani, so is it the same when you are treating patients with psoriasis who have got this much of skin involvement? So, is giving methotrexate in injectable form is safe and can be given in these patients or not?
Yes. In fact, the first, as my previous colleague has answered, it is nausea is the most common complication. In some set of patients, it is so nauseating that even the sight of methotrexate, they start feeling nauseating. In those patients in particular, that is with GI intolerance, injectable methotrexate is being recommended in plaque psoriasis as well. And in addition, the advantage would be higher bioavailability. When we increase the dose to 20 milligram, I prefer a subcutaneous dose instead of splitting the dose into 10 milligram twice a day in a week. And additional advantage is in old patients, often we find the most common cause of methotrexate toxicity is popping the pill every day instead of a weekly dose. There I find asking the family members to give an injectable methotrexate in a weekly basis is better, because that particular cause of side effect is totally delta way. So that is one of the, in my personal perception, one of the common indication of injectable methotrexate.
So can it be given on the affected skin also in psoriasis? So suppose patient has got extensive psoriasis which involves the bilateral deltoid area or abdomen and the thigh. Can it still be given?
So the mechanism of methotrexate is changed. It is no more only anti-metabolite or anti-proliferative. It acts on other different pathways. So injectable methotrexate at the site has no advantage, or it doesn't do better. The same applies to topical methotrexate as well. So
what I mean to say, can it be given at the affected skin? Is that a contraindication?
Okay, sorry, I got your question wrong. No, it's always wise to give on an unaffected skin or normal skin. Push the injection at a normal skin.
Okay. So let's listen from Dr. Ankit. So do you give injectable or oral steroids also in patients who have got psoriasis with arthritis?
So steroids, it's better to avoid in psoriasis and with psoriatic arthritis. So only thing is we are very fearful of when we stop the steroids, chances of palmoplantar psoriasis can flare up. So normally we tend to avoid oral or injectable steroids. Only thing injectable we can give as laser intra-articular injections that we can, or topical steroids do use. And second thing, sometimes we do give very low dose steroids if nothing is working, if our DMARDs are not working or something, and if we are trying with NSAIDs or we are not able to give NSAIDs. In some situations like where there is liver toxicity, patient not afford biologics, we can try very short course oral steroids, but we have to stop as early as possible.
I think it is preferable to give either intra-articular or maybe intramuscular shots for one or two times, and then we can probably continue with the DMARDs. So that is what. So let's talk about giving hydroxychloroquine. So Dr. Deepti, is it given in your practice in psoriasis, and does it work?
No, actually hydroxychloroquine is not coming in the category of treatment options for psoriasis, because it is coming in the category in the options that it induces, exacerbate and also relapse of psoriasis. How it is, because it breaks the epidermis or breaks the barrier function, which in the response, physiological response, there will be repair of the barrier system. So in this manner, the psoriasis may aggravate or induce. So SCQS, no, there is no role at all. It may aggravate psoriasis.
So like a lot of prescriptions are seen where it is being prescribed, maybe by rheumatologists or by dermatologists or otherwise.
I have not prescribed, but because there are so many case reports are
so
also
as such
there.
it doesn't work and probably doesn't have an indication as psoriasis.
It is a category of antimalarial drugs. So it may induce and relapse of psoriasis.
So Dr. Argya, is it the same with rheumatologists? Do we prescribe, should we prescribe, and what is the data say? Does it say that giving hydroxychloroquine may be useful in patients with psoriasis, psoriatic arthritis?
So like this two different, like for psoriasis that madam already told, like it's absolutely contraindicated. There are some reports that for psoriatic arthritis, it can be used, but in current situation, that with the availability of the other drugs, it is always better to avoid, because it has been, even meta-analysis has shown that there is good number of patients who got a very bad flare-up after starting hydroxychloroquine for the skin part, even whose skin were quiescent for a long time. So there is a relapse of the skin if someone being treated with hydroxychloroquine for psoriatic arthritis. So it's, with the availability of other drug, it's always better to avoid something which can precipitate the other components and which can complicate the entire treatment.
Okay, so let's listen from dermatologists now. So we have talked about steroids, hydroxychloroquine. So if a patient is there with psoriasis, whose disease is not controlled with methotrexate monotherapy, what DMARDs do we have in our armamentarium to add on with methotrexate to control the skin disease?
But psoriatic arthritis with psoriasis?
Basically psoriasis. I'm talking about skin or psoriatic arthritis. So
Psoriasis,
what would you like to add to methotrexate?
So if a patient is not responding to methotrexate, then if the best thing is if we have a phototherapy. If we have whole body phototherapy, that will be best. It is safe and effective. But the problem is lot of centers don't have even whole body phototherapy. So in that case, one of the choices I use apremilast. I try and give apremilast, which is safe. But the only problem is the initial period, maybe 2 to 3 weeks, that they develop all this nausea, vomiting, headache, woolly headedness, and diarrhea. If there is no contraindication and patient is a chronic stable plaque psoriasis and not in the childbearing age group, then acetyltraline is a very good choice. And elderly is acetretin if patient can afford, because acetretin is bit costly. One capsule comes around 65 rupees. So if patient can afford, in old age, chronic plaque psoriasis not responding to methotrexate, there is no associated arthritis, then acetretin would be a very good option. And nothing works, then we have looked into the other biologicals then.
So before that, is there any place for giving cyclosporin or tacrolimus orally for treating skin disease in psoriasis?
Orally, we don't give tacrolimus psoriasis. So cyclosporin, personally, I use cyclosporin only when there is emergency. That is when the patient is unstable psoriasis. The patient had psoriasis now, that in verge of going to either erythrodermic psoriasis or pustular psoriasis, or patient come with the pustular psoriasis or erythrodermic psoriasis. These are the three conditions I use cyclosporin. In extremely rare condition, when we have to need little rapid relief, but that is personal choice. But this is the three indication where I use or is indicated in psoriasis without arthritis.
Okay. So Dr. Parthajit, so similarly, like he's talking about biologics. So now, is there any preference of giving anti-TNF over anti-IL-17 or vice versa in patients who have psoriatic arthritis? Or both can be used interchangeably, or say probably, there is no preference. So what is the literature say? What is the evidence?
Okay, so I think as we all know, and Rohini has already pointed out earlier this morning, there are really 6 domains. If I go by domains, for the skin, there is no obvious difference between anti-TNF and anti-IL-17 blockers. So as for spine and joints, there is no clinical obvious difference. But for the eyes, I think anti-TNF scores much better. The evidence is more stronger. If you look at the nails, enthesitis, dactylitis, again, there is no obvious difference between both these drugs. But if there is a risk of infection is very high, suppose tuberculosis or any systemic infections, so IL-17 like secukinumab is less immunosuppressive, so that stands out. So even previous studies have shown there is no reported case of tuberculosis, so which really helps when you have a high risk of tuberculosis or high risk of infection, that's it. But there are some studies like Spirit studies, Spirit P1 and P2 studies, which have studied execunuzumab and adalimumab. And they have shown execunuzumab is probably better than adalimumab in both, joints and skin. So the PASI score and ACR score is much better in those, in execunuzumab group.
So in your practice, what is the determining factor when a patient comes and who is ready for biologics? What do you choose and why? Either anti-TNF or IL-17, anti-IL-17. So what is your choice?
It's basically a matter of discussion with the patients. So you give them discuss side effects as well. And many a times when the risk of infection is not that high, then anti-TNF is a better choice, especially in peripheries where you get the drugs easily. But if the risk of infection is high, then probably secukinumab is a better choice for us.
So, Dr. Bhavani, is it the same for psoriasis? Do you have any preference of anti-IL-17 versus anti-TNF in skin disease, or is it probably, you can choose either of them?
As far as chronic plaque psoriasis is concerned, from dermatology aspect, I feel we do choose IL-17 over anti-TNF alpha antagonist, because PASI 90 achievement or PASI 100 is faster with IL-17 inhibitors than anti-TNF alphas. And more so in our country, the chance of TB reactivation is always there with patients. So it is, as already pointed by Dr. Partha, that the chance of TB reactivation with IL-17 will be much less. And in addition, we have also seen drug failure. Initially, we were giving a lot of adalimumabs. So drug failure is, and now we've shifted to secukinumab, or off late with ixekizumab. Drug failure is more with IL-17 inhibitors. This is my perception, because adalimumab patients tend to get fatigued. The disease response tends to be plateau after some time. That may be possibly due to ADA, that we do not know. So I prefer IL-17 over anti-TNF alpha antagonists.
So, Dr. Ankit, so when you are choosing anti-TNFs, what is the choice like? So, is it that you always have one of the anti-TNFs used first, and then you go to say infliximab or adalimumab, or you can use either of them and they all work better? Is there any kind of contraindications when you are using in patients with psoriatic arthritis?
anti-TNF, we can either use adalimumab or infliximab. So efficacy-wise, both are equal. Only thing is the route of administration is different. In infliximab, we have to admit the patient and give or give in a daycare setting. Adalimumab, patient can take it home. So efficacy-wise, there is no such major problem. We can
So all can be used equally well.
So we practice, personally we give more of adalimumab, which is easy to administer also. And the patient can take this anti-TNF at home also.
So let's look at some of the resistant problems. So Dr. Deepti, patients have nail changes. When you are giving these biologics, what is the response to these nail changes? Does it work or they stay permanently?
Mostly we are prescribing biologics, or we had an option of biologics when disease is severe, disease is there. So nail psoriasis is a risk factor. So it's a severity, it shows that this is the signature sign, you may say that this disease is severe. So it works very good. But in mild nail involvement, like if less than 3 nails are involved, as literature. So you can use the topical treatment, like there are 2 kinds of involvement, as you know, nail blade involvement and nail matrix involvement. But the mild cases, the topical involvement is most, topical preparations will work only in the nail bed psoriatic changes. So in biologics works better, good in nail, the severity is more. If you will opt for in the severe cases, but mild cases we are not using biologicals. But so here in this forum, I want to share one thing, that in mild cases we ask the patient, we should ask the patient of every psoriasis patient, so cut the nails and keep the nails short and also moisturize the nails. So by doing this circular motion, I am asking for the chronic pyorrhea patients. So also I am asking the psoriatic nail patients also, that just keeping doing like this, moisturizing the nails, it may have a moisturizing effect and may not be more psoriatic nails may not come.
So topical preparations means what? Like what do you prescribe usually?
If in topical preparation, topical steroids I prescribe, then topical tacrolimus, and intralesional methotrexate is painful, but if the lesions are thick, then we are going for the intralesional methotrexate after the dipping in water, getting the soft nails. After getting the soft nails, we can go for intralesional methotrexate.
So Dr. Arghya, when patients are being prescribed these biologics, are they equally safe during pregnancy and lactations, anti-IL-17 and anti-TNFs, or there is any problem and they cannot be given during these conditions?
So like there is some recent changes in the guidelines or recommendations. So the last year, this year only BSR came up with some changes, like TNF was not previously recommended throughout the pregnancy. So anti-TNF now you can use safely throughout the pregnancy and breastfeeding. So that is the only thing that you can continue. Regarding IL-17, it is always safe to stop at the time of conception, and it only can be used unless otherwise no other options available for during the pregnancy. So it is always better, like TNF is now clean, you can use throughout pregnancy and breastfeeding, but IL-17 preferably stop unless pushed to use and no other options remain.
So, Dr. Biswanath, when we are having patients of psoriasis who has a particular area of skin involvement, when does your choice shift from topical agents to systemic agents, be it synthetic DMARDs or be it biologics? When do you make that shift of changing from a particular agent in a particular form to systemic agents?
So it depends upon either we can measure the body surface area by palm rule 1%, or we preferably we follow the passive psoriatic area severity index. So up to 5%, as a passive 5 you use topical, 5 to 10 varies. If patient, we can try topical and there is a satisfactory response, we can continue. If passive more than 10, then definitely we look either phototherapy or systemic drugs, any of the whichever applicable to the patient.
Okay. So let's talk about other medicines, pregnancy safety. So Dr. Parthojit, patients are given hydroxychloroquine in patients who have say lupus or who have say related spectrum disorders. Now, is it safe during pregnancy and lactation? And what is the safe, if it is safe or not safe, what is the usual dose at which it can be safely given during these two during these two conditions?
As per the literature goes, I think HCQS is quite safe during pregnancy. I think there are certain diseases like SLE, which really works well with HCQS, with hydroxychloroquine. Problem is many drugs, because of lack of awareness, they stop HCQS, but problem is when the disease flares because of stoppage of disease, that's a disaster. Because that can cause a lot of complications related to pregnancy. And the usual dose, safe dose is less than 5 milligrams per kg. And if the dose is maintained, even the concerns about retinal toxicity is quite low as well. So that if the dose is maintained less than 5 milligrams, the chance of developing side effects and retinal toxicity is around 2% over 10 years. So it's quite a safe drug to be prescribed during pregnancy.
Fine. So, Dr. Bhavani, is it the same for dermatologists? You also use hydroxychloroquine very frequently. What dose do you usually prescribe?
We do not go for a per kg body weight, but at the same time just keep a watch on the higher dose, that is less than 5 milligram per kg body weight. Standard starting dose is a 200 milligram, but if there is, we monitor the effects of the drug, and at the end of say 2 months or 3 months, since it's a slow acting drug, if the response is inadequate, then you switch to 200 twice daily, 400, or just keep a watch that what should be the highest dose for patients per kg body weight. So 200 to start, 200 or 300 to start with, and then escalate the dose based on the clinical response.
Is there any practice or guidelines which say that hydroxychloroquine should be given at bedtime? Is there any sense or say science behind it, or it's not the case? So usually what I have seen is that some people prescribe it only in the night before bedtime. So is there anything like that?
I'm not aware that that's what I do as well.
Okay.
It's a photoprotectant, but we cannot really, I don't find any judicious explanation to why it should be given at night or day. But when it is given at a double dose, 200 BD, we give it in a day and night dose.
Yeah. So, Dr. Ankit, both are giving. Now, how do you monitor this toxicity of hydroxychloroquine, and how worried you should be about it when you are giving it in higher doses?
So like hydroxychloroquine, we start as 5 milligram per kg body weight, and normally what we advise patient to do a retinal at the baseline. So we do a retinal screening test.
Okay.
Especially OCT, we have to look if there's any macular involvement. There is not. If it is normal, then we can repeat the scan again after 5 years. So 5 years again, a retinal scan will be required, and thereafter we have to do yearly checkup. We have to do yearly. So every yearly.
Every yearly.
So at the start of hydroxychloroquine, we have to see. Then after 5 years, and thereafter yearly.
So for first 5 years, basically we need not examine the retina, and then if there are any problems, we can examine. Otherwise, after that, yearly we can do. And as he has told, it is quite safe. The chances of retinal toxicity is even lesser than 2 to 3%. So Dr. Deepti, let's come to lupus now. We've been discussing a lot about psoriasis. So now my question is, when a patient has got pure cutaneous lupus, patients most likely land up with dermatology. So how do you start treatment? Because that is one problem which is where we don't deal with as rheumatologists, and as Dr. Mishra also discussed today. So how do you start treatment?
Cutaneous lupus, if it comes with ACLE, that is the acute cutaneous lupus, that it has a typical morphology, just like erythematous papules and having the central necrosis. So it is mostly over the photoexposed area. So we have to go for in SLE, what are the investigations to do. But if it is localized SLE and only it is coming for the first time, we are asking, giving them, prescribing them oral corticosteroid along with some topical preparation, just like your mometazone, mid-potent steroids, low-potent steroids, seeing the severity. If the less lesions are there, we can go for low-potent steroids. If it is severity is more, then mid-potent mometazone we can give. Then oral steroids we have to give, and after coming the report, we can go for the systemic steroid, any plan of the steroid-sparing drugs like SQS. So but the central part is the sunscreen. So we have to ask the patient to keep indoor, and the sun-related activity he or she should not do. And finally, the sunscreen, how to apply, minimum 50 SPF he should apply. And the sunscreen must contain UVA and UVB, both. Okay. And if the patient is going outside regularly, then use the UV film because UVA can come through the glass. So use the UVA protective regions, and avoid to go to the equatorial regions. We should ask them. And physical sunscreen, what is that? That is the
umbrella,
full globes and wide hat. That should be. You should ask all these things. In SCLE cases, it may mostly out of SCLE and SCLE, you will find kind of lesions, psoriatic kind of scaly lesions over the photoexposed part. So those cases are going mostly to SLE. So in this case, extensive investigations we should need, and oral corticosteroid along with SQS we are starting from the day one or a starting point of the SCLE along with the photoprotection and topical preparations.
Topical preparations, fine. So Dr. Argya, these patients land up with us also as rheumatologists. So in your practice, do you give any synthetic DMARDs to treat skin disease when a patient is otherwise in remission? And if yes, so what DMARDs are usually useful?
Like for cutaneous, we often prefer using methotrexate. That works very well for the cutaneous manifestation lupus. But other than that, if it is not working, mycophenolate cyclosporinol has been reported. Even for very severe refractive cases, the uses of cyclophosphamide IVIG, that also been reported. And the new player in the market is tofacitinib. So there are case reports are coming with some good positive results of refractory cutaneous manifestations lupus responding very well to tofacitinib.
Okay. So, Dr. Biswanath, next question is to you. So, Dr. Dipti has just spoken about giving topical agents like steroids or say tacrolimus. So, the problem of having skin atrophy with these lesions is common. So, how common is it, and is there any remedy to basically minimize this issue once the patients are using these agents?
First thing that we have to look what the cutaneous lesion has patient. So whether it's acute, subacute or chronic.
Yeah.
So acute comes in a shower-like fashion very rapidly, goes up in 7 to 15 days. So in acute cutaneous LE, we don't have to do anything. We can just wait also and the skin lesion also resolve. But the whole idea is that acute cutaneous LE is most of the time associated with SLE. So there my concern is not skin, my concern is what is the system involvement. Coming to subacute cutaneous LE and DLE, these are the spectrum where the systemic involvement may or may not occur. So first I look into whether systemic involvement is there or not. If systemic involvement there, my target will be system, not the skin. Coming to scarring, subacute cutaneous LE, it takes little more longer. It takes 3 to 6 months to resolve without scarring atrophy. But the patient may have depigmentation which look like vitiligo, but that vitiligo also with time also they again repigment. But the most the problem of scarring atrophy comes with discoid lupus erythematosus. So again, if the patient has isolated discoid lupus erythematosus without any systemic involvement, the drug of choice is hydroxychloroquine and topical reagent to prevent further spreading of the lesion. So usually I prefer to give, if it is scalp lesion, intralesional triamcinolone acetonide, 10 to 20, if the skin lesion, topical. If there are so many morphological variation of discoid lupus erythematosus. So based upon, there are so many types. So based upon the type we treat. But basically, the idea is to give hydroxychloroquine and treat the lesion topically or intralesionally. But the scarring atrophy in DL is inevitable. It will going to happen. So that we cannot do anything about that.
So do you use rituximab also in these patients when the
no rituximab for
skin
SLE, no rituximab for DLE. Only indication of rituximab, only therapy resistant patient who has already received 1 to 1.5 milligram of PRED, also not responding, then we shift to methylprednisolone pulse, still patient not responding, then we think about rituximab.
Okay. So Dr. Parthajit, we as rheumatologists use a lot of rituximab in these patients. So what has been your experience when you give rituximab for say nephritis or any other indication? What happens to the skin disease usually? Does it respond? How has been your experience with it?
I think once we use rituximab, the skin really improves significantly. But I don't think, although if you Google, there are some case reports and case series where there are so rituximab has been used for refractory cutaneous lupus. But I don't think there is any studies which has solely designed to look at this condition. But I think when you treat the systemic disease, the skin also improves.
Okay. So, Dr. Bhavani, is it the same for DLE? Do you use rituximab there? Because that is the problem which is most damaging in cutaneous, in cutaneous lesions among lupus. So, do you use lupus there? And what has been your prescription or practice like when you are treating patients with DLE?
I personally do not have any experience of infusing rituximab in DLE cases, nor even SLE, because once the systemic findings overhaul, it is usually our rheumatologist colleagues who take care of the disease.
Yes.
But howsoever this question, how do we approach to a case of DLE? Anti-malarials and photoprotection. Photoprotection, as Dr. Dipti has said, in the form of physical protection, sunscreens, and as my previous colleagues have said, anti-malarials are must for all chronic cutaneous early lesions. Howsoever, as dermatologists, we focus on the morphological presentation. So DLE contrast to the idea that it always presents with a central depigmentation, scarring, and a peripheral telangiectasia. It is not that. DLE usually can also present us at the earliest stage. So our intent is to prevent the further progression of the disease so that it doesn't go to the scarring stage. So if it's limited, along with antimalarial, if it's limited, then topical steroid, topical tacrolimus, and if it's extensive, systemic steroids. If the second line drug will be methotrexate, and if the morphological presentation of DLE is a verrucous or a hyperkeratotic or a hypertrophic DLE, then retinoids are our first choice of treatment.
So you give methotrexate for even skin disease and it works?
Yeah, indeed. For SCLE and chronic cutaneous LE, we do give systemic methotrexate.
Fine. So Dr. Ankit, so let's take from here. There is a lot of fear about methotrexate causing ILD. So is there anything like that? Is it true, or is it a myth that methotrexate can cause ILD, and that is how it should not be given in patients who are prone to develop ILD, say in myositis?
So previously it was a concept that methotrexate causes ILD, and like we used to refrain who are having lung disease. But nowadays the concept is reverse. In fact, in autoimmune conditions or connective tissue disease, like we give methotrexate so that the disease will be controlled and that it prevents ILD. Only thing is we have to be careful if we give methotrexate. When we start methotrexate, sometimes there may be hypersensitive pneumonitis, and patient might have cough and some symptoms like that. That is the only thing we have to withhold methotrexate. But otherwise, long-term rheumatoids or scleroderma, we can give methotrexate. There is no contraindication that it causes ILD.
So basically, there is no fear of ILD when we are treating patients with methotrexate.
2007, it was clear cut. Most of the guidelines supported that yes, it's safe.
Yeah.
It can be given in patients who are. It can be in treatment of ILD also. It is used.
Yeah. So Dr. Deepti, another pressing problem in patients with lupus is about hair fall. So how do you treat that, and is there any severity-based guidelines? How do we measure this hair fall, whether it is low or less? Because every other lady who comes to the OPD always have a complaint of alopecia. How do we measure it?
Among the symptoms of SLE, hair fall is around 20 to 50% patients are showing hair fall. So SLE, there are different types of hair fall is there. One is SLE specific, or that's non-scarring alopecia, and scarring alopecia. So if the patient is coming with different, there are 6 to 7 types are there. Telogen effluvium, anagen effluvium, then your lupus hair, then your scarring alopecia, all these things. If the patient disease, it is associated with disease, not having any scarring kind of thing, then it will improve with the treatment with SLE. So if, but in scarring, just like cause maybe DLE or tumid or paniculitis, all these things, we have to give we have to treat very extensively, or we have to give so many drugs. We have to give some kind of mini pulse to any intralesional therapy, or you can give the minoxidil along with the treatment of SLE. But in non-scarring alopecia, we can wait for, according to the patient is individualized. If the patient is asking that, yes, I need the hair more rapidly, or I need now. So in those patients, we can give minoxidil. We can go for topical steroid and topical tacrolimus along with the conventional treatment of the SLE. Severity guideline, it is not like that.
Is there anything like that?
Yes, like you can say CLASI score is there.
Yeah.
That is the cutaneous lupus area severity index, I think. So in that category, they have done 2 category score. That is severity score, and another is your disease score. So no healthy score, activity score, and disease score. So in that category, they are keeping this non-scarring is one category, under the category of severe, and scarring in the category of non-severe. So this is only one severity index is there.
Fine. So Dr. Arga, the other problem that comes frequently to both dermatologists and rheumatologists is palpable purpura, whether it is HSP or lupus or say ANCA vasculitis. What do you prescribe to these patients? Because this is a problem that they face day to day. The moment they are walking for some time, they develop this. So what pharmacological treatment can we offer them?
So like of the 3 diseases you have mentioned, 2 are primarily primary vasculitis. So, but for all disease, it is very important to look for the other organ involvement or other systemic involvement, because ANCA vasculitis is something can be sometimes very devastating, and rarely it isolated present with only cutaneous manifestation. So one should be very prudent when dealing with an ANCA vasculitis. But if sometime a situation be like that, patient was on remission and there is an isolated flare-up of the cutaneous manifestation as in palpable purpura, then colchicine or dapsone could be an options for treating those patients. But always to look for, because there is often there's a grumbling disease and they often any point of time they can flare up with all systemic manifestations. So one should be very watchful for the other systemic manifestation, and if there is that is there, then they should act accordingly with higher dose of steroid and other immunosuppressive therapies as per the treatment protocol of SLE, HSP and ANCA vasculitis.
So, Dr. Biswanath, same way, the patient has palpable purpura, maybe because it is because of HSP, who doesn't have any systemic involvement, there's no nephritis, no abdominal pain. These patients come to you. So, as dermatologists, what do you prescribe? Do you prescribe routinely hydroxychloroquine or steroids or any other thing to prevent these palpable purpura or to treat them?
So without any system involvement, if it is SLE, so I'll look into whether patient is getting hydroxychloroquine, what is the dose. It's like recommendation is we can increase up to 6.5 milligram per kg. So that is in SLE, I try to prevent palpable purpura using SCQ. But when it comes to henox and purpura, IgA vasculitis, I preferably use dapsone. Colchicine, I am really afraid. Personally, I don't use colchicine because of so many side effects it can cause. So dapsone is a safe drug if monitored properly. So for any small vessel vasculitis without any system complication, dapsone/hydroxychloroquine.
Fine. So, Dr. Parthajit, other problem is of scleroderma. Patients have scleroderma and mostly associated with ILD. What is the role and what is the role of rituximab in such patients?
Again, like SLE, I mean, there are all the studies which has been designed to look for systemic sclerosis. When they're used systemically, the skin really improves. The modified Rodnan score has improved in most of the studies. But I think skin is quite a challenge in systemic sclerosis patient. Many a times it's quite frustrating, and it doesn't really respond well.
Yeah. Fine. So mostly you mean to say the choice remains with the cyclophosphamide followed by maybe mycophenolate and then if required rituximab.
Absolutely.
Fine. So Dr. Bhavani, similarly I would like to know, is there any role of giving rituximab in patients with scleroderma? You told you don't use it for lupus. What about scleroderma?
No.
Again,
personally, if you ask, I have never used rituximab for systemic sclerosis to address the skin findings. Howsoever, as from today's lecture in the mornings, esteemed speakers have spoken, and also I went through the evidence. It has been seen to improve the modified Rodnan score if rituximab is given in double-blind placebo-controlled trials as well. As far as I went through literature, there are 9 RCTs where they have used Ritux in scleroderma, and the endpoint of modified Rodnan score was used in 7 of them. Apart from FVC, forced vital capacity, they have also measured the modified Rodnan score. So in all, out of 7, 4 have seen a significant difference from placebo, and 3 have not seen. So based on this much evidence, the ball is in our court. But having said everything, see, addressing skin in scleroderma is a difficult job. So if this drug shows some promise, I would probably will try to induct in our therapeutic armamentarium.
But I think rheumatologist's perspective may be slightly different. What we would have seen is that if you give it in early disease, in the initial 3-4 years, it does have effect.
Yeah, basically PSS is a progressive disease. So our intent is to arrest the progression. So what we do is once we get the patient in edematous stage, that's the best thing that can happen to us. So we infuse steroids. Either in a pulse, we are more used to Dexapulse, though it is obsolete these days. But if patient comes with a edematous stage, then the steroids are our go-to drugs. Apart from cyclophosphamide, they help us, or MMF.
So again, Dr. Ankit, will come back to psoriatic arthritis. Patient who has a psoriatic arthritis is not improving with conventional DMARD. We have given methotrexate monotherapy. In your practice, do you use combination DMARDs? And if yes, what happens to the skin disease? What have you seen as rheumatologists to their skin lesions once you are using combination of conventional DMARDs?
So like psoriasis patients, psoriasis for psoriatic arthritis, who is on methotrexate monotherapy, not responding. So generally I add sulfasalazine or leflunomide. So these are the two drugs which I preferably come to use, and if in some cases I do use tofacitinib also, JAK inhibitor. So basically, it should be always not to switch but to add. So
Yeah.
methotrexate can be combined with sulfasalazine, or methotrexate can be combined with leflunomide or tofacitinib, and normally thereafter we go to biologics therapy.
So that's what probably I would have also noticed, that if we are giving a combination of even synthetic DMARD, skin lesions improve. But what is your experience, Dr. Deepti, when you are having patients with psoriasis? Do you use a combination of DMARD? Methotrexate is the foremost, but then do you use leflunomide or other the conventional
We
DMARDs?
generally you go for monotherapy of methotrexate. After if there is any improvement is there or not, after seeing this, we are adding cyclosporine. Seeing the patient's response. After that, cyclosporine, we are just keeping the dose in low dose 100 at BD. After that 100 OD. Then if after 6 weeks the methotrexate is showing its effect, so we are just maintaining with the methotrexate. If the patient is going again into flares, then we can again add the cyclosporine. Otherwise, we are adding apremilast, but it is not worked good. That molecule came, but it is not working good. So we can go for biologics, but biologics is also like that. So you can use that one, and after you individualize. So one patient may respond good to 1 and 2 year. Other patient may show response or may not show response after 1 month or 2 months after the stoppage of the dose also.
So Dr. Biswanath, next question to you as a dermatologist. We have some special questions for dermatologists. So another problem in lupus apart from hair fall and skin disease is oral ulcers. Now this is one problem that usually doesn't respond to just giving prednisolone unless until patient is also receiving cyclophosphamide or any other drug for other manifestations. What do you prescribe for oral ulcers?
The first is how symptomatic is the patient. That is, means I have seen so many SLE patients, but their main complaint is not oral ulcer. We have so many diseases where oral ulcer is very, very devastating for patient. Oral lichen planus, pemphigus, cicatricial pemphigus. Those are very, very resistant to therapy oral ulcer. In comparison to SLE patient don't have that much problem with oral ulcer. The standard therapy is we treat as either the systemic or skin. Still the patient has pain. It will take some time. Depending on the depth of ulcer, it will take time from healing from 2 weeks to 2 months. So till that, what I use is one topical anesthetic gel, which will allow the patient to eat or drink properly, and topical steroid, which is triamcinolone paste, oromucosal paste to apply. If it is it's bothering some, then maybe intralesional triamcinolone 10 milligram per kg.
Okay, fine. So, Dr. Bhavani, another thing about, I recently saw and heard about this topical methotrexate gel. So where do you use it? How do you calculate the dose, and how do you monitor the toxicity? At least oral, we know that we are giving 25 milligram. In topical, the absorption can be haywire. So how do you monitor the toxicity in such cases?
In fact, if you ask my personal opinion, it is not that very effective molecule if given in a topical formulation. And the best evidence is only with psoriasis, but even it is not very effective drug. And as the literature shows it, the systemic absorption is very minimal. Even at the end of 48 weeks, they have found out serum methotrexate level is minimal. It doesn't reach the toxicity level. So it is safe, but howsoever it is not very effective drug. What I have done in my practice is I have tried in off-label indications like lichen sclerosus et atrophicus, that is a, we must say, counterpart of morphia. It's very much like a sclerosing condition. There I've seen some effect of topical methotrexate, but the burning sensation, at times erythema, charred skin, this is very commonly seen as far as I have seen in my practice. Otherwise, there is no worry about toxicity with topical methotrexate, but it is not very promising drug.
Fine. So, Dr. Deepti, another aspect of spondyloarthritis is keratoderma and cercinate balanitis. So, once the patient has been started on, say, DMARDs by a rheumatologist, if it is not anti-TNF, what do you prescribe? How do we go ahead with treatment?
In keratoderma, just like our palmoplantar keratoderma, we can give that topical steroid, tacrolimus, along with some keratolytic agents we have to use, along with the conventional drug that is having the reactive arthritis drugs. So topically in succinate balanitis, we can use just like steroid because all these are autoimmune disorders. So steroid and topical tacrolimus, but a few literature are there with topical tacrolimus and dapsone. So I have not used that one, but steroid, and if the patient after 10 days, then go for tacrolimus. I'm asking the patient if the lesion subsiding, only small part, 10%, 20% is there, you can apply the tacrolimus.
Thank you. So that brings us to the end of this session. And if we have tried to cover the commonest aspect of common disease, if anyone has any other questions, we would be happy to take it. Sir, please, in case you have something which we may have missed. Yeah, please.
When the patient comes for the first time with HS purpura, is there an indication of this colchicine and dapsone in the first time? Without any renal involvement, without any abdominal pain, patients have only purpura. So there are also the indication of dapsone and colchicine.
Thank you, sir. So the thing is, we have to see whether the small basal vasculitis is the first episode or recurrent episode. If it is a first episode and there is no system involvement, we can wait and watch. If it is a recurrent cutaneous vasculitis occurring without systemic involvement, then we may have to give either SCQ or dapsone to prevent the recurrent episode.
Right.
But as such, there is ideally I do first setting is if there is history-wise no system involvement. I take a very detailed history regarding system involvement. There is no history-wise system involvement. I just do an ESS CRP to look into whether is there a systemic inflammation is there or not. If there is indication of system inflammation, maybe I have looked into the other system. If there is nothing, then maybe we just wait if the patient gets second or not. Many times the Hennux colon purpura is difficult to distinguish from any of the hypersensitivity because whether it's a drug or infection which may occur one episode and spontaneously resolve. So it's better to, I always wait if there is recurrent episode.
Yeah, thank you.
Fine. So I think we'll
Doctor,
end up.
I'll just add one point. We'll finish.
Please.
Urine routine microscopy is must.
Yeah, true. So with that note, we would end this session, and I request, I thank you all the panelists and Dr. Jyoti for giving us the opportunity. Thank you.
So I'll call upon our patron, Dr. Bharat Paningrai sir, to felicitate our all young panelists, and I think they have done a very good job. Please give him a big hand of applause. And I think this is the most interesting session because these are the practical things that have been discussed from the morning, I think. Ladies power. And finally, the will give him.
Thank you. Thank you. Thank you. I have never been such a beautiful our efforts.
I think, so next, I think we'll start the oral paper presentation. Again, Dr. Bharat Panigrai, sir, please have a chair for moderating the session. Please, sir. And I'll call Dr. Durga Prasad Misra from SGPGI to have a chair. And we'll have 4 minutes for the presentation, 2 minutes for the question answer. I think that was told, 4 plus 2. Okay, and we want some judges here. Dr. Manas Puan, Dr. Bhavani Singh, and Dr. Bharti. You will be the judges. You will give the marks. Please come to the front desk. And all the participants, please come to the front. We are overwhelmed actually by the number of cases and the number of oral paper presentation, the number of posters. That's why we closed the advertisement for poster 1 month back. Otherwise, so many people are still calling me and telling, why you have not told, we could have given some more posters. I think this is a huge, huge encouragement by the younger generation and their love towards the subject. So please, I think that is the biggest success of the meeting, that we have received so many original papers and cases.
So to start with next session, this is the paper presentation. And the first speaker will be Dr. Prakashini MV from KIT University. So she will be talking on assessment of cutaneous disease activity in early lupus and its correlation with quality of life, a cross-sectional study. Yeah. I think it's 4 minutes only. Okay.
Good evening all. I am Dr. Prakashini. I am a second year DM resident from in clinical immunology and rheumatology from Kalinga Institute of Medical Sciences, Bhubaneswar. So today I'll be presenting our study, that's assessment of cutaneous disease activity in early lupus and its correlation with quality of life. This was a cross-sectional study. I have no disclosures. What is the need for this study? The skin manifestations in lupus are very common. It affects up to 80% of the patients. And chronic cutaneous lupus and subacute also can be potentially scarring. And this scarring can lead to poor quality of life. And we always chase to attain low disease activity and remission. So during this time, the quality of life assessment may take a backseat. what evidence is available till now, Class C activity scoring and damage scoring have been shown to be associated with quality of life. And SLIC damage index has also been associated with a poor QOL, quality of life. And they mainly saw these in generic quality of index scales like the SF36 and EQ5D. And Class C pain and body image have also been associated. The objectives of our study was to assess the cutaneous activity by Class C, to assess the quality of life in these patients, and also to correlate SLE-QOL, this is a questionnaire, with cutaneous and systemic disease activity and damage. This was a cross-sectional study. Study population were treatment-naive adolescent patients who were more than 11 years as per WHO definition for adolescents. And at the first presentation of SLE, we recruited consecutive patients. And this was done from September 2020 to August 22. The inclusion criteria, as I told, were consecutive patients of SLE over 11 years who classified the 2019 EULA classification criteria. And we excluded patients with fungal infections, urticaria, eczema, uncontrolled diabetes, chronic renal and hepatic insufficiency. At enrollment, we captured data of duration of symptoms, assessment of disease, which was done by both a dermatologist and a rheumatologist, Class C, Mexican SLEDI. We used Mexican SLEDI for ease because every time complements dsDNA may not have been available in patients who had only cutaneous disease, SLIC damage index, and also SLE quality of life. This was the quality of life index that was a self-reported questionnaire that was validated in ODIA. And the disease extent was evaluated by Class C if there was an activity and a damage score. And evaluation of disease activity, active disease was by Mexican SLEDI, and damage was by SLIC damage index. We saw a female predominance, which was expected. 72% were females, and the median age was 27 years. And the disease activity scores, the median Class C activity was 3, Class C damage was 1, Mexican SLEDI was 8, which meant that most of these patients had high disease activity. And damage index, median damage index was 0. And we also looked at the types of lupus-specific lesions in our cohort, and we found that the mala rash, the acute cutaneous mala rash, was the most common. And when we saw, this is all the cutaneous lesions, not just the lupus-specific, and when we saw all of them, the non-scarring alopecia and oral ulcers were more common. And when we saw how, which manifestations were associated with systemic disease, the acute cutaneous rash, as we've been hearing from morning, this may herald a flare. So there was renal involvement, arthritis, serositis, hematological and neurological involvement with low complements in these patients with mala rash. Organ-specific damage. This slide just shows the domain of SLIC damage index that was there in the patient, not the score. So the mean SLIC damage index was 0.63, and the renal and skin were most damaged. And in our cohort, only 3 patients had demonstrated more than 1 item of the SLIC damage index. This is quite a busy slide. I'll just want to indicate that what we found was that only the self-image domain of the SLE quality of life correlated with Class C damage, and the treatment domain of SLE quality of life correlated with the Mexican SLEDI. And there was no correlation between Class C activity and quality of life and Class C damage or quality of life. There were only 2 domains that correlated, and the median Mexican SLEDI was high in our cohort. So we feel that systemic disease may have influenced quality of life more. So why this happened? The treatment domain includes points like fear of needles, dietary restrictions, inconvenience of daily medication. This may have contributed to a poorer quality of life. And the self-image, as shown here, that also positively correlated with a poor quality of life. Our study was limited by a relatively small sample size. We did not have longitudinal follow-up. I would like to emphasize here that
What is it?
now there is...
Time is already over.
Okay.
Okay, thank you. So, any questions from the audience? Okay, Dr. Prakashini, you see the quality of life is influenced by both the systemic disease activity as well as the cutaneous disease activity, as you have already assessment of cutaneous disease activity. So, can you differentiate the quality of life? Can you just tell this much is from systemic disease activity and this much is from cutaneous disease activity? Can you differentiate?
We cannot maybe directly quantify each of it like black and white, sir, but there are different domains in the quality of life index, and they individually we saw correlations with systemic disease activity and damage. That's what we found. The individual domain of the treatment domain and the self-image domain were only significant. So but as you told, it is difficult to quantify like that.
Just one minor comment here. Maybe you could actually statistically try to do a regression wherein you include both the skin scores as well as the systemic disease activity scores separately and see how they influence the quality of life. A linear regression probably might help.
Basically, I also at the same point, it is very difficult to differentiate whether the quality of life which is poor is because of the systemic disease or cutaneous disease. So that may not be very, you may not be able to do that.
Dr. Ekaparnika S. Joshi.
Good evening, chairpersons and judges and my dear friends. Here I am, myself is Dr. Vinay from DRMB resident from an SCB Medical College, Cuttack. Here I am presenting a rare case of actinomycosis in an SLE. She is a 35-year-old female who presented in 2017 with history of fever intermittent with malar rash, followed by oral ulcer and pilar edema. She was on evaluation found to have mucocutaneous and nephritis as a domain. During this point of time, she was given a pulse methylprednisolone followed by prednisolone at 1 mg per kg. Later on, she was tapered to 2.5 mg. She did receive cyclophosphamide and urolupus regimen followed by MMF as in maintenance. During the follow-up, MMF has been tapered to 1.5 gram and she was receiving prednisolone 2.5 mg, HCQ 200 mg and prednisolone of 1 gram during the follow-up and she was in remission. And She presented in April 2021 with a history of lesion over the right calf with no history of any fever, redness, pus discharge, no history of trauma. At that point of time, SLE disease was present. On examination, she had a variegated 11 cross 7 centimeter nodular mass lesion, no surface changes, no discharge in the subcutaneous plane, not attached to the muscle or underlying bone. There was no lymphadenopathy. Investigation, the ultrasonography was done, which was showing an hypoechoic nodular conglomerated elongated lesion in the subcutaneous plane in posterior aspect of the right mid-calf with minimal internal flowing debris. The FNAC of the lesion showed only polymorphs with some lymphocytes and plasma cells. The biopsy done showed this one, collection of an polymorphs with multiple branching basophilic material in the center, followed by club-shaped eosinophilic centers surrounding the basophilic filamentous structure, probably suggestive of an actinomycotic lesions. She was put on prednisone 200 mg and she was given amoxiclavulinic acid for 6 months duration. During this point of time, her lesions resolved. Later on, she was restarted with methotrexate as a DMARD as she had cutaneous flare during the follow-ups. She again represented in the month of April 2022 with recurrence of a lesion, which was again variegated and nodular with multiple satellite lesions with surrounding discolorations which was present. So she did had an cutaneous flare at that point of time, and other systemic examination was within normal limit. And investigation-wise, our CBC, LFTs, RFTs were within normal limits. Urine showed 1 plus proteinuria and 24-hour urine protein was 360 less than 500 mg. C3, C4 were normal. Rebiopsy was done. Again, it was suggestive of an actinomycosis. In view of cutaneous flare which she had and requirement of long-term antibiotic therapy, surgical excision of the lesion was done. And 6 months after the follow-up, she is doing well. Then later on, she was restarted with methotrexate and titrated the dose for the cutaneous flares. So actinomycosis is a rare, indolent, slowly progressive. It is not associated with immunosuppression. This is just an incidental infection which has happened in the case of an SLE. It does not have any geographical boundaries. Mostly it is those patients who do not have accessibility to the healthcare facilities tend to get actinomycosis, and with trauma and poor dental hygiene in this one. It usually colonizes in the mouth, colon and vagina. Whenever a breach in the mucosa happens, they tend to develop cervicofacial, abdominal or pelvic lesions. Treatment is most likely the medical. Prolonged duration of antitherapy is required. Whenever there is an emergent condition, surgical therapy is needed. Thank you.
What do you think causes more chances of having these infections, steroids or methotrexate?
Sir, I didn't get completely.
What do you think has more chances of causing such infections, giving her long-term steroids or giving her long-term methotrexate?
Sir, actually in this actinomycosis is not associated with immunosuppression, sir. More likely it's a trauma and she has not received any of the care in usual this one. Most of the times actinomycosis is very amenable for this one. Mucosal breach, someone receives some part of the time penicillins, it gets usually cured. So pre-antibiotic area actinomycosis were very common. Post-antibiotic area actinomycosis is rare because of frequent antibiotic use for some other conditions most of the times.
Would you like to stop her methotrexate or steroids for treatment further?
Sir, DMARDs are the usual one which we, because this is prolonged antibiotic, this one, ideally we have to come down with steroids first, sir. Taper and stop and followed by tapering of the methotrexate.
Now, what he is telling, it is not at all associated with immunosuppressive therapy. So the question of stopping this doesn't arise.
Okay. She had flares, sir. That's the reason why we had.
But nocardia is very, very associated with immunosuppressive conditions on this thing.
Yes, it is more of a coincidence.
So you have done this surgical excision.
Yes,
after that, you have not given any antibiotics.
Sir, post-surgical incision we have not given, sir.
And there is no flare.
No further. Almost 1 year. Almost 1 year follow-up. She is no further recurrence of the lesion. And cutaneous flare she had. For that we have hiked up the titrated the doses of methotrexate for this. Thank you, sir.
Next. Dr. Joshi.
Good evening, everyone. I'm Dr. Ekparnika Joshi from the Department of Medicine from Himalayan Institute of Medical Science. and I'll be presenting a case of alprostatil in the treatment of persistent Raynaud's phenomena in systemic sclerosis, done under the guidance of my consultant, Dr. Yogesh Preet Singh, sir. So, systemic sclerosis is an autoimmune disorder characterized by inflammation, fibrosis, and microvasculopathy that results in potentially widespread fibrosis and vascular abnormalities, which can affect the skin, lungs, heart, the gastrointestinal tract, and the kidneys. The vascular involvement causing Raynaud's phenomena, digital ulcers, and non-digital ulcers. And these are the major source of pain and disability, has significant impact on the quality of life, and the treatment from these includes protection from cold, smoking cessation, and vasodilators, which are the non-pharmacological measures. Now, the management of Raynaud's and digital ulceration, the first step is starting the patient on CCBs. Then if this doesn't work well, we go to the second step, which is the phosphodiesterase 5 inhibitors, plus minus the ET blockers, and other therapies like aspirin, statins, angiotensin receptor blockers, ACE inhibitors, SSRIs, and topical nitrates. If this also fails, we go to the third step further, which is the IV prostanoids, leading to the terminal step of wound debridement, digital sympathectomy, or botulinum toxin injections. The non-pharmacological measures, including the smoking cessation, cold avoidance, and patient education, holds true for everybody, and this is what we start from. Now here's presenting my case of a 62-year-old female who's a case of diffuse cutaneous systemic sclerosis since many years, for at least more than 20 years. And she presented to us between October 2021 and November 2021. During the cold months, it's very prevalently seen in our area. So the Raynaud's we started her on oral CCBs, which is amlodipine, and we sequentially started adding the therapy needed one after the other as she was presenting with persistent Raynaud's phenomena. So we started with topical nitrates, then we went further down to phosphodiesterase 5 inhibitors in the form of tadalafil. Then we added endothelin blockers in the form of ambrisentan with other therapies like losartan and aspirin. Despite optimum management with maximally tolerated drug doses of these therapies, the patient had persistent Raynaud's, impending digital ischemia, digital ulcers, and non-digital ulcers. The area in red is to give a brief idea of the areas she presented to us in the form of digital and non-digital ulcers. Going ahead, we started with the classical management form, and that led to the third step of the IV prostanoids when the rest of the management failed. So, why not iloprost? We did not start with iloprost because iloprost is not available in India. It is costly and there is a need of central line. So we gave her alprostatil, which is a prostaglandin E1 analog, similar in efficacy as iloprost, as given in many studies, a few which have been done on this topic, in the treatment of Raynaud's phenomena and digital ulcers. The patient, we gave her a dose of 500 micrograms IV infusion per day for 5 days. And this is the image of the patient when we received her after as a follow-up case. We can see that the digital ulcers and the non-digital ulcers which were present showed a drastic improvement after the administration of alprostatil infusion. At 3 months after alprostatil infusion, this is the picture we had, and in November 2022, she received a repeat alprostatil for Raynaud's phenomena. Now there was an improvement in the Raynaud's, and review after discharge was a significant improvement in the digital ulcers and the non-digital ulcers after 6 weeks. This is the before and the after picture. So to conclude, alprostatil can be considered as an alternative to iloprost in refractory Raynaud's phenomena. It may also have a role in the treatment of refractory digital ulcer and non-digital ulcer. Plus, there is a need for further studies of larger samples to establish its role in the treatment of vascular complications associated with systemic sclerosis, for which we are planning to start a case series, and we've started collecting cases on this. My references. And this shows the various studies, 3 to 4 studies which has been done, and the different doses of alprostatil and iloprost use, which overall sums up that both of them are almost equal in efficacy, and alprostatil can be used as an alternative to iloprost, and it leads to a reduction in the Raynaud's phenomena severity, as well as the digital and the non-digital ulcers. Thank you.
Thank you for presenting the interesting case. It was difficult to treat and the patient improved, so that's good for the patient.
Thank you, sir.
Any
What is
question?
the availability? Which company makes alprostatil? Well, I have used in 2-3 patients, but after that I think that's a problem, availability problem here. So which company?
So it is available there. We get it for the pediatric age group. We get it for the patent ductus arteriosus wala the ampule. We are using the same ampule.
Now,
The company, sir.
You don't know. I think it is Biocon or something that was available. I have used in 2-3 patients. Excellent drug.
Yes, sir.
But the thing is, I have used only for 1 or 2 days. You also, those who are having severe pain, the pain just goes away.
Yes,
But
sir.
the thing again, it is about the availability in our state.
So actually, it was a sample which was procured because this lady, she was not affordable at all.
The cost is actually 5,000 to 6,000. It was available somewhere in Master Canteen.
3,500 around.
Then I have been directed to Chaudhary Bazar or something, that pharma, this thing. But after third time, I have not got this one. But they are excellent drugs.
So there it is available around 3,500 to 4,000. We procured it for her for free because she was not.
Can you courier some of them to Odisha?
Sir Yogesh sir would be more than happy to help.
So anyhow, please give a big hand because she had come from Dehradun to present the case.
Thank you so much, sir. Thank you.
Dr. Sarmista.
Good evening, everyone. I am Dr. Shormishtha Paja, resident of dermatology from Kolkata, Arjikar Medical College. Today, I'll be presenting my paper on a clinical and demographic profile of generalized discoid lupus erythematosus, a cross-sectional observational study from a tertiary care hospital of Eastern India. It's not working. Discoid lupus erythematosus is a variant of cutaneous lupus erythematosus that may occur independently or as a manifestation of SLE in up to 20% of patients. Generalized DLE refers to DLE occurring both above and below the level of the neck. Since there was a dearth of any formal study on generalized DLE, we were prompted to undertake the present study. The study was undertaken to find out the clinical and demographical patterns, cutaneous and systemic associations, and complications seen in DLE patients. Coming to methodology, my study design was cross-sectional descriptive, carried out at the OPD of dermatology of a tertiary care hospital in Eastern India over a period of 36 months. And all the stroke statement guidelines were followed accordingly. After obtaining permission from Institution Ethics Committee and informed consent from the consecutive patients, as per both inclusion and exclusion criteria, they were thoroughly evaluated clinically. Dermoscopy was done, and also histopathological examination was done in every patient. Relevant lab panels were done, and data was recorded in a pre-tested, pre-designed, semi-structured schedule, and statistical analysis was done using GraphPad Prism version 5. Coming to the results, the total number of patients evaluated were 23, with a male is to female ratio of 11:12. The mean age of onset of disease was 46 years. The median duration of disease was 24 months. Coming to the smoking history was present in 34.8% of patients, and among symptoms, the most common symptom reported was photosensitivity by 69.5% of patients, followed by pruritus. Coming to the cutaneous signs, depigmentation and atrophy was the most common cutaneous signs present in all of the cases. And in types, the most common type was classic type, present in almost 79% of patients. The number of lesions ranged from 3 to 24, with an average number of lesions as 15.3. The most common sites affected were face, followed by neck and scalp. 5 patients, that is 21.7%, fulfilled the Euler classification criteria for SLE. Most common mucosal lesion morphology was plaque type. ANA with high titers, that is 1:80 or higher, was positive in 6 patients, that is 26% patients. Anti-dsDNA was positive in 8.69% of patients. And among dermoscopy findings, the most common finding was follicular keratotic plaques, followed by arborizing vessels. The first two pictures shows generalized DLE. The upper second picture shows acral DLE. The below third picture shows one DLE patient complicated with squamous cell carcinoma. And the right-sided picture shows Schuster sign, and the upper one picture shows the oral mucosal lesion of DLE. This is a comparative study between the key findings between our present study and the previous 2 studies on DLE. What is known is basically most of the findings were comparable to the existing literature, but what was new in this study? That is, photosensitivity was detected in 69.5% in contrast to 14.6% found in the Thai study. ANA positivity in DLE patients of the Thai population was 68.5%, but in discordance to this, we found 22% of DLE patients where ANA was positive. The most common morphology of mucosal lesions in our study was found to be plaque type. Being an institution-based study, the study findings may not reflect the community's true situation, which remained a limitation of this study, and also a relatively small sample size. To conclude, we could not find any previous study on generalized DLE in the Indian population, especially in Eastern India, so our report is probably a first step towards shedding light on this important subject. Physicians should be aware that DLE is not a static condition. Long-term follow-up and with frequent re-evaluation is necessary, especially in those who had positive ANA, abnormal urine analysis, rheumatologic symptoms, and generalized DLE lesions. Thank you.
Okay, Sharmishta. Yes. I think all your patients are either a low socioeconomic status or lower middle economic status. So is there any relationship between socioeconomic status and DLE?
Sir, I have mentioned the findings of socioeconomic status, but there was no significant statistical association between the socioeconomic status and DLE.
Oh, no, this is a demographic study, no?
Yes, sir, I have mentioned that, the demographical finding. Among 58% were belonging to the lower economic status.
Okay.
What is the age of the oldest patient in your group?
70 years.
70 years.
Yes.
So age at onset?
Yes, sir, age at onset. Sir, firstly, all of them were diagnosed with generalized DLE, and among them, only 5 patients developed SLE consecutively over the follow-up of 3 years.
Thank you.
Thank you, sir.
Next. But the pictures were really good actually. For rheumatologists, this is like atlas. That picture showing hypertrophic and everything. Thank you, sir. So next. Shreya.
Good evening all. Today I am presenting a single-centered case-controlled observational study on nail fold capillaroscopy and correlation with microvessel density in psoriatic patients in central India. I am Dr. Shreya from AIIMS Bhubaneswar. Psoriasis is a chronic disease with worldwide prevalence of 0.1 to 11% of the general population and affects third and fourth decade of the population with male preponderance. The rationale for the study was psoriasis involves the vasculature in very early stages of the disease and leads to impaired capillary permeability and decreased density of capillaries. The study was conducted in a tertiary care center. It is a single-centered case control study conducted between March 2021 to August 2022. 100 patients with psoriasis and 100 controls were taken. The aim was to describe the morphology of nail fold capillaries and quantify these changes and correlate these findings with the microvessel density in the skin biopsy of the patients of psoriasis. Patients between 10 to 80 years were included with a body surface area more than 10% and PASI more than 10 with or without psoriatic arthritis. Those who are off treatment for the past 4 weeks. Exclusion criteria was patients with diabetes, hypertension, and other connective tissue disorders and who have undergone cosmetic procedures for the nail in the past 4 weeks were excluded. The material used was USB denolite microscope was used for nail fold capillaroscopy, and microvessel density is assessed from the skin biopsy of the psoriasis plaques with CD31 marker by using the semi-automated device. After taking the informed consent, patient characteristics like age, gender, duration of illness, comorbidities, BMI, and history of precipitating factors, and PASI, NAPSI, and joint involvement in the patients of psoriasis were documented. Cases and control were seated in the room temperature for 30 minutes, and nail fold capillaroscopy abnormalities were assessed from second and fifth fingers using USB denolite, and images were subsequently coded, and skin biopsies were taken, and CD31 marker were assessed. For the ordinal data, chi-square was used, and for the continuous data, student t-test was used. The baseline characteristics of age, gender, and BMI was statistically insignificant. The patients with psoriasis, the body surface area was more than 22%, with 11% having joint involvement and 5% with the DAP involvement, and NAPSI was 17, and nail involvement was seen in 58% of the cases. There was significant correlation between the joint involvement and the PASI scores, and there was a moderate positive correlation between the PASI and the NAPSI score, and there is no significant correlation between the PASI and the microvessel density. And the morphology of the capillaries in the cases and controls were reduced density of capillaries in the patients of psoriasis, and it was 6.6 around, and it was more significantly affected in the patients with erythrodermic and pustular variant. There is dilated capillaries in 20% of the cases, and it was correlated with the PASI and the nail involvement. Tortuous capillaries were seen in 17% of the cases. This correlated with the NAPSI. Hemorrhages, avascular areas, and visibility of subpapillary plexus and ramified capillaries were seen more in the patients with cases, but there is no significant correlation with the PASI, NAPSI, and DIP involvement. The morphological features seen are bizarre capillaries, hemorrhages, tortuous capillaries, and ramified capillaries. The relation between the microvessel density of the psoriatic plaques with the nail fold capillary scope was insignificant. The association between the nail fold capillaroscopy changes with the microvessel density was not less than 0.05. This is the image depicting the microvessel density. The brown pigmentation represents the CD31 marker in the papillary dermis in the cases of psoriatic plaques. The capillary density was correlating with the reduction in the capillary density correlated with the PASI, and this was more reduced in the patients with erythrodermic variants and pustular variant. This was in concordance with the previous study. The dilated capillaries there was no correlation with the DAP joint involvement, maybe due to the USB microscope could not measure the afferent and efferent limb of the vessels, and this was correlated with the PASI and the nail involvement. The tortuous capillaries there is no significant correlation with the PASI, but there was correlation with the NAPSI. This indicates the neoangiogenesis. Hemorrhages, there is no significant association between the PASI, NAPSI, and DIP joint involvement. Hemorrhages indicate the early vascular damages. Avascular areas were more seen in patients with pustular psoriasis and patients with greater PASI and NAPSI. Visibility of the subpapillary plexus was more seen in patients with erythrodermic psoriasis. Limitation of the study, we could not assess the diameters of the afferent and the efferent limb because of the USB device. Nail fold capillary changes with respect to the treatment could not be evaluated, and DAP joint involvement and other joint involvement was not assessed with the nail fold capillaroscopy, and it was not as correlated with the disease duration also. To conclude, the microvessel density of the psoriatic plaques quantified by the IHC, there is no correlation with any of the capillaroscopic findings. The majority of the capillaroscopic findings were seen with the reduced density and hemorrhages, tortuous, and dilated capillaries. And nail fold capillaroscopy is a non-invasive imaging tool for microvascular evaluation and highly reproducible tool that helps us to predict in the clinical course in the cases. Thank you.
What were your controls?
I want to assess the severity, nail involvement, joint involvement, was whether it is correlating with the nail fold changes. That if nail fold capillary changes indicate the further progression of the disease also.
I mean to say, you had written that the age of controls were around 40 years.
Yes.
So who were your control subjects?
Control were the patients who was not having psoriasis, which is actually we did not match, sir. Unmatched, those who are having, those who are attending the OPD, dermatology OPD, either in the form of acne, other diseases, we included all those patients.
These are not healthy controls. They have some disease, but
some
not
other
psoriasis.
disease, but not psoriasis. Not even other connective tissue disorder that would affect that will lead to bias of the study.
But can you say for 100% that they cannot have any nail fold changes?
Sir, only more than 2 nail involvement, matlab significant changes, that only considered as abnormality. So in normal patients, sir, there was significant difference in the psoriasis and in the control patients also, more than 0.05.
No, I think age and sex matched control, healthy control, you should have taken healthy control, because if some other drug means, that is always confounding factors will be there. And whenever you are taking control, because so many patients are coming to your OPD,
Yes,
you can take age and sex matched. It may not be randomized, but it can be of that same age group and this thing, so that at least we can.
At least there should be healthy controls. Why take diseased controls?
The control should be healthy, who have not have any nail or at least hand involvement.
No. The acne and all, like that, those.
Okay, so healthy
Just-
in, so that's also we are discussing, healthy in terms of hand.
Okay.
That is okay. So, yeah, that is okay.
Just a comment regarding your study design. This is a cross-sectional study. This is not a case control study.
Cross-section with the control of.
That doesn't make it a case control study. Go back and read the definition of case control studies.
Okay, sir.
Okay, next. Thank you.
Thank you, sir.
Dr. Ananya.
Good evening, everyone. The topic of my presentation is topical tofacitinib in localized plaque psoriasis, a case series. Psoriasis is a chronic inflammatory multifactorial disorder with variable period of remission having immense effect on the quality of life. When most patients have mild to moderate disease and respond well to the conventional topical therapy. But the current topical agents have limited efficacy and undesirable side effects associated with its prolonged use. JAK inhibitors, by inhibiting the JAK-STAT pathway, block signaling of multiple cytokines implicated in the immune response and inflammation. Tofacitinib, a JAK inhibitor, is a small molecule and shows good drug delivery in the human skin and is shown to have good result and acceptable safety profile. The objective of my study was to assess the efficacy and the safety of topical tofacitinib in localized plaque psoriasis. The inclusion criteria were patients with localized plaque psoriasis with a body surface area of less than 10%, of age of more than equal to 18 years, and without having any treatment of the disease, either topical or systemic, for at least 4 weeks before enrollment. The exclusion criteria were non-plaque form of psoriasis, drug-induced psoriasis, history of infection requiring hospitalization or treatment with oral or topical antimicrobial therapy within the 2 weeks prior to the baseline visit, history of any malignancy, HIV, hepatitis B or C, known case or family history or contact history of tuberculosis, pregnancy, and lactation. 8 patients with localized chronic plaque psoriasis fulfilling the inclusion criteria were selected and were advised to apply topical tofacitinib 2% ointment twice daily over the plaques along with bland emollients. The patients were followed up every 4 weekly and were monitored based on the clinical improvement, that is by the reduced erythema, induration, scaling, with a reduction in the PASI and the itching, which was assessed by the visual analog scale. According to the clinical improvement, the dose was tapered and then stopped in another 8 weeks. These were the results where we have the results of PASI at the baseline, PASI at 4 weeks, and PASI at 12 weeks. Here we can see that 5 patients achieved a reduction in the PASI, significant reduction in the PASI, whereas 3 patients did not have much improvement. Here is the VAS of pruritus, showing the baseline value and value at 4 weeks and 12 weeks, where most of the patient had improvement in pruritus. There were no significant adverse effects recorded at each follow-up. These are the photographs of the patient. In the first case, we are seeing that delta PASI 75 was achieved. In the second one, we are seeing that a delta PASI of 90 was achieved. Here we can see a delta PASI of 90 achieved. In this patient, a delta PASI of 100 was achieved. But in this patient, we did not find much response. This series demonstrated the clinical efficacy of topical JAK inhibitor in localized psoriasis as assessed by the improvement in PASI score and VAS. There is a randomized double-blinded vehicle control study by PAP et al., where 435 patients of mild to moderate psoriasis were randomized and prescribed topical tofacitinib 1% or 2% in once daily or twice daily doses and were followed up for 3 months. The patient showed good result with no significant adverse effects to this molecule. Our findings suggest that topical tofacitinib can serve as a promising new treatment for localized chronic plaque psoriasis. The advantage of this therapy will be that it will have lesser side effects than systemic therapy and will also serve as an alternative steroid-sparing topical modality. The limitations of my study were low sample size, absence of a control group, short duration of the study. Further randomized comparative trials can be conducted to validate this study and to determine the long-term efficacy and safety of JAK inhibitors in psoriasis. These are my references. Thank you. Sir, could not hear you, sir.
Very interesting study. My only question was, what is the minimal clinically important difference for PASI? What difference do you consider as clinically significant, and how many patients attained that clinically significant difference?
So till now we just had 8 patients.
There must be a defined MCID.
Sir, we are considering of a PASI, delta PASI of 50 or delta PASI of 75 to be of significant improvement. And we are also considering, I haven't taken many objective scores here, major scores that we are considering, like the pruritus score, it's also a subjective score. And PASI is also, it will depend, it will have an inter-observer variation as well, sir. I have observed all those values, and here in this, in these people, we have seen that based on, sorry, sir.
50 or 75,
Huh,
yes,
sir?
sir. You said 50 or 75, isn't it?
70 and 50, sir. And for some patients, we have even gotten PASI 90 and PASI 100, sir.
Fine, thank you.
Thank you. Next.
Tofacitinib is also available, that is ointment or gel?
Sir, both formulations are available, but the approved formulation for other indications is the ointment formulation. And sir, moreover, ointment specifically in case of chronic plaque psoriasis, as because it has a thicker consistency and more hydrating potential, less sensitization potential, so we would prefer an ointment formulation.
It is available in the market?
Sir, yes, sir.
Okay, thank you.
Thank you, sir.
Next. Binita, sir.
Good evening, everyone. I'm Dr. Vinisha, postgraduate resident, dermatology, KIMS, here to present my study on detection of subclinical enthesitis sonologically in patients with psoriasis and psoriatic arthritis, a cross-sectional study. Around 10 to 40% patients with psoriasis have arthritis. Enthesitis is the inflammation at the insertion of ligaments or tendon. Many psoriasis patients with or without arthritis will also have enthesitis. Primary objective of my study is to estimate prevalence of enthesitis in psoriasis. Secondary objective is to find out clinical factors leading to development of enthesitis in psoriasis. It is a cross-sectional type of study. All clinically diagnosed cases of psoriasis are included. Patients with pedal edema or lower limb cellulitis are excluded. All the patients with clinically diagnosed psoriasis attending the OPD of dermatology satisfying inclusion and exclusion criteria. Patients will be clinically examined for enthesitis as per Leeds Enthesitis Index, Manders Enthesitis Index, skin severity by PASI scoring. Concomitant arthritis and inflammatory backache, if present, will be documented. Enthesitis will be confirmed by point-of-care musculoskeletal ultrasound by OMERACT ultrasound definition of enthesitis. Sonologically, we are examining bilateral, lateral epicondyle, bilateral attachment of proximal patellar ligaments, bilateral attachment of patellar tendon, bilateral Achilles tendon attachment. We have a sample size of 30 with male and female ratio 7:5. Median disease duration is around 24 months. Psoriasis vulgaris accounting for 66%, while guttate, palmoplantar and scalp psoriasis following the rest. Common type of psoriasis, mean PASI is 11.5. Enthesitis is clinically found in 36%, while sonologically in 40%. Difference between clinical and ultrasound detection is not statistically different. Longitudinal scan showing Achilles tendon with heterogeneity and enthesiophytes. Longitudinal scan of lateral epicondyle with grade 2 PD signals. Hypoechogenicity and increased thickness are more common findings seen in psoriasis and psoriatic patients. Out of all the parameters recorded, concomitant arthritis is found to be statistically significant. It is an ongoing study. We are presenting data of first 30 patients. Varied presentations of enthesitis have been demonstrated with the help of arthritis. Till now, there is no statistical difference between clinical and ultrasound detection of enthesitis. Presence of enthesitis was associated with presence of arthritis. Concluding, prevalence of enthesitis in our psoriasis cohort is 40%. Predictors for presence of enthesitis is concomitant arthritis. However, as our cohort size increases, we expect to identify more predictors. Thank you. Sir, moderate blood flow towards the... so moderate disease activity.
Sombra, a kit.
Sir,
Yes.
in collaboration with rheumatology, sir.
Okay, so no, one thing. So why you are doing this subclinical assessment exercise? How it is important? What will you achieve by that?
So we can prevent the progression of the disease, sir.
Progression of disease what? Progression of what?
So 40% of psoriasis patients can lead to psoriatic arthritis. If we find out the subclinical enthesitis, we can start the treatment for preventing the disease progression.
Is there any relationship that this much of subclinical enthesitis that will lead to this much of arthritis? Is there any relationship
Sir,
like that?
enthesitis is cardinal feature of arthritis, so...
Rather, you can tell like enthesitis are usually diagnosed if you diagnose it only clinically. So sometimes that may not be detected. So that's why this is subclinical.
Yes, sir.
So that enthesitis is present, but that is not being accessible for clinical examination. So that's why you can start early treatment. You have to treat enthesitis. Otherwise, they will progress and they will lead to weakening of that tendon and everything.
But how much of there are you see, it is a systemic inflammatory disease. Okay, there are many organs which can be affected subclinically. My point is, if subclinical stage of enthesitis, you don't know how much of them will be really coming out to the frank enthesitis or frank arthritis. That too, is there any study like that?
No.
Maybe 1/3%. But first thing, we'll know the burden of disease. Then maybe we can follow up the patients. Maybe the next PG student can do. Then they can find out if persons with subclinical enthesitis have a higher probability of developing arthritis. That will be the second step of the study.
Okay, thank you.
CB, nobody is there, I think. Okay, he has not prepared, I think. Okay, this is the end of the oral presentation. Very nice cases. I think all of them are winners. We can give them a big hand up. Applause. By the time our judges are getting ready, please, we'll start the quiz. So I invite our quiz master, Professor Dr. Sakir Ahmad and Dr. Arpita.
Thank you, Dr. Jyoti. So can we have the participants who are going to participate kindly come to the first seats? Sit
teams,
2 by 2, leave at least one seat in between.
whoever want to participate also can give your name and come forward.
So we already have some names here, but if anyone extra wants to join, we have no issues.
Yes.
Just sit 2 by 2.
But please sit at different, different lines and give your name first.
At least give a gap of one seat in between. Take a blank paper, write your names. Can we have the slides? Prelim quiz slides. So, has everyone got the papers? Anyone without paper? Just write your names. You stand at your own places. Please stand at your own places who have not got the paper. Those who have got the papers can sit down. Please write number 1, your names. Number 2, name of your department. Number 3, name of your institute. And anyone single who wants to join? Anyone who is left single? If you are brave enough, you can join single also. Can we have a scorekeeper? Someone has to keep the scores. Not now, for the main prelims. Approximately 30 seconds. We will, as soon as I finish reading. So questions will be shown on the screen and I'll be reading the question. After I finish reading the question, 10 seconds more will be given. It is very easy, it is multiple choice. So only you have to write the question number and the choice A, B, C or D. So all of you have written your names, departments and institutes. Paper. Madam, are you joining? So everyone is ready? Are the slides ready? Madam. Madam, slides. Here, give. So the prelims will have 20 questions. For each correct answer, you will be getting 1 point. And for a wrong answer, you will get minus 0.25, or 1/4 of the mark will be deducted for the wrong answer. Attempt as many as you can. The top 4 teams will be selected. And in case we have a tie in the final round, then we'll go back to the prelims, and whichever team has scored higher in the prelims, that will be used as a tiebreaker. So be careful about your prelims also. So we have, I think, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. 14 participants or groups. I would ask the organizers to please organize 8 chairs also on the dais. 8 chairs, because we can keep them over here. Okay, sorry for the delay. As I said, 1 mark for correct answer, minus 1/4 for negative answer. So though we are saying 30 seconds, from your faces I know if you have written you are going to answer that question or not, and we can go fast to the next question. And in case there is a tie in the prelims, then 4 specific questions will be sought for, and whoever scores more on these questions will be taken as the tiebreaker. So first question, choose the correctly matched antibody with clinical characteristics in dermatomyositis. MDF5, Gotron papule, anti-MI2, calcinosis, anti-NXP2, ILD, anti-TIF1 gamma, malignancy, which is correctly matched. If you want at the end, I'll show you the questions once more. Going to number 2. Most common drug implicated in drug-induced dermatomyositis. Is it hydroxycarbamide? Is it carticane? Is it phenylbutazone? Or is it neflumic acid? Plenty of hair scratching, beard scratching. I'll go to the next. Rowell syndrome is characterized by all except cutaneous features of lupus erythematosus, cutaneous features of erythema multiforme, homogeneous antinuclear antibody, or chilblain. Number 4, all are true about pathogenesis of SLE except UV light resistance to the 3' repair exonucleus 1 mediated degeneration is there. In case of hydralazine, there is activation of extracellular signal regulated kinase pathway. In case of prolactin, there is enhanced B cell proliferation. Or in the case of procainamide, there is inhibition of DNA methyltransferase 1. Number 5, all are true about antiphospholipid antibody syndrome except 80% of patients of lupus have this antiphospholipid antibody. 10% of women with recurrent miscarriages have APLA antibodies. 25% of patients with venous thromboembolism exhibit APLA antibodies, or 20% of patients having stroke before the age of 50 years have antiphospholipid syndrome. I'll give my voice a rest and I'll ask Madam to please take the next 10 questions.
So this is the 6th one. So familial form of chilblain lupus is characterized by all except autosomal dominant inheritance, mutation in TREX1, Aicardi-Gautier syndrome may have similar cutaneous lesions. Up to 90% of patients progress to SLE. So I think we can move to the next. Mark the true statement about drug-induced LE. It occurs in an older age group. Central nervous system involvement is common. Anti-DNA antibodies are positive. Renal involvement is common. What is true? This is an AG1.
So we move on to the next. Scleroderma renal crisis is characterized by all except retinopathy and encephalopathy may develop. High-dose corticosteroid may increase the risk of this renal crisis in such patients. ACE inhibitors are contraindicated. Almost half of the patients have RNA polymerase III antibody. This is also very clinical. Usually we are asked in Viva. Next, which test is recommended for ocular Zika in the diagnosis of Sjogren syndrome? Schirmer 1 without local anesthesia, with local anesthesia, 2 without local anesthesia, and 2 with local anesthesia. This is also very basic. So we'll move on to the next. Limited form of systemic sclerosis is characterized by low risk of scleroderma renal crisis, absence of gastrointestinal disease, rapid progression of skin signs, pulmonary hypertension is rare. So next question. Which is not true about neonatal lupus. It is a self-limiting disease associated with Rho or La antibodies. Cutaneous involvement is the most common manifestation. The risk of complete AB block is 2% for first pregnancies or where previous pregnancies were not affected. So mind that you understand if it is asked not true, true for each question. That varies. Huh? Keep that in mind. So next question. What is the drug of choice for methotrexate toxicity? Very basic, very clinical one. Folic acid, cholestyramine, aminopterin, leucovorin. All of us have encountered such cases. Next. What is guselkumab? So, the number, you have to guess the number. Is it a monoclonal antibody against IL-17, 12, 23, or 12 and 23? So rheumatology quiz means these MUMABs are a must. Next one. Which of the following is used to quantify activity and damage of skin in systemic lupus erythematosus? So the name of the scores and the full forms are there. So whoever has attended the sessions mindfully, they will be able to answer. Yes. This is 15, sir, I think. This is the 15th. I think there is a, one was missed, sir. Number was missed. So this is the 15, I think. Should I go ahead or stop? There is a mistake in, okay. So that's all. Actually 15. There was a mistake in the, so you gave us, well, Actually, 4 was twice. So anyone, I can go again if you want. The questions I can go. This is question 1. Then this is 2. This is 3.
Give them 5 seconds. Anyone has a doubt, you just tell us to stop.
4. Then this is 5, actually labeled as 4 again. Then this is 5, actually 6.
6.
This is 7, 8, 9, 10, 11, 12, 13, 14, and yes. Okay. So which is not an enzyme raised during active myositis. Okay, we'll stop here.
Please give your papers. So while the prelims are getting checked, I'll just show the answers. Can we have the same slides or the Word document, whichever? First question was, which is correct? Which one? D. No doubts? Second, drug-induced dermatomyositis. D. Second is A. Third is Rowell syndrome, homogeneous ANA. C. Fourth is hydralazine doesn't activate the negative marking is there. First you can just tick right and wrong, add positive, and for each wrong it will be minus 1/4. This is actually number 5. This is 4. 4 is B. Five. Which one? Lupus. How many have antiphospholipid antibodies? 30%. 30 to 10% will have antiphospholipid syndrome. 30% will have antibodies. So answer is A. Number 5. Answer is A. Number 6. What is true about children lupus except D? Most of them will stay children only. They will not go into complete systemic lupus. That is, answer is D. Number 6. 7. drug-induced lupus. See, it can occur at any age. Classically, dsDNA is not found, but in case of anti-TNF-induced lupus erythematosus, you may get dsDNA also. So technically, C is correct, D is wrong. So the correct answer is A. Number 7, correct answer is A. Number 8, scleroderma renal crisis, all except. This is the A. It can, drug induced can occur at any age. Sorry. So usual CNS involvement will not occur. dsDNA, if it is true, it will be A. Answer is A. Technically, okay, what we'll do, we'll give both A and C. Anyone who has answered A or C will get 1 mark. Classical are antihistones, but anti-dsDNA, okay, we'll see. A. 7 is A. 8 is, obviously this one is an easy one, ACE inhibitor. 9, it is Shermer. 1 or 2? It is Shermer 1. Shermer 2 involves nasal stimulation. You have to give nasal stimulation for Shermer 2, and it is always done without local anesthesia. So correct answer is A. 9 is A. -1, -0.25, 1/4. 10, limited form of systemic sclerosis. Which one? A. So they have limited risk of systemic sclerosis. Pulmonary hypertension occurs more commonly. 11 is neonatal lupus. Which one is not correct? Which one is not correct? C. Most common manifestation is cardiac. You get heart block. That is the most common manifestation. Cutaneous manifestation occurs in up till 20% of cases. Pardon? Risk of complete AV block is 2%. So 98% will be asymptomatic. 2% may have cardiac block. Out of this 2%, 1/5 will have cutaneous manifestations. Out of this 2%, 1/5 will have cutaneous manifestations. I hope the doubt is clear. Going to number 12, drug of choice, methotrexate. It is leucovorin. Number D. 12 is D. 13, guselkumab. It was mentioned today. It is C. Against IL-23. 13 is C. 14. So we have heard it, I think, twice, at least twice or thrice today. If you have been paying attention, it is classy, B. Two of the speakers had presented and there was one oral presentation also. 15, which enzyme is not raised during active myositis? Huh? AGPT obviously will be raised. This is AGPT, na? Answer is B. It is aspartate transaminase. Here it is written as aspartate trans hydroxylase. AST, this is AST. AST is aspartate transaminase, not hydroxylase. So hopefully the marks scoring has been done. Can we have the other set of slides, main quiz? So I would like to invite to the stage, I'll not tell you the marks now. In random order I am calling. Dr. Priyanka and Priyankshi. Dermatology AIMS, Bhubaneswar. Please come up. Second is Vivekananda Mohapatra and Khameshwar Augusti from SCB. Come to ma'am, you pick up a slip and that will be your seat. Third will be, not third, but next group is Dr. Shreya and Dr. Sonita from AIMS. And one more group is Purnendu Sinha and Saswat Bahanipati, MKCG. So congrats on being selected. Hope you have got your seat numbers, A, B, C, D, I think. You can take your seats here. Next slide set, main quiz. A will come here. A, B, C, D. You have a screen in front of you. Make yourself comfortable, make sure you can see the screen. And when you whisper among yourselves, make sure the neighbors don't hear because questions will be passed. So Arpita ma'am's name has come. I would like to call her to the stage. She'll set the ball rolling.
Okay. So this is the most exciting part. So we'll start. Sir, yes, we'll start then. So the rules are this. There will be 4 rounds plus 1 nomination round and 1 rapid fire round. 4 questions in each round, 1 direct question for each team. So time to answer direct question 10 seconds, pass question immediately, then correct answer will have 10 points, past question 5 points, no negative marks for the direct questions. Special rules will be there for round 5, that is nomination round, rapid fire round, 10 questions in 1 minute. As much you will answer correctly, you will get the marks. So each correct answer will get 3 points. In case of a tie, the marks of the prelim will be considered as tiebreaker. So may the best team win. So let's start. And yes, the decision of the quiz masters will be final, as always. So coming to round 1. So this will be a direct question to team A. A 60-year male with history of polyarthritis, skin lesions, interstitial pneumonia, presented with recent onset skin lesions on nail folds, and the dermoscopy of the skin lesions is seen. You can see here, these are the skin lesions we are talking about. So what is the name of this new onset lesions? So this is a direct question for the team A. This. Sir, someone has to tell. Next, pass. You have to tell pass also. Team B. You have to tell the name. C. D. So this is a very simple one. So I wanted the name of the lesion. So this is called bivatus lesion. This is a leukocytoclastic vasculitis. So I will not give for vasculitis. I wanted the name of the lesion. So it is no one gets any marks for this one. So next, this is the second question is for team B. So a 52-year male with painful subcutaneous nodules on elbow area. This is the FNAC image. The stain used is Lisman stain at 400x magnification. So what is your diagnosis? Direct question for team B. Sir, when 10 seconds are over, you have to tell. Okay, so that is the answer. So can you tell why there are 2 images? Okay, so this is a gouty tophi. So claps for the answer, please. So they have 10 points. Team B has got 10 points for the direct question. So this shows stacks of needle-like monosodium urate crystals. So next question, direct question for team C, 25-year male with fever, arthralgia, skin lesions. The skin lesions are shown, bilateral tender cervical lymphadenopathy. The lymph node biopsy showed necrosis with absence of staining for organisms, and CD68 was positive. So what is your diagnosis? Team D. Team A. Team B. Again, the correct answer by team B, so they will get 5 marks for this, as this was a past question. So this is called Kikuchi Fujimoto disease or histiocytic necrotizing lymphadenitis. So now comes the direct question for team D. A female presented with symmetrical proximal muscle weakness and tenderness, arthritis, Raynaud's phenomenon, fever, interstitial lung disease. The diagnosis is clear. So thick keratotic lesions were seen on the hands and feet. What is the type of antibody mostly associated with such lesions? These lesions. Louder, you have to be louder. माइक है वो Okay, again, the correct answer by team B. So this is called anti-synthetase syndrome. This is mechanic's hand. So anti-Jo antibody. 5 points for team B. So with that, we come to the end of round 1. So round 2. So this will be direct question to team B. So, so here you have to name the test. It is for team B. Your turn will come. I can deduct marks if you... yes, this is a very interesting one. It should good. So pass. You have to tell the search decision. Wrong, for wrong answer there will be, we'll listen from everyone. Then team C. So you tell your answers. Team for what? Team D? Team A? Sir will not give. Yes. So, no, so no one will ask you DIF at this level, no? So, immunofluorescence will not give you any marks. This is for MBBS level. Anything fluorescent is immunofluorescence, so we didn't ask this. Okay, so we'll move on. So, this is the direct question for team C. This person with uncle arthritis with erythema nodosum lesions, what is the investigation shown in the picture? You have to tell the name of the test. Team D. Okay, I will give it to team D. So 5 marks for team D. So with that, they have opened their account, I think. It will be if someone tries to, if it is not your chance and you are murmuring, then we'll cut marks. So be careful. Okay? So you use the the microphone and tell loudly. So can we have 2 more microphones? No? So you be louder. You pass it. This one for these 2 teams and that one would be passed. So use that. Okay? So if you are not audible to me, I may not give you marks. Okay? So we'll move on. So this will be a direct question to team D. What is the difference between acid-fast staining and modified AFB staining? Very simple one.
Percentage of sulfuric acid.
-5 for team A. You have to be attentive which team is being asked. It is written, in the top it is written, whichever is in the front.
Percentage of decolorizer used 20% sulfuric acid AFB staining, 5% in modified.
Okay, so we'll give it to them. It was a direct question for them, so 10 marks. So next is the direct question for team A. Okay. So intensely pruritic inflammatory papules and vesicles on the forearms, knees, scalp or buttocks. The histopathology shows subepidermal deposition of IgA, neutrophilic dermal infiltrate in the superficial dermis, which is the most specific autoantibody for this condition.
Anti-TTG?
Sir, your take. You tell again. Anti-TTG. We'll listen from all, sir. It is your take, your question. Okay, we'll give it to them. So 10 marks. So can you tell the diagnosis? TTG, you tell the full.
Tissue transglutaminase.
Okay. Okay, so what is the diagnosis here?
Dermatitis herpetiformis.
Okay. So which which type of uh, mm, antibody is positive here?
IgA.
Okay. Okay. So it is 10 marks for them. So I think we have come to the end of this round. So this is an audience question. So by the time the score will be added. So what is the meaning of lupus? Yes?
Wolf.
Yes, sir has answered it correctly. So it is wolf. So because it causes so much of scarring, so can we half the score by the end of 2 rounds? How much the, from least to the highest, sir?
So at the end of round 2, team A is on plus 10, team B is on plus 20, team C is yet to open their account, and team D is on plus 15.
So a round of applause. So there are still more rounds. So, I will ask sir to take over.
So what I think, as the rounds progress, difficulty will also become more. So this is a direct question to team C. There is a die which is used in the criteria, and that die has been classically described. Can you name the die? You can see the staining there. Time is up. Next. D. A.
Rose Bengal.
It is Rose Bengal. So nowadays, though people are using other stains, this has been the classical stain described. Now Lizamine or fluorescent stains are being recommended. The second question to team D, male child who has atopic dermatitis, but IgE, IgA are raised, but IgM is low. There is thrombocytopenia and the platelet size are very small.
Viscott-Ehlers syndrome.
Very good. This is Viscott-Ehlers syndrome. So 10 marks for team D. Then the third question to team A. What is this image being shown? Name the technique. There is something about rewarming, then putting on cold water. What do you call this technique? No guesses. Next.
Infrared thermography.
Sorry.
Infrared thermography.
Yes, that is the correct answer. 5 marks for team B. Now the direct question to team B. So this is infrared thermography. Direct question for you. This is a giant capillary. How do you define a giant capillary? What is its width vis-a-vis a normal capillary? When you call it a giant capillary, how big should it be?
10 times.
Very good. So that is the correct answer. Another 10 points for team B. Then coming to round number 4. The first question will go to team D. This is the ethyl ester of an active metabolite, which is from this monitor is not working. Several penicillinum species. It acts by inhibiting the type 2 isoform of IMP, dehydrogenase. It was FDA approved in 1995 for which disease? Maybe.
Azathioprine.
Drug, that is not the question. Next, A.
Rheumatoid arthritis.
B.
MMFO, that is.
Indication, first approved indication. D. It is mycophenolate and the indication was obviously for organ transplant. All these drugs are coming in malignancies or transplant first, then they will come to rheumatology. So the no marks for anyone. A will have this question, direct question to team A. Brown discoloration of skin, diabetes, arthritis, you can see in the X-ray, second and third metacarpal joints. 2 parts of the question are there. First part is likely diagnosis and second part non-invasive technique to clinch the diagnosis.
Hemochromatosis.
And non-invasive technique?
MRI.
Team B, you'll get 5 points. They will get 5 points.
Elastography.
No. No.
Ferritin levels. Ferritin levels.
Non-invasive. Ferritin you have to take out the blood. So there is a special test which is called as SQUID, superconducting quantum interference device. So 5 points for team A. Then the third question to team B. This is a synthetic analog of natural purine base. This is metabolized to 6-mercaptopurine. And this enzyme is deficient in Leach-Nyhan syndrome. What is this enzyme? Name the enzyme, not the drug.
Hypoxanthine guanyl phosphorybossyl transferase, HGPRT. HGPRT, hypoxanthine guanyl phosphorybossyl transferase enzyme.
Okay, correct. So another 10 points for them. So that brings us to the end of, there is a fourth question for team C, direct question. Which metabolite of dapsone is used for the, is responsible for the side effects?
Dapsone hydroxylamine.
Okay, correct answer. So 10 points to team C. So, audience question first, while the scorer can total the scores. Janus was the god of gatekeeper. Okay, that is the correct answer. So beginnings, gates, forward and back, starting and end. And January is named after Janus, obviously. Scores, please. So next round will be a little bit complicated. It is called nomination round. We'll ask the team who has the lowest score, they can nominate someone, including yourselves. This will be the last round. Correct answer will get you 20 points, but wrong answer will, or even if you can't answer, you will get minus 10 points. So C has the lowest score, so whom would you like to nominate for the first question? You want to increase your score or you want to decrease someone else's score? Yes, they can nominate themselves 5 times also. Yeah. Please hurry. Whom do you want to nominate? Nominate a team, A, B, C, D. Whoever answers correctly, 20, otherwise minus 10. If you have enemies, you...
Team A.
Huh?
Team A.
Team A. So you are their enemies. So first question. One book of the Bible is named after this person, and God gave him sores all over the body, took his wealth, took his children died, and there is an immunodeficiency syndrome named after him. Name the person or name the disease. Wrong. So they will get minus 10. And you can nominate someone else. This is Job syndrome. That person was Job, also known as hyper IgE syndrome. You can nominate someone else. C. So they are taking revenge. For C, this is a question. 30-year-old male. This type of gums, then nasal polyposis, then polyarthritis, and mononeuritis multiplex. Cryoglobulins, ANA, ANCA is negative. What is the most likely diagnosis? So for first question, they get minus 10.
Microscopic polyangiitis.
Okay, I'll give you that. It may, basically this is ANCA vasculitis. So 10 to 15% of ANCA vasculitis may be ANCA negative also. So this is ANCA negative, ANCA associated vasculitis. So 20 points for them. So whom do you want to nominate? Huh? Team B. So for Team B, this is the question. You can see someone with a big tongue and shoulder pad sign. And you know this is amyloidosis, but tell me which type of amyloidosis?
Primary systemic amyloidosis associated with multiple myeloma. मतलब myeloma associated. Primary systemic.
What type of amyloid you get here?
Amyloid light chain. Amyloid
Light chain.
light chain.
That is the correct answer. They get 20 points. Whom would you like to nominate for the last question?
Team C.
Okay, so third time for Team C. See the hand. It is deformed. There are some nodules, erythematous. The biopsy shows CD68 positive cells. This was discussed today morning also, I think. And what is the diagnosis? No answer is minus 10.
Sir,
Wrong answer is also minus 10.
Tendon xanthoma hypercholesterolemia.
Hypercholesterolemia will not cause deforming arthritis. And why would you get CD68 positive cells? The correct answer is multicentric reticulohistiocytosis. So minus 10. So with that, we would like to end. I would ask the scorer for the final scores and the winners. Ranjan sir can please come up to the stage and announce.
So after all the 5 rounds, at third position we have Team C with plus 20 points. At second position we have Team D with plus 25 points. And the winner for the quiz is Team B with plus 65 points.
So AIMS Bhubaneswar got the first prize. So now we'll come to the last of the prize distribution ceremony. So first we want to felicitate the quiz masters. Oh sorry, quiz participants. You can stand here or you can go down. I will call on. Please, Dr. Sakir and Dr. Arpita, please come. You have done a wonderful job. Lovely questions. Now, Dr. Anjan Gupta, please come to distribute the prizes. Prizes of oral and poster presentations. Oh, sorry. First, the quiz.
Quiz masters को बुलाओ.
Please bring the results. Please. Call
the quiz
ये
masters.
किसका है? Quiz. So I think the quiz masters can join us in distributing the prizes. This is Dr. Shreya K. from AIMS and Dr. Sonika Garg from AIMS. And they have given, what is this cash prize, Amazon cash prize of 5,000 rupees. The next, second, Dr. Priyanka and Dr. Priyansh. They are from Dehradun. So they are from Dehradun, Dr. Priyansh and Dr. Again names Bhubaneswar. Dr. Hemeswar Agasti and Dr. Vivekanand Mahapatra. You are from? SCB. All within the Now it's for oral paper.
Quiz?
Dr. Sudhir, please come. Please come.